Good afternoon everyone. First of all, a very happy World Optometry Day to all my colleagues, friends and professionals joining us from across the globe. On behalf of United Optometrist Forum, I warmly welcome you to Myopia Conclave 2.0, proudly hosted from Dubai here on this innovative 3D Metaverse platform. I also sincerely hope that everyone in our Gulf region and beyond is safe and doing well during this current situation. Today is truly special with 2000 plus registered attendees and speakers joining from more than 40 plus countries. This has become one of the largest online myopia focused events ever organized, a true global step towards combating the growing myopia epidemic. I am also happy to share that this event is accredited by Dubai Health Authority with 7 CME points and attendance certificate will be issued within 21 working days. To eligible, please ensure you attend at least 60 minutes of the session and participate in the polls as required by DHA guidelines. A heartfelt thank you to all our sponsors and partners. This event would not have been possible without your generous support. Since we are meeting inside this 3D Metaverse experience, I encourage everyone to explore the environment. You can visit the virtual booths, chat or connect via one-to-one video call with our partners, roam around the space to learn about their products, and also visit the virtual selfie booth to add your photo to the photo wall and share it on social media. And if you need a quick break, feel free to step into the game zone to refresh your minds. But before we proceed further, as a mark of our respect and gratitude to this great host nation, the United Arab Emirates, I kindly request everyone to take a moment to honor the country that is proudly hosting this global gathering from Dubai today. May I request all the participants to please stand virtually as we play the national anthem of United Arab Emirates. Thank you team. With the inspiring notes of the UAE national anthem setting the tone for today's distinguished gathering, we now move into the opening segment of this prestigious global event Myopia Conclave 2.0. It is my great honor and privilege to invite our distinguished chief guest to deliver the opening address. None other than Dr. Rajiv Prasad, President-elect World Council of Optometry, President of Asia Pacific Council of Optometry, Secretary General Indian Optometric Association, Founder and Director of Visual Eyes India, and Founder iGurukul. So, ladies and gentlemen, please join me in warmly welcoming Dr. Rajiv Prasad for the opening address. Over to you, sir.
Good afternoon, everyone. Respected dignitaries, distinguished speakers, members of United Optometry Forum, and dear colleagues. It is truly a privilege and honor to be here today at Myopia Conclave 2.0. I would like to begin by expressing my sincere gratitude to United Optometry Forum for inviting me and organizing such an exceptional scientific gathering. Platforms like this are not just conferences, they are catalysts for change in how we approach vision care globally. Today we are united by a common purpose, addressing myopia, which is no longer just a refractive error but a rapidly escalating global public health concern, with projections suggesting that nearly half of the world's population may be myopic by 2050 and a significant proportion is at high risk of myopia. We are looking for a future at where vision-threatening complications could become far more common than we have experienced before. This makes our role just more important and critical. What makes this conclave truly special is the extraordinary panel of experts gathered here. It is inspiring to see some of the world's leading researchers, thought leaders, and myopia under one roof. I'm especially delighted to see the past president of IAOMC, Marino Fomenti, whose immense contributions have significantly shaped modern myopia practice globally. It is also wonderful to see dear friends and highly respected experts like Jagrat Lalu, Mark Bulimo, and Dr. Ramesh Kanupaya, along with many other distinguished faculty who continues to push the boundaries of research, clinical excellence, and innovation in the field. Your presence here reflects the depth, credibility, and global relevance of this conclave. At the same time, I would like to bring attention to a growing concern that we cannot afford to overlook. We are living in the era defined by rapid digital transformation and the rise of artificial intelligence, where these advances are revolutionizing and education and connectivity. They are also significantly increasing near work children. Early and prolonged exposure devices, reduced outdoor activities, and changing lifestyle patterns are creating some of these early onset and rapid progression of myopia. This is not just a clinical observation, it is a reality supported by global research acknowledged by organizations such as WHO. As clinicians, we must recognize that the future of myopia lies in proactive management rather than passive correction. The time has to come move beyond prescribing glasses and start taking responsibility for controlling the progression. This means early risk assessment, consistent monitoring, and timely intervention uses evidence-based strategies such as optical solution, pharma, and lifestyle modification. It is also about educating parents, engaging schools, and building awareness at the community level. Global organizations such as World Health Organization and World Council of Optometry have clearly emphasized that myopia management must be integrated into standard clinical care rather than being treated as an optional or niche services. The WCO, through its Myopia Management Standard of Care initiative and global advocacy, has outlined a structured approach centered on mitigation, measurement, and management, while also working on ambassadors and global experts to drive awareness and implementation across countries. These initiatives provide clinicians worldwide a unified direction towards evidence-based myopia care. Equally important is the need of collaboration. The complexity of myopia today demands that we work together, clinicians, researchers, industry, and educators. No single practitioner or system can address the challenge alone. Collaboration with specialty centers, integration of the care, and as AI continues to integrate into education and daily life, we must acknowledge its impact. Greater skin dependency, reduced physical interaction, and increased accommodative stress, which, if not balanced, can accelerate myopia progression and increase the long-term risks. As clinicians and leaders in eye care, we must recognize that this is not a challenge we ignore or delay. The question is not whether technology will evolve, or it certainly will. The question is whether, as we profession, will evolve alongside with responsibility and foresight. This includes establishing clear clinical and public health guidelines that promote digital hygiene, structured screen time, regular visual breaks as 20-20-20 rule, and conscious effort to increase outdoor exposure at least 90 to 120 minutes per day. From a clinical standpoint, early risk assessment must become routine, especially in digital exposed children, with timely initiation of myopia control strategies as and when indicated based on condition. The way forward is clear. We must align ourselves with global standard, adopt structured myopia management protocols, and ensure that every child we see is not give just clarity of vision, but a chance for a healthier visual comfort. In today's world, the challenge is not technology itself, but how we adopt it. If we act early, act wisely, and act together, we can ensure that benefits of the digital and AI revolution do not come at a cost of our children's vision. Let this conclave serve as a reminder and a call to action that protecting vision is the modern era requirement, not just the knowledge but leadership, collaboration and the commitment as well. Once again, I would like to extend my heartfelt thanks to UOF for this wonderful initiative and for bringing together such an outstanding panel of global experts. I am confident that the discussion over the course of this conclave will inspire each of us to elevate our practice, contribute meaningfully towards tackling the myopia epidemic. Let us work together to ensure that next generation does not just see clearly, but live free from preventable vision loss. At last, thank you. I really wish Myopia Conclave 2.0 a grand success. Thank you all. Enjoy the Knowledge Fest and have a great day ahead. Thank you so much.
Thank you, Dr. Rajiv Prasad, for that truly inspiring opening address. And now, we begin our journey at Myopia Conclave 2.0, the world's largest online myopia event today. Let's make this evening of learning impactful and memorable. Now I hand over to Sana Merchant to begin the scientific sessions. Over to you, Sana.
Good afternoon, everyone. Happy World Optometry Day to each and every one of you. I am Sana Merchant, a core committee member of United Optometrist Forum. On behalf of everyone, once again, I wish you a very happy World Optometry Day. Let's begin our first session for the Myopia Conclave 2, which is on how to determine and manage myopia development and progression. And for this, I would like to call our speakers for this session. Our first speaker for this session is Dr. Gareth Lingham from Australia, and he shall take us through measuring myopia risk factors in the clinic. Over to you, Dr. Gareth.
Thank you for that introduction. Just get my slides up. Hope that's okay. So I'm going to talk about, thank you again for the kind introduction, and good afternoon, good morning, good evening, wherever in the world you are. I'm going to talk about measuring myopia risk factors in the clinic. And Carla's going to talk a bit about risk calculators for myopia progression. So I'm going to stick to risk factors for myopia onset. But I just want to point out that sometimes these risk factors tend to overlap, but sometimes the evidence for whether they are a risk factor for myopia progression is stronger than it is for myopia onset, or vice versa. I'm not going to talk about age and sex because we so routinely collect that in clinics, and focus on some of the other risk factors that I've listed there. So education, this is pretty well known to correlate with prevalence of myopia, and it's much easier in adults where you can ask what's your highest educational attainment as a measure of their education or their length of exposure to education systems. But in school children who are typically assessing, they've usually had the same exposure to education in terms of for their age, so you get an exact correlation with their age. One thing you can measure instead of their length of exposure to the education system is their exposure to the educational intensity that they've been exposed to. But this is not really a well-defined concept in myopia research at the moment. One proxy that I think is quite useful is asking about after-school classes, and there's been a couple of studies that have investigated this. One study published by Carla showed that those adults who attended after-school classes during childhood had an earlier age of onset of myopia. And then there's a well-run Taiwanese study there that showed a 12% increase in the risk of incident myopia for children who attended more than 5 hours of after-school classes per week. So I think that's a useful question to ask when children are still going through that school system. Family history, I'm not going to talk about monogenic myopia, so I'm talking about our typical polygenic myopia that we see coming through the clinics. And it's usually assessed through the number of myopic parents. And you can see in this graph here that the more myopic parents you have, the greater your risk of myopia as a child. And it is harder to see, but those bars for having 2 myopic parents are usually about twice the height of the bar for having no myopic parents. We looked at this in the Australian RAIN study Generation 2 study, which is at young adults, but we actually found that myopia prevalence in those without a parent with myopia was 22%. It increased to 33% if you had one myopic parent, and 44% if you had 2. So exactly double the risk of myopia if you had 2 myopic parents versus none. A little curiosity, but we actually also found that there was a greater than chance probability that you would have 2 myopic parents if one of them was myopic. And that's probably explained that parents that meet each other in university where they're exposed to the same risk factors for myopia. And so there's a greater than chance probability that you'll either have 2 parents with myopia or 2 parents without myopia. So how do you determine if a parent's myopic? Well, if they're wearing glasses, it's very easy. You can measure their glasses with a photometer or a lensometer, or you can look for the prismatic effects from convex and concave lenses. But they've often had past refractive surgery or are wearing contact lenses, and you do need to ask because they don't always volunteer this sort of information. In that case, you have to ask them. And there's been some research on the best questions that will be able to detect myopia in adults. And these are the best 2 you can use in combination. So the first question is, for what reason did you first need glasses or contact lenses? Was it for far away or close up? And the second question was, how old were you when you first started wearing glasses? And so if you're between 5 and 30 when you first started wearing glasses, then it's likely myopia. If you're younger or older, then it's more likely hyperopia, astigmatism, or presbyopia. It's quite a good area under the curve for detecting myopia of 0.93 in that study. Now, I get asked about ethnicity, race, and ancestry quite a bit. And so, yes, these are risk factors for myopia prevalence. In the Sydney Myopia study, children with East or South Asians ethnicity had a higher prevalence of myopia. In the multi-ethnic study in atherosclerosis, these are American adults. Chinese adults were at higher risk, had a higher prevalence of myopia compared to white, black, and Hispanic. I want to point out at this point, though, that these are probably proxy measures in some ways of other risk factors. So that these cultural behaviors or emphases translate into behaviors that also increase your risk. There may be a small genetic component to that. I do want to the main point I want to get across is that ethnicity, race, and ancestry are very complicated variables to measure. So, for example, we think of someone who's from China as Chinese maybe, but within China, there's many different ethnic and language groups that exist, and so that person may not identify necessarily as Chinese. And we do use these terms sort of interchangeably, but they are different, and there are defined definitions for each of race, ethnicity, and ancestry. We probably use ethnicity and ancestry more often. So ethnicity is a group that person identifies as a part of, a cultural group, and so it's self-reported. So it's really important that person tells you what their ethnicity is rather than you assigning it. And ancestry tends to be used in genetic studies, and it's sort of a genetic descent measure. This can be convenient and simpler, but it also can be more complicated, particularly in terms of children of mixed ancestry. If you're going to measure these, my suggestion is to ask for patients to self-report this sort of information and to really recognise the context that you're asking in, so your community and the multicultural components of that community, and the sensitivity of that sort of question. You may even not want to ask this question and focus on some probably more direct measures of risk factors for myopia. One slide on polygenic risk scores. This is not here yet, but I think it might come in the future. And so this is a DNA test to look at your polygenic score, your polygenic risk of myopia. So this is adding up thousands of different variations in your DNA to determine a risk score. And they do work in terms of stratifying people at high risk of high myopia. And this is data from the UK Biobank. But you do need a service to be in place for you to be able to do this. And one of the real barriers to using a polygenic risk score at the moment is that they tend to be, performance tends to vary by ancestry. So this polygenic risk score is derived from European data, so it works quite well for Europeans, but not for Africans or East Asians or South Asians. So that's a real problem at the moment. And also returns a percentile score, which can be hard to use, implement, or interpret. Now, we all think about outdoor time and year work, and these are really important risk factors because they are modifiable. It's important to note that when you ask about how much time a person spends outside, they tend to overestimate, and that's pretty well described, that if you actually measure their outdoor time, it tends to be lower than what they report. Despite this, you do actually get a reasonable ranking. So you can rank people from lowest amount of time outside to the most amount of time outside, and that can be useful. People also do slightly underestimate the amount of near work they do. If you're going to ask this question, again, which is definitely worthwhile, I encourage you to ask this in your clinic. I think it's easiest and to categorize or dichotomize the response. So pick a threshold that is meaningful to you and ask, do you spend less than or more than this amount of time outside or near work? There are light meters that are available. I don't think they're being clinically used yet. They're more accurate, but there are questions around cost models. They generate a lot of data that you then need to interpret or look through reports that are interpreted for you or generated for you. And which patients you're going to use this on is another question. So my final one, cycloplegic spherical equivalent refraction. This is your baseline refractive error, and this is really, really important. So there's going to be talk about premyopia later, but the closer a child is to the threshold for myopia, the higher their risk of instant myopia, and it dramatically decreases the further they are from that threshold. This is found in the Sydney Myopia study and the CLEAR study on the right, which showed that it's both age and refractive error, baseline refractive error dependent. So again, it must be cycloplegic. And actually, the CLEAR study found that if you use just age and baseline refractive error, those are the two most important variables for assessing myopia risk, and none of the other variables significantly improved the prediction of whether a person was going to become myopic or not. If we look at the Sydney Myopia study, they found exactly the same thing on that right-hand graph. That's the 12 to 13-year-olds. You can see that baseline SER, which is just a solid line, does exactly the same as adding baseline SER plus ethnicity, time outdoors, or both. And so with these graphs, you're looking for the line to go towards the top left corner. That indicates improved performance. For the 6 to 7-year-olds, it did improve a little bit by adding in other risk factors, but by and large, baseline SER described a lot of the risk for incident myopia in that group. And this makes sense because your baseline refractive error is a result of all your environmental and genetic risk factor exposures up until that age. And so if you're exposed to myopogenic environments or genetics, they're going to be pushing you towards myopia from an early age. And so when you measure their refractive error, it's going to be nearer to the myopia threshold than if they weren't exposed to those risk factors. And so in some ways, this is the risk factor to look at if you're worried about risk of incident myopia in a child, because it, to some extent, measures other risk factors that I've talked about. So the take-homes, education, I think asking about after-school classes is a useful and maybe the most relevant question if you're looking to differentiate the effects of education within a particular age. Ethnicity, race, and ancestry are tricky to measure and complicated variables, but use self-reported data if you're going to measure it. Two parents in myopia approximately doubles the risk. We know recall of outdoor time and near work can be inaccurate, but they do tend to rank people accordingly. So I definitely think they have use. And cycloplegic sphere equivalent is the best measure, or one of the most important measures for assessing risk of myopia onset. Thank you. I look forward to taking some questions at the end.
Thank you, Dr. Gareth Lingham, for that insightful talk on measuring myopia risk factors in clinical practice. Now we move on to the second speaker of this session. It's a pleasure to welcome Dr. Lorraine Rose from Australia. Her topic, Understanding Myopia Rebound, Evidence, Predictors, and Prevention. Thank you, Dr. Gareth Lingham, for that insightful talk on measuring myopia risk factors in clinical practice. Now we move on to the second speaker of this session. It's a pleasure to welcome Dr. Lorraine Rose from Australia. Her topic, Understanding Myopia Rebound, Evidence, Predictors, and Prevention.
Hello, and thank you for the invitation. This is quite exciting. So I will be sharing my thoughts on rebound, understanding evidence, predictors, and prevention, as was just said. So I'm going to start by some basics here. I want to start by some definitions so that we're all talking about the same thing. So rebound is an increase in the growth of the eye that occurs when we discontinue some of the interventions that we use. And specifically, it's atropine, ortho-K, and repetitive low-level red light. True rebound is really that you've stopped the treatment and your patient group now is progressing faster than the control group that is aged and ethnicity matched. So it's not just that you've stopped the treatment and you've gone fast again, you're going faster than the control group, faster than the age appropriate number. So it's truly a loss of treatment that you've actually been benefiting from. So to ensure long-term results, we really need to be thinking how long we need to treat. And we know from growth curves that can be quite long. And we also need to know that these interventions have got different rates of rebound. So looking at the evidence then, peripheral defocused glasses have been studied and there's multiple publications. There doesn't seem to be any significant rebound with either the DIMS or the HAL lenses. Dual focus contact lenses also seem to not have a significant amount of rebound. So they seem to have a different effect once we stop the treatment, and that's reassuring. But atropine's a different story, and basically the early atom studies found rebound quite early on. Later, the LAMP studies showed us some different levels of rebound, different doses, and I think we're all kind of understanding that there is very much a dose response effect with atropine, where you have more rebound the stronger the dose or the stronger the concentration. And you can see in this LAMP study quite clearly, the blue is the higher dose, 0.05%. The red is a 0.01%. So you can see that, you have different effects. But then on the third year, where they had the washout year, is where you see the rebound, where you stop the treatment and you can see this blip going up on that third year, quite a steep rise, and obviously more for the higher dose than the lower dose. So it's been quite clearly shown for atropine in these studies. And really the effect of this has been shown really well in 2024 with the Atlas study from Singapore, which had the follow-up of the Atom 1 and Atom 2 group. So 17% of Atom 1 and 40% of Atom 2 both have been followed up for about 10 to 20 years. And really the disappointing result from this study was that the refraction and axial length was no different between the treatment group and the control group. In other words, the benefits we saw early on in these studies had been lost over time once rebound had come on top. And so it is really important that we follow this up. It was reassuring that this study showed there was no long-term effects, but the treatment was only 2 to 4 years long. So there was no long-term effects that were detrimental, such as cataract or glaucoma, but really there was no benefit, which is actually really quite disappointing. The study also showed that the greater rebound was the younger patients and the higher dose treatment. So again, it shows that dose concentration is really important with atropine. A recent study looked at this quite nicely and tried to sort of look at what the 12-month rebound rate would be with different doses of atropine. You can see again that concentration dose increase when you're dealing with 0.5. You can have a rebound of 0.3 millimeters or almost a diopter, which is really negating your treatment at least a year, probably much longer than that. So the speed up can be quite detrimental to the final outcome. Evidence for orthokeratology is a little bit more varied, I'm going to say. There's data saying that definitely most publications say there is rebound, but the data is mostly for under 14-year-olds. The data also has quite short washout periods, so the actual true effect of rebound is a little bit unknown. The most current publications show quite a varied rate of 0.3 millimeters in a year period. compared to 0.1 in millimeters in a month. So you can see that that value is not really standardized, and probably more research needs to be done here. The newest intervention to red light therapy, to myopia is red light therapy, and this shows the greatest amount of rebound. There's not a lot of studies here because it's not been available or tested for very long, but it does seem to couple efficiency of myopia control, that is good effect for myopia control, and then high amount of rebound when you stop that treatment. A couple of studies have shown one a 3-month period of rebound of 0.16 millimeters, and another one's showing a 0.4 millimeter per year. These numbers don't even closely equate to each other, so clearly we need more studies to know what the true rate is and whether it's dependent on age, etc. So there are many questions still, but there's no doubt that rebound is there. My colleague who's talking, I think, in a couple more talks, Mark Bullimore, has this lovely, good representation of how rebound can impact the growth once it's stopped, and just looking at that efficiency of myopia control versus a rebound after if we don't watch it. So soft contact lenses and spectacle, pretty much no rebound. Atropine, you can see the different doses, and as you increase the dose, you get more rebound, and ortho-K and red light therapy being the highest level of rebound in this graph or analysis. So what are the predictors? Well, most studies that look into rebound do point at age. We expect rebound to be greater at a younger age. And again, dose is very clearly related. So the higher the dose of atropine specifically. There are other, I'm going to say, softer predictors, but I do think they're helpful in our clinical practice. Family history, for example, if there's a family history of high myopia, especially very progressive myopia well into the teens, well, that's probably not going to follow the trend that we expect with those growth curves. And you know, we expect some genetics there and maybe some environmental confounders. So if there's a strong family history of strong progression or high myopia, that might be a predictor for this rebound to be of concern. I use axial length a lot. There is a little bit of a contentious issue that when we measure something that it might be a blip on it being fast and it's a regression to the mean on the next measurement. But I like to look at a trend over a long period of time. My patients are followed routinely with axial length every 6 months. So I hope that I see a trend where the natural slowing down of the eye occurs and we can sort of consider stopping treatment in a more safe way. So that's helpful. And again, that environmental confounders are really important. I mean, I don't really think it's a good idea to consider stopping treatment when a child's about to embark their final year exams. And you know they're going to be indoors and doing a lot of near work. Although it is important to explain and try and encourage them outside, sometimes their lifestyle is quite clearly not going to be the best in the next 6 months. That might not be a best time to consider stopping treatment. And what we're trying to do is prevent that rebound from negating that that effort we've gone to all these years to control this myopia progression. So I review 6 monthly, as I said, and specifically we're talking about reviewing post-treatment cessation or weaning. We want to know that we're actually not getting significant rebound because we can at least act on it. I've had patients referred and have had rebound for a few years without their knowledge, and you know, you can't wind the clock back for those patients. I do think it is important to review those predictors along the way. So you have a plan of action. You are speaking to the families about what your intentions are. And so, for example, a young patient, you really want to control their myopia and not consider getting them off the treatment too early. And again, poor outdoor and high near work exposures are the risk factors. So if we're under that environment, then we need to consider continuing treatment for longer. So what is best practice? Well, a lot of people consider weaning is the better way to go. Cessation is not considered a good idea. I do this a little bit, but I do it over a long period of monitoring a trend. The other way we can think about it is transition. We can go from one treatment to another. And another way is to combine. So in other words, you might start peripheral defocus lenses, look for a little while before you start weaning or ceasing atropine as a way of controlling or ensuring that rebound is under control. And when do you wean? Well, the most recent publication was talking about normal growth patterns, and as you get older we expect slower growth, so using that as a baseline to decide that's a good time to start weaning, and not stopping treatment under for a 10-year-old or under, because we expect that that will cause rebound. This is yet to be tried or proven. These are just guidelines to consider, and I think that they're important processes we need to go through when we're stopping our treatment as our child gets older. So what is best practice? I'm not here to tell you. As I've said, there's still a lot of research that needs to be done. But one of the ways to look at this is we can wean the dose, or we can wean the frequency, or we can do both. So atropine concentration, if you're in a high concentration, you can reduce it over a 3-month period. And then you can reduce the frequency. Instead of nightly, you do it every second night. Again, no good studies to tell you this is the way to go, but if you're monitoring, at least you know that what is the result of your practice. And red light therapy, similarly, it's twice a day, so you can reduce the frequency initially to once a day, and then consider reducing the frequency of how many days a week you expose the red light, you're exposed to the red light. And that is one way of looking at it as well. And so this is not meant to be an absolute guideline, but more of a food for thought. And thank you for your attention. I look forward to some questions and discussion at the end.
Thank you, Dr. Lauren. Our next speaker for this session is Dr. Carla Lanka from Portugal, and she shall take us through predicting myopia progression. How useful are risk calculators in clinical practices? Over to you, Dr. Carla.
Thank you for the introduction. So today I'm going to talk about predicting myopia progression. Thank you for the two speakers. I think Dr. Lauren Rose already helped me explaining some of the difficulties we have when we are seeing patients and we have to at least predict the risk of their progression. So let's talk about that in a while. So those are my conflict of interest. And as we know, we are trying to address a growing myopia challenge with projected or expected to have around 50% of the population myopic by 2050, and high myopia is expected to reach around 10% of the population. So as you can see here from this imaging that I have here, I'm showing an example of the Brian Holden Vision Institute. This is just an example of the calculators. Nowadays, we have a lot of them. Some of them have been incorporated in biometers. So some of you in your clinical practice are already having access to some of those measures. So what do the calculators do? So they help us to identify high-risk children. And of course, having access to these prediction models, it's important to help us to decide what to do. So over here, we are seeing a Caucasian child with 6 years old. She's a female, and the refractive error at the moment is minus 0.5 diopters. So you can see the expected progression based on this calculator on the red color. You can also see what can we save in terms of progression if we use a treatment. In this case, I selected atropine, but the calculator allows you to select other options. The question is to know how accurate are those calculators. We can also, sometimes we also need to predict not only myopia progression, but also when we see a patient, if there is a risk of onset or a risk of developing myopia. That's also important for us to decide if we need to treat or if we need to wait and monitor the child. For example, here you can see another calculator. This one is predicting the risk of myopia in an Asian child, this one with 6 years old, a female, and with the hyperopic refractive error 2.5. So as you can see here, the risk is low. There's no parents with myopia. But of course, the calculators also also help us to determine the treatment intensity and how we should do our monitoring of follow-up intervals. But one of the things that I think the calculators are most important is also in counseling parents and even the child, especially when they are older and they understand what we are showing it to them. So there are many types of myopia prediction tools, such as percentile charts. There are also the axial length growth curves, regression-based models, and most recently, there's also machine learning models that help us to visualize the progression. So over here, in this image, we are seeing another calculator, this one showing AL, in an Asian child with 8 years old, a male, and the refractive error already myopic, -1, and AL 21 millimeters. So again, we can see how much this child is expected to elongate up to the age of 17 years. And for example, if you use orthokeratology as a treatment, you can see how much we can save in terms of progression. The question is, as I said before, and Dr. Lauren Rose already talked about the regression to the mean, but also how valid are those calculators? So we don't have access at the moment to a lot of studies working on the validation of these calculators, but I found this one from the Hong Kong children. So what the authors did was to compare myopia progression of children aged 7 to 13 years. And looking at those children, they compared the progression with the calculator. So they found that 36% progress within the 95 confidence intervals of the calculator estimate, which is good. But they also found that 33% became less myopic than predicted, and 31% become more myopic. So as you can see, almost 64% of children were not within what we would expect from the calculator. In another study, the authors used modern machine learning-based algorithms to try to understand what was the best way of predicting progression. So in this case, the authors found that the best algorithm included age, included sphere, but also sex as inputs. And they compared their performance with two calculators, the myopia calculator and the myopia. And they found that their algorithm had a little bit or slightly better performance with the myopia compared with the Brian Holden Vision Institute, which had similar performance. Nevertheless, they concluded something that is important for us in clinical practice, is that the growth curves and this predicting algorithm, they are important for us to understand or to have a reference of a child within a population. However, they must not be used in isolation. So they are a reference, so they should not be a unique tool for risk assessment. So let's go to the percentile curves concept again. As you can see here, I'm showing curves for sex, for females and males. So these curves are from the group in the Netherlands. So they show the AL growth and the risk of developing myopia in European children. So as you can see, this is like pediatric eye growth charts. They track the growth relative to population reference, and they are used to detect any abnormal growth trajectories. So they can be based for this in AL, but they can also show refractive error. So this group in the Netherlands, very interesting because based on their practice in myopia management, they use the chart and they have thresholds. For example, when they found that they have a child in an AL that is in the 75 percentile or above, they increase the intensity of treatment. In this example, they say that they go for higher atropine dose, such as 0.5. And of course, if there is complaints, they use multifocal photochromatic glasses with an addition of 3 diopters. and they do measures of refractive error and AL every 6 months. So based on the results of the chart, they change atropine concentration, either increasing or diminishing depending on the progression. Nevertheless, there are several publications now emerging looking at the centile charts and also saying that because they include the growth from myopes but also emmetropes, they may not be the best ways of monitoring the growth. So for example, in this paper from Noel Brennan and Mark Bollimore, the authors say that annualized growth rates are more informative. And I've drawn some of the data that is presenting in this paper for East Asian ethnicity and non-Asian. And here you can see that the curves are only for myopic children. So this would be the expected growth in myopic children. And similarly, we can also plot the same for emmetropic children. Another very recent study from Jos Rosema also show evidence from the young childhood high study. So they looked into the percentiles again, but this time they call it the corrected percentile curves. So based on the same thought, what the authors found was that if we use the population-wide curves, we may underestimate myopia risk. So in this study, they plot separate curves for emmetropic and also for myopizing eyes. So this improves the detection of myopic growth. We are also working in our calculator for Middle East. We are looking into data from the Sharon eye children. And again, we have challenges, especially when we are looking to Middle East data, where we have prevalence of myopia, which is lower than Asia, and also lower progression. And of course, Asian cohorts or models cannot be generalized to our cohort. And we are working on local validation as well. So what would be the future of tracking myopia progressions of the calculator? So as Garrett showed, we would like to have monitoring of in lifestyle, for example, NEO work, objective monitor of outdoor time, and we can input that data to the calculators. Also genetics, of course, to have individualized predictors. We also would like to have, based on this risk, identify non-responses, and based on that also to choose the best treatment and customize the treatment to improve effectiveness. It's one of the things that also would be very important for us to have is to identify the risk of developing MMD, myopic macular disease, not only progression, but to know which child is going to develop the disease and how we can predict this long term, and also select a treatment or a tool that would prevent the development of severe disease. So real-time feedback would be something that maybe in future we can have with digital health tools and help us to adjust our intervention. So thank you so much for your attention, and we will open later the discussion for questions.
Thank you, Dr. Carla Lanka, for that insightful talk on predicting myopia progression and for the practical guidance on using risk calculators in clinical practice. Now, let us move to our next speaker of the evening, Dr. Mark Bollimore from the United States of America. Over to you, Doctor.
Good morning, everybody. Can you hear me okay?
Yes, yes.
Okay, I apologize. Well, greetings from Colorado. The weather's not quite as bad as it looks behind me. It's 4:52 in the morning. So I'm going to talk to you briefly about the IMI, or the International Myopia Institute report on interventions for controlling myopia onset and progression. Before I begin, I have some disclosures to tell you about. I make my living working with companies large and small, and many of these, of course, have an interest in the area of myopia. So the interventions paper I'm really going to cover this morning was published in Investigative Ophthalmology and Vision Science last year. As I said, it's early here. This QR code will take you there, but it's also very easy to find it on the web. So the main results of this review are shown on the right, where we display different interventions and show their relative efficacy from different studies. This is the outline for the paper, of course. We go into other things beyond different interventions. So before we begin, let me just remind you how we describe efficacy in this paper. So obviously we can monitor myopia progression two ways, with axial length and refractive error, and the same applies for efficacy and myopia control. In terms of the two, we focused in the review paper on axial length, in part because its measurement is much more precise or repeatable than refractive error. And also, there are some interventions, notably overnight orthokeratology, where we cannot monitor efficacy using refractive error. In terms of how we define efficacy, there are a number of options, which I've detailed on the right there. But again, the one that we focus on is the absolute reduction in axial elongation, or indeed refractive error. We tend to focus on this because it tends to be fairly robust across studies. And you can also see that from this review paper that the efficacy is not the same in years 1 and years 2. The efficacy always, regardless of intervention, seems to be higher in year 1 than in subsequent years. In fact, the efficacy when we look at year 1. The advantage of using absolute values is it seems to be relatively unaffected by age. So if you look at the data here, I'm showing data from the LAMP study on the left and a red light therapy study on the right, and the lines compare the axial elongation in treated and untreated children, or control group children. And you can see those lines are virtually parallel. So the absolute reduction in axial elongation is unaffected by age in these two studies. The problem is when you start using percentages, it varies tremendously with age. So you get very high efficacy in terms of percentage treatment effect in older children, and disappointingly low treatment effects in younger children. So going back to the paper and looking at different interventions, let's start with myopia management spectacles. We don't show progressive addition lenses here because they are so very limited efficacy. The options available to a practitioner depends on where they are in the world, but it's quite clear from this graph that when we reviewed the literature, the two lenses were the most effective. But obviously, since we published this study, there have been other papers published. In terms of soft contact lenses, there are some studies with 3 years duration. And fortunately, two of the lenses that have been evaluated for 3 years, the dual focus lenses and also the high-ad multifocal, are the most effective. In terms of orthokeratology, you may note that the data are more closely bunched here. The orthokeratology trials seem to be more consistent than others because the design tends to be more consistent. You will also notice, if you look closely, is that the orthokeratology is less effective in eyes with lower myopia. In terms of 0.01% atropine, there's a remarkable 21 randomized clinical trials. And again, there have been more published since this chart was constructed. The median 2-year efficacy when available is 0.12 millimeters, which is about half or more, or half or less what you observe with some of the best optical interventions. You can, of course, get better efficacy with higher concentrations of atropine, but particularly as we found in the ATOM study, the rebound was very pronounced with 1% atropine, although of course that may be due to it being a unilateral intervention. Red light therapy. This is clearly, based on the data, the most effective of interventions, but there are legitimate and serious concerns about the safety given the light levels involved and shining coherent laser light into a young myopic eye. As also, as Lauren mentioned earlier in the session, there is much greater rebound than you see with optical interventions. So that's the global picture of what these different interventions provide. The question I often get asked is which treatment is best? My answer is always the same, regardless of who's paying me to speak. It's the one that the child will use. And really, when it comes to myopia control, the key is here compliance. If a child is not going to use the treatment, they're not going to derive any benefit. The other topics that are discussed in our review paper include modifying and monitoring behavior. We review some of the behavioral approaches to myopia control and the growing use of smart devices for monitoring risk and also compliance. We review the interventions to delay myopia onset. This is, of course, important because, as Benjamin Franklin once said, an ounce of prevention is worth a pound of cure, and we quantify this on the paper on the right. There are clear evidence that outdoor activity can affect the onset of myopia, but 0.05% atropine and also optical interventions like the Howell lens can also reduce the incidence of myopia. Finally, in the paper, we talk about the surgical management of high myopia. These surgeries aren't for the faint of heart, but we review posterior scleral reinforcement and macular buckling surgery. These are, of course, reserved for the more severe cases of myopia. In the discussion, we cover a number of areas like safety, rebound, and the future, and of course the gaps in knowledge and future directions. As Lauren already presented, rebound seems to be non-existent with our optical interventions and indeed low concentrations of atropine, but it can be very pronounced at higher concentrations of atropine and of course red light therapy. So I want to thank you for your attention. I'm easy to find in the interwebs and the metaverses, but you can find me at my website or my email address there. And thanks for the opportunity to participate. Stop screen sharing.
Thank
It's
you.
like Gareth in the dark.
Yeah.
There he is.
Thank you to
He's
all
got
the
a big head
speakers.
to me.
Yes, this is new for all of us to be in this immersive platform. It looks very nice, actually. So I think all the presentations complemented each other and were very interested in that aspect. I will start by Garrett. So you talk about the most important factor to identify children at risk. I was wondering if you can also let us know in clinical practice, what are the two factors that you consider most important for having risk of rapid myopia progression? And also if you can let us know which clinical monitoring tools you are using to monitor progression. I will just ask everyone to be very short because we have just 3 minutes.
Sure. I mean, for myopia progression, the main thing is age. I think that's just very clear across all the literature that the younger the person is, the higher their risk of fast progression. And that's very consistent and easy to measure. And then I think, as Lauren mentioned, parental myopia is the second one to consider. But in my head, age probably trumps that to a large extent. Personally, I'm not doing a lot of monitoring of myopia progression myself, but be sticking with the regular axial length. And I've been working a bit in that space in terms of tools to sort of compare axial length growth so that you have a reference value again that might indicate what this person would be expected to, how their eye would be expected to grow if they were not myopic or if they were myopic and treated. But I think, as Mark mentioned, it's much more precise. It's very repeatable. It's a nice metric to use. We just need to make sure it's got some context around that value.
Thank you so much. I have a question for Dr. Lauren Rose. It was very good to see your approach to the rebound phenomenon. My question is, for how long should we treat a child, or what would be the safe age where the rebound will be much lower, as we've seen from the results of the ATOM study, 10 to 20 years. 20 years after treatment, there were no differences between the treated group and the control. So my question would be, based on your clinical practice, what would be this ideal age, if there is one?
Yeah, that's a very common question I get from my families that see me. How long are we going to have to do this for? And I initially, at least very beginning, I usually say, how long's a piece of string? Because it's very hard to know initially. I do see children I've seen children for a really long time, and I do see trends. Very rarely do I see a very pronounced trend with seasonal variability, but most of the time I see a trend that is, this is their rate, you do something, it slows it down, and then they kind of potter along for a little while. And then over a period of time, I see a little bit of a decline again. And it does take a long time to get that sort of picture. But that's what I use. I don't actually use age in the sense that I've got 18-year-olds that are fast progressors, and I've got 14-year-olds that really haven't changed for ages. So age is a good guide, especially when they're very young. I'm going to say under 10. But after that, I think it's a little bit variable, and I think you need to look at the whole picture, not just the age. I think you can be a little bit tricked by age and think that it's all done, because the average age is where progression slows down significantly in all the graphs 15, 16. But I've seen many of those age kids going to a very intense level of study because of what they're doing at high school at that age, and potentially that being the confounder, but I don't know, maybe it's something else, but being quite progressive. So I do think you just got to monitor during and after treatment. And I think it's really important we start thinking about personalizing treatment, not coming with cookie cutter ideals, because unfortunately the landscape is very, very messy and noisy, and it's hard to give the best practice if you're just going to do the same for everybody.
Thank you so much. So my last question for Mark, I will not ask you which treatment is the best, but my question is for clinicians nowadays. There's so many treatments coming up, even for spectacle-based interventions. Many types of lenses appear. What would be your best tip for them in terms of which option to choose with so many available, and they don't have much time to sometimes look into all the literature available on myopia?
Thanks for the reminder for what passes as a succinct response in Australia. I would basically say, be the clinician, talk to the parent, assess the child, and pick the intervention that's going to be most appropriate for their lifestyle and the one that they're going to use. Obviously, you're not going to potentially put a very young child into a soft contact lens. A drawback with Atropine, of course, is you still need to correct the refractive error. So many of my colleagues in the US, for that reason, start with optical interventions.
Thank you to all the speakers. I would like to continue the discussion, but in the interest of time, we have to move on to the next section. Thank you so much for your participation.
Thank you, Doctor. Carla Lanka, and all our esteemed speakers for the previous session. Truly an insightful and engaging discussion. We now move into a special session by Unoya Med and iRising Group. Red light therapy is an emerging non-invasive approach showing promising results in myopia management through controlled light exposure. It is my pleasure to invite our speaker, Dr. Sanal Joseph from Australia. The topic, red light therapy, real-world evidence for global adoption. Over to you, Doctor.
Good evening, ladies and gentlemen, and thank you for this opportunity to speak in the Myopia Conclave organized by United Optometry Forum. I am Sanil Joseph, the Medical Affairs Lead at iRising International. We are a Melbourne-based technology company and the legal manufacturers of red light therapy device for treating myopia in pediatric patients. So our device is regulatory approved for treating myopia of all severity in pediatric patients. So today I'll be focusing more on the impact of red light therapy in treating high myopic patients. To begin with, I would like to introduce you to James, an Australian boy from Sydney. He was diagnosed with myopia at the age of 7 in 2020, and he had a correction of minus 2.5 diopters at that point. He was advised to be on atropine drops. When they followed up after a year, atropine was found not to have worked. His vision deteriorated to minus 3.5 diopters, and the doctor subsequently prescribed James to use DIMS defocal lenses along with the atropine drops. Then they followed him up after 2 years, and his vision was found to be rapidly deteriorated to minus 7 diopters in spite of the combination therapy of atropine and DIMS lenses. The parents were losing hope until red light therapy was introduced in Australian markets following the TGA approval. And James was started with red light therapy. And in a year's time, James had very dramatic improvement in terms of axial lens shortening and improvement in the spherical equivalent refraction. And his progression was completely stabilized. So repeated low-level red light therapy, RLRL, has been found to be a disease-modifying therapy, and it is particularly effective in patients with high myopia. And James's is not a unique case. We have been getting similar stories of impact from all the other markets that we have been entering. Currently, we have got regulatory approval in more than 40 countries, and most recently, we also have entered the markets in many countries in the Gulf region as well. We have been really privileged to work with many senior clinicians from different parts of the world. What you see on the screen is what some of them say about the benefits of red light therapy. They are not only leaders in their field, but also care deeply for their patients. They want to do the best for their patients. And more importantly, they have been open to innovative strategies to deal with myopia. But that's not enough. We would like to work with more clinicians from different parts of the world so that this effective technology can reach more patients who can benefit from it. Because as all of you know, myopia has been considered to be the world's most commonly diagnosed disease. However, the existing therapies have been found to be less effective, especially in high myopic patients. And globally, around 300 million people have been estimated to have myopia, including around 70 million children with high myopia. And just in the countries where we have initially entered, the number of people with high myopia exceeds 8 million. Our device is very uniquely positioned to treat pediatric myopia. It's a only patented, internationally available device for home use. The protocol is very straightforward and easy. It's 3 minutes usage twice a day, 5 days per week, and nothing else is required. And there is an inbuilt mechanism to moderate the usage so that there won't be any overexposure or prolonged usage of the device. The clinicians can monitor the compliance online, and the system generates an SMS alert so that the patients will be reminded not to miss the sessions. We have already seen some of the real-world evidences that I presented before. Now let's see what is there in the literature. What you see here is an efficacy comparison of different treatment modalities for myopia. On the right-hand side, the chart represents myopia of all severity levels, whereas the left-hand side chart represents only high myopic patients. Each bar represents a study and each color represents a treatment modality. As you can see, red light therapy represented by red bars is far superior with more than 100% efficacy. which means red light therapy not only arrests progression but also causes regression of the disease. Now that we have discussed the efficacy of the treatment, it is also important to consider the safety aspects of it. In fact, there is no treatment that is completely free of adverse effects, and hence it is important to consider risk versus benefit when you are evaluating the effectiveness of a treatment. Red light therapy has been in the field for over 9 years now, and more than 110,000 patients are using it. There has been zero significant adverse events or permanent injury reported till date. Some clinicians are still reluctant to prescribe red light therapy because they consider it is relatively new, and they are looking for more evidence. And we won't know how much is more because we have more than 30 peer-reviewed journals published, including more than 2,500 patients in clinical trials. Recently, there has been a couple of reports by Dr. Lisa Austin from Houston University about the safety levels of the red light therapy. So this is completely based on the laboratory experiments their team conducted. They have not considered any real-world experiments. However, this has created some concerns and confusion amongst clinicians who are already using red light therapy. So we wanted to clarify this for ourselves and for the other users. So we requested two internationally renowned ophthalmic laser safety experts to evaluate the eye-rising myopia management device. Professor John Marshall, who is the Emeritus Professor of Ophthalmology in the University College of London. He's a pioneer in ophthalmic laser research and laser refractive surgery. Secondly, Dr. Karl Schermeister from Austria. He's a leading international expert on laser safety standards and the former president of the International Laser Safety Association. So their experiments were based on measured emission parameters, comparison with experimentally derived retinal injury thresholds, and human volunteer experiments. They concluded that the eye-rising myopia management device operates within conservative safety margins under the prescribed treatment regimen, and hence they recommended the device to be safe for clinical use in myopia management when operated according to the manufacturer-defined protocols. And these are some of the reasons why they considered the eye-rising myopia management device is safe. Primarily, the output from the device is approximately 1 megawatt for 3 minutes, remains well below the non-retinal injury thresholds. Secondly, in the human volunteer study, participants were exposed to laser levels almost 5 times higher than that of the eye-rising device and for 5 times longer duration. But still they didn't have any clinical or functional retinal damage. And the eye-rising device uses very low-level red light that has negligible risk for photochemical retinal toxicity. Another important aspect is the physiological pupil constriction during treatment under ambient light conditions. The typical pupil size would be approximately 3 millimeter, which substantially reduces retinal irradiance. In the laboratory study conducted by Dr. Austin's team, they didn't use ambient light, and the pupil size was 7 millimeter to represent the worst case scenario. So these scenarios are not comparable. And as I already mentioned, the device has built-in safety controls which prevents any overexposure to red light. And on top of all this, we have a structured clinical monitoring protocol with a follow-up at 1 month, 3 months, 6 months, 12 months, and every 6 months thereafter, which also includes OCT scans. And this supports early detection of any possible adverse events, and the treatment can be adjusted accordingly for safety. Professor John Marshall and Dr. Karl are finalizing the manuscript based on their analysis. In the interim, we were really privileged to have Professor John Marshall make a presentation of their findings at the recent APAO Congress held in Hong Kong. So I encourage all of you to scan this and watch the video. I once again thank the organizers for giving us this opportunity to make this presentation in Myopia Conclave. You may please scan these QR codes either to subscribe to our newsletter, to connect us on LinkedIn, or to contact us directly. Thank you very much.
Thank you, Doctor. Sanal Joseph, for that amazing and insightful talk on red light therapy. We also extend our sincere thanks to iRising and Unoya Med Group for this valuable session. Now we begin the third session of today, eye structure, growth dynamics, and emmetropization process. It is my pleasure to invite our first speaker, Dr. Zoelfagar Mohammed from Oman. His topic, Anatomical Changes in the Growing Eye, Understanding Emmetropization. Over to you, Doctor.
Thank you. Thank you, for inviting me for Myopia Conclave 2 to speak about anatomical change in the growing eye, understanding the emmetropization, because this is a key factor for us in the clinic to implement our treatments, optical treatment, non-optical treatment, even Atropine. Let us start. I will address my topic through this point, the concept of emmetropization and mismatch at birth for the kids, and stages for ocular growth and clinical significance. Before clinical significance, we'll discuss anatomical change during ocular growth. Then we'll go to clinical significance of emmetropization. What is the concept of emmetropization? Emmetropization it came from the emmetropia, and it is the original definition for that: observed shift from hypermetropia at birth towards emmetropia as age advanced. Most of the studies speak about that, speak about shifting from hypermetropia, because as we know, the children start the eyes will be not completed, develop around, most of the studies speak about 70% or more or less. When the eye begins receiving retinal image, growth typically brings the refractive errors from moderate to low hypermetropia. But the ideal refractive states, or the definition, it is ideal refractive state where the parallel light rays from infinity focus precisely in the retina when the accommodation at rest. Because when you look for the prevalence of myopia and all this study, you'll find some studies they use non-cycloplegic refraction. So you will find the result for this study is little bit less accurate, because without atropine, accommodation can work, and some part of physiologic or some part of hypermetropia will disappear. So myopia, maybe it will be induced, or pseudomyopia. So very important when we speak about the definition to keep in our mind accommodation at rest. What is happening in the mismatch at pairs? There is physiological hypermetropia, but it is asymptoms. Okay, because of eye development related to age and growth. During the development, a degree of physiological hyperopia occurs as a part of normal eye development. This study conducted about this physiological hypermetropia, they said regular monitoring of physiological hypermetropia should begin at preschools. And very important to keep in your mind, as clinicians, if you find child within this age with zero refraction, okay, or little bit minus refraction, you need to put a red flag for this patient, because this time the patient start to be myope. So very important, when you look for the emmetropization, you need to look for the age. Is this number is suitable for this age or not? Okay, let us see these points related to the ocular growth. It is very important for us in the clinic to look for the age and then to decide. In the pairs at the age 2, the fastest growth phase with the eye lengths increasing from 16.5 millimeter to 22 to at age 3. So during this age, that means around 30% is still not developed. So when you find axial links within 16.5, you will put in the understand. You will put in your mind this patient is still normal. So or the axial links is normal. After that, in the puberty, you will find secondary slower growth phase occur during puberty with eye reaching its final adult size near to 24. Okay. In adulthood, eye growth generally stop around 8 to 18, 22, 21. So you will find, if you will find growth for your child or for your patient after 21 or after this age, that means also indication of some progression. The lens also has some period of time of growth. The human lens, it is in 2 phases. I don't know what has happened. I lost. I don't know who stopped share from me. Sorry. Okay. The human lens grow 2 phases. The first one is rapid, and this is symptomatic growth up to 1.5 years old, followed by slower linear growth throughout the life. So at the end, it will finish by the cataract, and before that, presbyopia. So there is some two types of growth. One, it is rapid, and this it will be in the first 2 years, and then after that, the slow one. The development of refractive or the development of refraction up to age of 6, you will find this also it come under different times. During early stage, there are change in the corneal curvature and axial length and lens power. We need to put in our mind each millimeter in corneal curvatures, it gives us 6 diameter. Each each millimeter in axial length, it will give us 3 diameter. So we need to put this in our mind. So the change it will happen during that. At 1 year of age, there is a further shift toward emmetrobization. Emmetrobization continues to slow rate after 3 until 6 years of old. By age of 6, most of children are typically 0.75 diameter hypermetrop. So if you find plus 0.75 hypermetrop, that means the child within normal range, and tendency toward increase in little bit to hypermetropia, but not high hypermetropia. Also keep in your mind to look for the esotropia, accommodative esotropia. That means you need to check the binocular vision status for this child. At or after age 6, there is refractive development differ by population. So again, this is come to idea. Some studies we need to conduct in different region, different country to find what is the normality for this region. So it will be different according to the regions. Also, it has observed that onset of myopia is differ or is after the age of 6. The progression of myopia is primarily due to increase of axial lengths, one of the main cause, even when the condition occurs in adults. Refractive change in adulthood reflects lens power change rather than axial length change, and the lens growth change in refractive index throughout the life. So the progression, according to the time, is different from refractive change to axial change. Anatomical change during the ocular growth, it will be also divided by cornea and crystalline lens. In the cornea, put in your mind steep adverse around 51 to 52, and rapid flattening starting between 6 to 12 months to 43 to 44, and then refractive impact, it will be offset the increasing axial lengths. The lens shape and power also is spherical powerful in the first stage of life. Then growth, it will be the lens, it will go to be flattened also, and little bit there is mistaken number, but there it will be also flattened, and also it will the refractive impact it will be counterbalance axial elongation. If you look for this study conducted 2019 about axial lens development in children Okay, they found there is progression till 6 to 7 years. If you look for 3 to 6 months, you will find the mean around 19.7. And if you go till 7 years, you will find the axial length is 22.4. So at birth 16 to 17, infantile phase around rapid growth to 2021, and juvenile phase it will find it near to 23, 24. So it will reach around the adult size. Put in our mind there is some feedbacks regarding this immetropization. It will come, and according to this experimental evidence from deprivation myopia animal studies showing that degrading the retinal image size cause uncontrolled axial elongation and myopia. This proof in vision dependent. If you look for this study, another study about the lens compensation studies, animal studies where spectacle lenses are used to artificially impose hypermetropic or myopic defocus, and the eye adjusts to growth rate to compensate for the lens and demonstrating active feedback. Regarding the retina, it is the photoreceptors, and it is a brain of metropization. It detects as the sign of defocus, which is hypermetropic and myopic flare. Dopamine also has some role. Stop signal of eye growth released more bright light, which is protective against myopia, and suppressed by form deprivation. Immetropization, or clinical significance of immetropization, there is two very important to put in our mind. Immetropization failure can be because of genetic, and this it can lead to myopia and hypermetropia, or myopia or hypermetropia history, father or mother, or any relative, or father and mothers, and environment, prolonged near work, and this is one of the very important factors related to effect of immetropization. And this can lead to these outcomes. If it is normal, it will go for emmetropia or maybe myopia, and myopia almost it will be axial in nature, or hypermetropia. Hypermetropia will speak about significant hypermetropia, which is more than 2, can lead to accommodative esotropia and amblyopia. Astigmatism also maybe can happen if asymmetrical change in the cornea or little bit in the crystalline lens. Let us at the end to take this key away for you. Immetropization is an active feedback-driven process, not passive growth. It involves coordinated symphony of structural change, corneal flattening, lens power decrease, and controlled axial elongation. The retina detects defocus and signals to sclera, or reds send signal to the sclera and modulated growth and cascade of biochemical signs like dopamine. Failure of this mechanism can lead to common refractive errors. Understanding of this process is fundamental to developing intervention of myopia control and managing pediatric eye conditions. That's all from my side. Thank you.
Thank you, Dr. Zulfiqar Mohammed, for that insightful session. Now, it is my pleasure to invite our next esteemed speaker, Dr. Bruce Williams, to deliver his talk. Over to you, Dr. Bruce.
Hello, everyone. This is Bruce Williams from Seattle, Washington, USA. Thanks for having me. Let's take a look at the importance of axial length and how it pertains to myopia management and clinical practice. We can look at some of the thresholds, the red flags, and monitoring strategies. Why is it important? It's the direct measurement of eye growth. Longer eyeballs equal higher levels of the disease, helps predict the risk of progression, what is the likelihood, and to what extent are kids going to develop the disease. It's not affected by optical factors such as accommodation. Unlike refraction, axial length remains stable during near work, giving a true structural baseline. These are some of the reasons it might be better to use structural versus functional protocols. First of all, structural measurements gives us a true sense of actual progression. whereas functional measurements, like in diopters, can be influenced by other factors such as accommodation. Axial length is a true biomarker of eye growth. Refraction can give us an incomplete picture. There are 3 stages of physiological axial growth or emmetropization, usually starting at about 2 diopters. Stage 1 is the most rapid phase up to about 18 months. Stage 2, from 18 months to 6 years, we see a slower, precise, refining phase shifting toward low hyperopia or emmetropia. Stage 3, it's mostly complete with small adjustments via visual feedback. Our goal is to keep axial growth as close to 0.1 millimeters per year as possible. There's going to be a lot of variation in these numbers. You'll see some that are stable at 0.2 millimeters per year and others that are not still progressing. These are guidelines. Use all the tools to assess progression. At 0.1 millimeters per year, that's considered minimal elongation. We can be confident that our current regimen is working. If we're getting 0.1 to 0.2 per year, we need to monitor very closely and consider treatment optimization or step-up treatment. At 0.2 to 0.3 millimeters per year, we have inadequate control. Let's review compliance or start considering combination therapy. Greater than 0.3 millimeters per year requires urgent intervention. You need to reassess the entire management program. Here are some red flags. Early onset, less than 8 years old, suggests faster progression and higher final magnitude. Treatment needs to be initiated as soon as possible, and the patient needs to be monitored very closely. Age and sex-matched axial length above the 90th percentile signals pathologically accelerated eye growth. Here again, these kids need to be put on a very aggressive regimen and closely monitored for the first year to make sure your treatment plan is sufficient. Rapid year-on-year growth over 0.3 millimeters, despite treatment, warrants immediate regimen reassessment or maybe combination therapy. Axial length percentiles are especially valuable in premyopes, where refraction is still within the normal range, but axial length is tracking high. Parents need to know if their child is at risk. Parents understand growth charts and will have better acceptance of early treatment. These curves represent illustrative normative trends for population studies. Individual growth, of course, varies. East Asian children show a much higher absolute axial length value at all ages. This chart is adapted from normative data sets for East Asian children ages 6 to 16. Values vary by ethnicity. You want to apply appropriate norms for your patient population. 95% of my myopia management population is of Chinese descent. When I show this to the parents, there is intense scrutiny. Parents want to know where their child fits into the greater scheme. If the child is above the 50th percentile, parents become very concerned and will almost always opt for immediate implementation of a treatment plan. Here are some red flags during treatment. If there's an increase greater than 0.2 millimeters per year, despite treatment, this signals inadequate control. You'll need to review your treatment. Acceleration after initial control is a serious warning sign. Check compliance and consider step-up therapy. A difference greater than 0.5 millimeters between the eyes may indicate monocular compliance issues, amblyopia, or other ocular pathology. You'll want to investigate further. It would be great if we could get these kids prior to onset. Parents usually don't bring their kids in until there's a problem. In any case, it's still necessary to get the baseline established as soon as possible. You want to repeat measurements every 6 months to establish a trend. Always use the same biometer. Plot trends, not just values. A single axial length reading is meaningless without context. Trends let you know how well your plan is working and gives the parents more confidence in how you are managing their child. It's always best to use a cycloplegic refraction. This eliminates accommodative variance. It isn't always possible, depending on the access to cycloplegics, but you still want to interpret axial length alongside refraction. Refraction isn't always the most reliable measure of progression, but it does give us additional information. A stable refraction but increased axial length of over 0.2 millimeters is not stable. A stable refraction is one of the most common sources of undertreatment. Here's something that really helps me. Parents intuitively understand height and weight percentiles. Axial length percentile charts translate immediately. When you say your child's eye is growing faster than 85% of kids their age, that resonates. Show trends over time. A rising trajectory is visually compelling. Emphasize long-term eye health. Avoid higher risk of glaucoma, cataracts, and myopic retinopathies. Frame axial length control as protection against high myopia complications. When these red flags appear, it's time to move into action. Low-dose atropine for younger or fast progression. Ortho-K may need to be adjusted to smaller treatment zone or more aggressive reverse curve. Myopia control soft lenses or spectacle options for daily wear. Combination therapy, using more than one treatment simultaneously. Environmental guidance is important as well. 2+ hours a day for outdoor time. Adequate lighting at near. Reduce screen time. Environmental guidance is not a standalone treatment. Measure early. Get that baseline axial length. You can't track what you have not measured. If you don't have access to biometry, then use dioptric change. Inspect the lenses at every visit. Over-refract and look for the need for additional minus. That would indicate progression. You want to monitor regularly, check every 6 months. Velocity matters. Act on axial length. Don't wait for prescription change. Lenses may need to be replaced more than once a year. Use percentiles. Age-matched context transforms a raw number into a clinical decision tool. Parents understand percentiles and will respond positively if they can conceptualize progression. Thanks again for inviting me, and I hope this was helpful. I welcome your feedback, and I can be reached at drwilliams@seattlevision.net for further questions or comments. Here's some additional reading. Thank you for your attention.
Thank you, Bruce Williams, for that highly practical and informative talk on axial length in clinical practice, highlighting key thresholds, red flags, and effective monitoring strategies. Now, we move on to our next presentation, the Premyopic Eye, How to Counsel, Monitor, and Intervene. It is my pleasure to invite Dr. Marino Formenti. Over to you, Doctor.
Hello. First of all, I would like to thank the organizer for inviting me to talk about one of my favorite topics, myopia, and in particular, early onset myopia. I'm really excited to present on premyopia from a clinician perspective. It's a vast subject, but I will try to summarize in a few minutes. We can define premyopia, a refractive state between plus 0.75 and minus 0.50, where a combination of risk factors indicate a high risk of developing myopia, then meriting preventive intervention. As eye care providers, we have the duty to examine the child eye and vision, then the structure and the function of the visual processes. We assess the structure of the eye through refraction, pay particular attention to control accommodation, or by using a cycloplegic agent. We also perform biometry and verify the integrity of the eye. As for function, we will measure the functionality of the accommodation and convergences processes. When dealing with a young person, and even more with a child, it's important to consider the risk factors that may lead to the development of myopia and its progression. In the first stage of our examination, the case history, we will look at general risk factors such as ethnicity, gender, parental myopia, outdoor and near work timing. We will look at the risk factor for refraction, where a more or less significant reduction in hyperopia will indicate whether the risk is minimal or pronounced. Next, we will look at axial length, where subjective measurement may be high or low. In fact, scientific evidence indicate that while the axial length increase of 0.1 millimeter in normal children is normal in children, we often see an acceleration of axial length during the year preceding the onset of myopia. Finally, we have the risk factor for binocular vision, which we'll describe in detail shortly. Here, the first group of generic risk factor, ethnicity. Asian children, and especially South Asian children, have a high risk for development and progression. So Caucasian have a low risk, while Asian have a higher, and in between we have Indians. Gender. Female are more exposed to the risk of myopia and from age 9. Age onset. Well, we are in premyopia, so this is not really the case, but we can say that the sooner the myopia starts, the more is rapid, and most rapidly from 6 to 12. Genetic. No parents, low risk. 2 myopic parents, high risk. Outdoor timing, 2 or more low risk, less than 1 is high risk for myopia development. Near work timing, 1 hour or less is low risk, 3 or more is high risk. Refraction. Dr. Zadnik and Muti have investigated the refractive component in the process of emmetropization and have established refractive index value for hyperopia corresponding to low, medium, or high risk. We can therefore say that if a child is 6 years of age and has an hyperopia of 150, we are quite safe. While if his or her hyperopia is 0.75 or less, the chance of developing myopia becomes high. In practice, physiological hyperopia protect us, and the closer we remain to 0.75 during the years of the primary school, the better. Axial length. The first thing we see here is that axial length differs between Asian and Caucasian children. We know that the prevalence of myopia in Asia is higher than in any other part of the world. The values are based on Tiedemann axial length growth chart for European and Asian children. Axial length percentile indicate the risk of and progression of myopia in children. They compare a patient eye length to age-matched peers to define myopia risk. So The 50% percentile is the average. The 75 indicate higher risk requiring intervention. And here we are to the evaluation of binocular vision. What do we need to consider for this evaluation? What is the accommodative response to the accommodative demand for that reading distance? And here we have the lag of accommodation. How is the accommodative facility when with the subjective finding? Here we can measure it in two-way, negative and positive relative accommodation, or with the flipper, plus and minus 2. Which is the near foria with the refractive finding? Is the child ISO? Is it IGSO? Which is the ACA ratio? We take the gradient ACA, we take the foria with the subject, we take the foria with the subject plus 1, and the difference between these two forias give us the ACA ratio. Is the foria well compensated by fusional reserves? This means can we measure with virgin facility, and we can have the B prism, 3 bays in, 12 bays out, and we measure the cycle in a minute. And then considering the performance of the child at near, how much the reading distance is to the near point of convergence. Here it becomes a little bit more complicated, even because the scientific evidence is less robust. Reading distance. The shorter the reading distance, the greater the demand on the accommodation and convergence system. Does the child have this ability? Therefore, if the child has a reading distance of 35 or more, the risk is low. But if the child reads at 25 centimeter, the risk is much higher because the demand on accommodation and convergences are much higher. ACA, we know that ACA ratio is an early sign of myopia development, and that can appear as soon as 4 years before myopia onset. And then, if the ACA ratio is over 5 to 1, the risk is high. Having ACA ratio high means having esophoria near. Does the child has the ability to compensate this esophoria with this fusional reserve? Virgin facility can be measured with the B prism, 3 bays up, 3 bays in, 12 bays out. It takes only 1 minute, and if it's less than 12 cycles per minute, then the risk is higher. Visual postural reflex. We can state that the closer the reading distance is to near point of convergence, the more the visual discomfort the child will experience. Is this reading distance at less than 5 centimeters to the near point of convergence? Then the risk is high. Here we come to the last topic, the accommodation. Lack of accommodation is a bit controversial here. It seems more pronounced after myopia onset than before myopia onset. In any way, if the lag is high, the risk is higher. Finally, accommodative facility. We have two ways to measure it, and the most effective is the flipper, plus and minus 2. So we have a change of 4 diopter between the lens and the other, and if the performance is less than 5 cycles per minute, the risk is high. Well, the purpose of our intervention in premyopia is to do everything possible to delay myopia onset. Let's see a case here. We have Lisa. She is 8 years and a half. She is Caucasian. At the case history, we learned that the two parents are myopic. She is a good reader, an excellent student, lot of study, and poor, no so many pauses during the study. Electronic devices are used for a long time, 3 hours a day, and outdoor timing is poor. She stay home, she plays, she study, but not really playing outside. Refraction is plus 0.50. Axial length is 20 2380. And in evaluating binocular vision, we have a high lag of accommodation, difficulty to stimulate accommodation, esophoria with low fusional reserve, and a high ACA ratio. This is the copy of the record of my discussion with the parents after the evaluation. For generic risk factor, there are 3 that cannot be modified. And here we have ethnicity, gender, and parental myopia. While the 2, like outdoor and near work timing, can be modified. So they keep them separate from the other because they can be modified by our recommendation of visual hygiene. Refraction and axial length indicate the level of risk in relation to the spherical equivalent to refraction, and axial length related to the age. Plus 0.50 refraction is a moderate risk for a girl of 8.5 years, while 23.8 is high risk for axial length. Binocular vision block evidentiate a visual dysfunction characterized by convergent excess due to the ESO, and also accommodative insufficiency due to the difficulty to stimulate the accommodation. I recommend an optical strategy correcting hyperopia and giving an ad for near. Then a prescription of 0.50 with an ad of 1, or using accommodative support lenses, new type, ad of 1.3. Also, we recommend go out, play outside at least 1.5 hours, have 10 minutes break every hour of studying. Use electronic devices for a maximum of 2 hours per day. And inside, use a good illumination at the desk, and possibly with the full spectrum bulb. What all this mean? We cannot wait the child become myope before acting. And this is all for me. I thank you, and I wish you a successful meeting.
Thank you, Dr. Marino Formenti, for that insightful talk on managing the premyopic eye, with practical guidance on counseling, monitoring, and early intervention. Now we move to our next presentation, Neurobiological Framework of Myopia, the Role of Omicron Cells. It is my pleasure to invite Prof. Paolo Nucci. Over to you, Professor.
Thanks, Carla, for the invitation. I just recovered from a flu, so please forgive this tenebrous voice that comes from just a disease. Today, I'd like to propose a shift in perspective. We usually treat myopia as an optical issue, something related to lenses, focus, or refraction. But what I will show you is a bit different. Myopia, fundamentally, is a neurobiological regulation disorder. The eye does not elongate randomly. It is responding to signals. These signals originate in the retina, are translated in the choroids, and executed by the sclera. So, the key question is not how do we correct myopia, but who is instructing the eye to grow. The retina is not a camera film, it is not passive. It is a neural tissue, and more importantly, a decision-making tissue. It does not just receive images, it interprets the visual environment and converts the environment into biological instructions. And these instructions regulate eye growth. The final output of the retina is not optical, it is neurochemical. So myopia does not start with blur. It starts with retinal interpretation of the environment. And inside the inner retina, we find amacrine cells. These are interneurons. They do not project to the brain, yet they regulate the tonic state of the visual system. Think of them as local governors. For myopia, two populations of amacrine cells matter most, the cholinergic and the dopaminergic amacrine cells. They do not transmit vision. They regulate growth signals. So the control system of eyesight is very local, is retinal, and is mainly chemical. Cholinergic starburst amacrine cells are activated during near work, during foveal stimulation, high detailed perception, sustained attention. In other words, the modern visual behavior. The biological message they send is simple. The environment requires adaptation. Plasticity is needed. The eye must grow. This is not pathology. It is an adaptive program that becomes maladaptive when chronically activated. Dopaminergic amacrine cells respond to daylight, to peripheral stimulation, and a wide visual field. Their message is the opposite. The environment is stable, growth should stop. Dopamine is the retinal brake with respect to axial elongation. Outdoor exposure is therefore not behavioral advice, it is neurochemical therapy. These systems are functionally antagonistic. When acetylcholine rises, dopamine falls. When dopamine rises, cholinergic drive decreases. Myopia develops when the balance shifts chronically toward acetylcholine. So, as you can understand, this is not a defect in optics, it is a shift in neurochemical equilibrium. Why screens promote myopia? Screens stimulate mainly the fovea, use low light levels, and suppresses peripheral stimulation. This biases the retina toward cholinergic dominance. So the problem with screens is not blue light nor accommodation. It is a neurobiological, neurochemical imbalance. On the other part, the peripheral retina, that is rich in dopaminergic cells, integrates motion, contrast, and global light. When stimulated, it sends signals to the choroid, inducing thickening and growth inhibition. The periphery of the eye is not secondary, it is regulatory. So, let's go through choroid role. The choroid is not just a vascular padding, as someone told us from the beginning of our studies. It is really a signal transducer between retina and sclera. Here, two pathways dominate, different, retinoic acid and transformed growth factors beta. They represent rapid plastic adaptation versus long-term structural stabilization. Retinoic acid induces choroidal thinning, enhances signaling toward the sclera, promotes extracellular matrix remodeling, and favors axial elongation. It is very fast, visually driven, and reversible. Transforming growth factors beta stabilizes the sclera, promotes collagen synthesis, and increases rigidity. It is not a visual sensor, but a structural regulator. Reduced transforming growth factors beta means plastic sclera. Increasing or transforming growth factors beta means stability. Let's look at this. The choroid modulates in the sclera with this activity between metalloproteinases, especially in 2 and 9 activity, and TIMP, the tissue inhibitors of metalloproteinases expression. And from this regulation starts the remodeling of the extracellular matrix. Let's try to summarize. I think that this table, you can take pictures of this, will help you in recalling these concurrent pathways. So, to see and understand the cascade, you see that the dopamine induced choroidal thickening, reduced pro-growth signals, acetylcholine induced choroidal thinning, increased trophic diffusion. These cascades translate visual behavior into structural eye change. And let's look at the drugs, at the atropine. Low-dose atropine is what we call a subtractive pharmacology. It does not force anything, but blocks muscarinic receptors, so means reducing cholinergic tone, and secondarily allows dopaminergic signaling. So it removes the permission to grow. The sclera is the real executor. The sclera does not grow in volume, it remodels. The issue, also in this case, is biomechanics, as not a size production. Let me go back a bit to the metalloproteinases versus tissue inhibitors of MMP. We should remind that metalloproteinase degrade collagen and increase compliance, while TIMPs inhibit metalloproteinases and preserve stiffness of the sclera. This balance is what regulates axial elongation. So, as per clinical outcomes, stable eye, balanced MMP TIMP, progressive myopia, there is MMP predominance. Finally, we have to remind that all therapies converge here. Light, atropine, peripheral defocus. Despite the different upstream mechanism, we have the same downstream target. So it's important to restore MMP TIMP control. So let me conclude with this take-home messages. No therapy shortens the eye. All effective therapies prevent the sclera from yielding. Myopia is not an optical defect. It is a kind of a dysregulation of a retinal choroidal scleral signaling axis. When we understand this, prevention, pharmacology, optics, and behavior all make sense within one framework. Thank you.
Thank you, Prof. Paulo. Myopia is not an optical problem. And thank you, Dr. Bruce. Thank you, Dr. Marino, for this insightful session and talk. My first question to Dr. Bruce about shifting the paradigm from refraction to biology. How do we clinically manage this accordance between axial length and spherical equivalence? If Dr. Bruce not here, we can shift to Dr. Marino, if he's here, about the parental counseling how we frame the pre-myopia to parent as predictable condition in requiring monitoring, or as a treatable condition requiring immediate action. What is the language between the goal preventions with the risk causing anxiety or unnecessary treatment burden?
Well, myopia, the most important thing is that we have to try to delay myopia onset. Why do we have to try to delay myopia onset? Because if we do it, myopia will not get to the level of eye myopia. And we know that if we keep myopia lower than 4 diopters, then the incidence of pathological myopia it's lower. So all we have to do is to try to prevent, and in my case, and what we have to do is that let's evaluate the whole system. Let's evaluate the risk factor, general risk factor. We have to evaluate refraction, also cycloplegic refraction. Axial length is extremely important, but what is one of the pillars in myopia management, I think, especially in pre-myopia, is binocular vision. Why? Because we have to see if the child has the ability to compensate the problem that may arise with a short reading distance and a visual performance that is concentrate on a very near task. So if like in the presentation I did, we have a child that is over converging, well, we know since 50 years that we have to do something to solve the problem, because if we solve the problem and the child is over converging using eye lag of accommodation, using IACA ratio, well, the demand is very strong, and this will keep in myopia. So we have to try to prevent that.
Thank you. Thank you. We have also a question to Prof. Paulo. From cell to clinic, how do we translate the Macrine cell signing into actionable therapeutic target? If Prof. Paulo is here. If he is not here, I will come to conclude these discussions because the time. Thank you, Dr. Marino, Dr. Bros, and Prof. Paulo and thank you, attendees, for joining this session. Thank you all.
Thank you, Doctor. Zulfikar Muhammad and all our esteemed speakers from the previous session for such an insightful and enriching discussion. We now move to a special session by Uyun Care Vision and Equipment Solutions. It is my pleasure to invite Mr. Sharath Raj for his talk, Commercial Aspects of Myopia Control, a Global Overview. Over to you, Mr. Sharath Raj.
Hi, good evening, everyone. Today we are going to talk about the myopia control on a global commercial landscape. Basically, not on the clinical side, this is basically on the commercial side. What is our conclusion? How will be the business what is approaching, what is the clinical setups and all. First, I'll introduce my company. My company name is Uyun Care medical equipment company, which is founded in 2017 with a private and professional proprietor. And also we are very dedicated to the ophthalmology solution. We are building that relationship with the leading market technologies to bring the ophthalmology industries with advanced machines and all. Also, we are committed to the high delivery quality ophthalmic products, solutions coupled with exceptional services, because we are having a team of around 6 to 7 optometrists. So we are more keen to bringing the new technologies, new products to the ophthalmology department. I'm handling both vision care and ophthalmology department. I'm working in UAE for more than 15 years now. Also, as per the expansion plan, we are not only UAE, we are registered in Oman, India, Nepal, Turkey, and UK as well. This is the roadmap of our company. Basically, in 2017, when we started as a specialty contact lenses. Then we introduced IPCLs, EDOF lenses, more diagnostic machines, human corneas, amniotic membrane. So I'll go to the details in the next slides. So mainly our products are specialty lenses, which is actually base we started. Then we introduced the phakic implantations, EDOF IOLs, and Ultima Smart toric lenses. Then we come up with the human cornea tissue supply and amniotic membrane distribution to UAE. Then we added a retinal products, which is silicone oil and gases. Then surgical products and consumables, which is used in the day surgery centers, OPD departments, and OT. And also we now introduced hospital and optical diagnostic instruments. I'll go in the slides one by one. Our first product, the specialty contact lenses, we are dealing with the LCS from France, where we have a AKS brand name of the lenses is AKS scleral lenses, which is available in the toric, asymmetric design, and freeform designs. Also, we are dealing with sphere, toric, multifocal, and multifocal toric designs. Then we slowly introduce the myopia control lenses, where we have an option for the soft and RGP lenses of the myopia control lenses. When we have an area MC, which is the toric and spherical availability lenses. Also, we have Essentia, which is patients who are the first time user of a hard lenses. They don't want to use the night wearing lenses or the orthokeratoid lenses. For them, we have a soft lenses options, where the prescription will be covered from -20 to -20 spherical to -6 cylinder. As also for the hard lenses, for the night wearing lenses, we have a coverage of -10 to -350 astigmatism. And also we have the latest lenses, which is the OCA defocus, is also soft lenses. It's a more famous now for the myopia control design, which basically is the multifocal design of the contact lenses. And also next we have the product called IPC, which is the implantable phakic lenses, which is the world's only customized phakic implantation lens, where you can customize anything from the optical center to the power range, the size of the lenses. And it's available in monofocal, toric, presbyopic, and presbyopic toric. And it's FDA approved, FDA Japan approved lenses. And the specialty of these lenses, the USP of these lenses, whatever the astigmatism you have, you need to put the lenses 0 to 180. This is a smart toric design. So we can cover up to -30 power to +15 and up to -10 astigmatism. In the case of the surgeons, if required, changing the astigmatism, we can go up to -14 astigmatism, the highest astigmatism we implanted in UAE. As a spherical side, we went to -28 astigmatism. Then we have a EDOF and smart toric IOLs, where EDOF lenses is a combination of a monofocal and a trifocal design, where it doesn't have a rings. It having a tunnel design, tunnel dynamic light distribution design, where the patient can able to see the distance and intermediate 100%, and near it will cover around 95% of the vision. And we have the best IOL option available as Ultima Smart Toric. This is the same technology what we have in the phakic implantation, but this is the IOL lenses, where you can go the power range up to -10 to +40, and astigmatism you can correct up to -20. So here also same the smart toric technique, where you can have a lenses on the 0 to 180 marking. It won't be tilted as per the axis. It's a smart toric, or there's a pre-aligned toric design. And also this all the smart toric designs are patented with the care group, so it is available only with them. And when it's come to next part, we have a human cornea tissue and amniotic membrane supplement. We are tied with the Lions World Vision Institute, where we are the only company who is having a pre-cut and preloaded corneas for the DSEC and DMEC cases. Then we have amniotic membrane, which is mainly used for corneal aeration, chemical burn, corneal injury, or any other cases related to the corneal surface, where we have two categories, wet and dry amniotic membrane. In the wet, we have an amniotic patch, is only one the design available, which is having a 50 and 100 microns availability. Then for the dry, we have three options for corneal surface cases. Basically, the dries are more easy to store with the room temperature, and it comes with the long expiry dates. So it's available in the disc, patch, and the amino ring available. And also we have a MacuSeal, which is mainly used in the retinal cases to cover the macular holes. Then we have a microbed company which is from Italy, which is more than 50 years old company. They are distribution of the silicon oil and gases availability. So we have a distribution for this gas and silicon oils for UA market. Also, they have a Active company which is from Italy as well, which is again is a 50-year-old company who is supplying of the trocars, back flush, foreign body removal, and many other related retinal instruments designed. They are pioneer with the retinal instruments supply, and also as a surgical instruments, as I told you, for the OPD department and the surgery or the minor OT surgery, day surgery center, they need a lot of surgical instruments. So we have a two different company, which is Escort from UK, which is in the good quality, the economy prices, and we have a NOPA from German, which is the high-end quality products. Then as a surgical consumables like HPMC, Hyaluron, blue rice is all used in the cataract and cataract surgery or any other procedure, silicone oil exchange, IOL implantation, phakic implantations, and many other surgery. Along with that one, we have a Trifine punch and vacuum receiver and donor cornea punch, and also iris care and capsule tension ring with the preloaded and unloaded option, and blades for the surgical surgeries. As a hospital and optical diagnostic instruments, we have a Mediworks company, which is FDA approved company, where they have a Scansys Pro 300 segment analyzer, which can be used for not only for the topography, also you can do the glaucoma screening, volt calculation, ICRS optimization, IOL toric optimization. Even you can do the scleral lens and myopia control progression the diagnosis and assessments and all. And also they have a topographer, and also they have a slit lamp with a microscope where you can have an inbuilt dry eye system where it will help you mostly for the pediatric cases or the before the cataract surgery or before any other refractive surgery. You want to see how much is the dryness level of the patient, what is the meibomian gland ratio, what is the blinking level, TS production. This can be calculated with the inbuilt machine of a slit lamp. Also, we have a optical setup for the hospital for the ARK machine and the Forafter from the Potek company, which is the Korean company. Then we have a total setups for the unit setups for the hospital and clinic setups. We have iOptic and Potek. These all the companies are FDA approved, available in UAE. So as a myopia control global commercial landscape, so we'll have an executive overview, global market and Middle East opportunities, and focus on commercial strategy, growth drivers, and regional expansions. So if you look into the chart here, as a global myopia control market, the market will grow CAGR of 12.6%, which is forecasted by 2033, which is 4.8 billion, which is a huge market. This includes contact lenses or the multifocal contact lenses, orthokeratology, myopia control glasses, and others. As a global myopia epidemic, 50% of the global population projected as a myopia by 2050. This is more into the rapid increase in the childhood myopia, screen exposure, and urban lifestyle key drivers, growing the need for the preventive eye care and myopia management become the standard of care. So global myopia by 2050, 50% of the global population predicted will be almost 5 billion people in the world. This is very scary, and as a global market opportunity, global myopia control market is expanding very rapidly. This is the hot cake now. So whenever you have any related this one vision, it is a vision therapy or the glasses, refractive surgery, ortho care, contact lenses, these all the treatments are available in the market. A growth driven with the specialty optical solutions. Key segments are spectacle lenses, contact lenses, atropine therapy. Orthokeratology also is growing in a specialty clinics, a strong investment from the major ophthalmic companies. If you look at the global myopia treatment market, 24 and 2033, as a regional analysis, including North America, Europe, Asia, Latin America, Middle East, and Africa. By treatment type, you can have a vision therapy, glasses, refractive surgeries, ortho care, contact lenses. By end user, specialty clinics, refractive surgery centers, hospitals, and clinics. By age group, there is adult myopia and childhood myopia. If you look at the ratio from 2023-2032, there is 8.4% of the ratio increasing of the global market. So revenue model in myopia management, Recurring revenue model means the patient having initial consultation diagnosis test, lens fitting, atropine therapy, follow-up monitoring visits, annual lens replacement, long-term patient management programs, higher lifetime value versus a traditional vision correction, because these patients are repeated patient. If you give a good service with a proper solution, this patient will be your permanent patient or the honest patient to you, so they will be repeated on all the time. So the care is more important, the suggestion is more, the solution is most important in this case. So as a Middle East market opportunity, there is a growing pediatric populations, raising the screen time among the children. This is started from after COVID is increased a lot, and expanding the private healthcare sector. You can see in UAE market there is a very huge private healthcare sector is growing. So this is also one good opportunity to grow the myopia control market in UAE, increase the awareness of myopia progression. There is a lot of awareness program happening in the schools, the campaigns in the hospitals, and many more places. And premium ophthalmic clinics is adapting more advanced treatment. So most of the premium ophthalmic clinic, they are looking for the more advanced treatment setups for the myopia controlling. And even the parents are, due to this awareness programs, even the parents are looking for more advanced treatment expectation, and they are inquiring with the hospitals, optometrist doctors. This is a good sign to go a market in a bigger way. So key commercial drivers in the Middle East. So the strong private hospital networks. In UAE, there is a very huge, strong private hospital networks and high disposable income in the GCC countries. This is also one reason. If you find more of the people or the more high disposable income people available in UAE, they are more concerned on their kids or the childrens to give a better treatment or better suggestions, or to control their kids' glasses, get it from the glasses and control the myopia and all. And this is helping with the strong private hospital networks is available in UAE, and the premium lens adaptation potential. There is, which are the lens production adaptation, the premium lens, whether it's a ortho K or it's a myopia control glasses, whatever the design, which a high-end product is easily adapted in UAE market due to the different experts and the local nationality people are available in UAE. So medical tourism in UAE, partnership the ophthalmology chains and the optometry groups. Even as Optoverse, there is a many optometry groups are available in UAE and throughout the Middle East, which is supporting a lot, discussing on the CME programs or the conference, or discussing on the myopia control awareness campaigns. This is helping more more development of the market on the myopia control. So strategic market entry approach, educate the ophthalmologists and optometrists, which is actually most of the people are doing in the market now. Build pediatric myopia clinics. So this is the most important things we have to grow throughout the Middle East markets. Partner with the hospital and optical chains. So we should have a partnership between the opticals and hospital chains, where they can understand the patient requirement, the budgets, and the patient what the patient is looking for solution and everything. Launch awareness campaigns for the patients, parents actually, because most of the time there will be campaigns in the schools, but the parents are not available. So we should do some of the campaigns in the schools when the parents meeting. So I always suggest some of the optical stores who is doing the camps or this one camps in the schools. I always suggest them, ask the management, ask some of the days when the parents are available, they can come and do a awareness campaign on the myopia control. So that will be more awareness to the parents. It will be reached to the children to have a better solution. Position the myopia control as a preventive eye care. So this tagline will be help you more to grow the marketing of myopia control. So our main goal is to build a long-term patient management and programs. Thank you.
Thank you, Mr. Sharath Raj and Yuyun Care Vision and Equipment Solutions for that excellent and insightful session. We now move to the fifth session of the day, evaluating myopia and long-term complications. It is my pleasure to invite our first speaker of this session, Dr. Syafra Harrington from Ireland. Her topic, Myopia Evaluation in Clinical Practice, cycloplegic versus non-cycloplegic methods. Over to you, Doctor.
Good afternoon, everybody. I am just going to share my slides now and go from the beginning. Okay, good afternoon, everyone, and welcome from Dublin. I would like to thank the United Optometrist Forum for this invitation to talk to you today. So today we're going to discuss myopia evaluation and clinical practice, and specifically what I'm going to be looking at are cycloplegic versus non-cycloplegic refraction methods. And I think we need to first consider why we are doing this. At the moment, we're talking today about myopia and identifying myopia, but really we need to identify premyopia as well. Because ultimately what we need to do, or what we should do, is considering ways to delay the onset of myopia, but also maybe prevent myopia. Maybe that's the future we can aspire towards. So if we want to prevent myopia, we need to measure it properly. Management starts with diagnosis. We have to find those kiddos who are myopic. Diagnosis depends on measurement, and indeed measurement needs to be accurate. And I suppose a quick reminder of why measurement matters. When we think of this category of myopia that's interesting, but it covers a huge swathe of the population, of the myopic population, from -50 all the way up to our double-digit myopia. But let's think about premyopia, that risk state that has been identified by the IMI. And what we know from a lot of the epidemiological, especially the longitudinal studies, including the NICER study in Northern Ireland, is that axial elongation seems to precede refractive shift. So that early intervention window is narrow. And really we need to think about, if we can't intervene early, we are detecting it late. And should we really congratulate ourselves from treating myopia once a child has become myopic? Ideally, where we want to get to is to that stage before myopia has started, so that we can do all we can to keep, that magic -4 diopters and prevent visual impairment in mid to later life. So let's think about what happens when we're checking refractive error. We first, in practice, we check refraction, and what happens if we measure without cycloplegia. So the first study I'm going to show you here looks at pre and post cycloplegic refraction in young adults. So this is a student population, and they were all pre-presbyopic. And so they had active accommodation, but they are also from a cohort that we wouldn't traditionally use cycloplegia in practice, because they were all over the age of 18, or 18 plus. What we found was, when we compared the results, there was a mean hyperopic shift after introducing cycloplegia of 0.68 diopters. I mean, that's clinically significant. And then we found that half of the population, almost half of the population, had a greater than half diopter difference between the pre and post cycloplegic reading. And the largest difference, of course, was in the hyperopes. But in general, most of the prescriptions and overall had changed. So we underestimated hyperopia, we overestimated myopia, and we misclassified premyopia. And I think we need to think about that, because if we misclassify, this will impact our clinical decision. And imagine the impact now for children when you see this is what's happening in young adults. So let's look at our Bland-Altman plots here, because that gives us a better view on the limits of agreement. And we can see here that when we compared, repeatability for readings taken, in other words, taking numerous readings with cycloplegia and without cycloplegia, we found that the repeatability, because there's always going to be, there can often be a slight difference if you measure the same child with the same instrument in the same circumstances on the same day. If we take multiple readings, there will be a slight difference, and this is the repeatability of the instrument. But we need to see, if the difference between pre and post is outside that range, and indeed it was. So I suppose in summary, cycloplegia reduces instrument noise. Our readings are more repeatable. This will give rise to better prescriptions, better research, and better moderating and monitoring in practice. But yes, it takes time. And people say, I don't have 30 minutes, I'm busy, it's a busy practice. So the next thing we're looking at here, first thing we're looking at the accuracy. The accuracy is better and repeatability is better with Cycloplegic. But what about the efficiency here of using cyclopentolate? Well, what we know is traditionally we have waited 30 minutes after introducing cyclopentolate drops. Do we need to wait that long? So we checked this in participants aged 6 to 7 years and 12 to 13 years. And we really found there was next to no difference between readings taken in this cohort of children who were predominantly white between 20 minutes and 30 minutes after installation of eye drops. However, we did find that if we pre-instilled proximethicane hydrochloride, which is a local anesthetic, which stings very little, it's kept in the fridge, it's quite cool, and it really stings very little. And this is our protocol for children who have Down syndrome and cerebral palsy, but in our clinic we use it for all children. But it speeds up the absorption of cyclopentolate, and therefore we found that we could get an accurate measurement more earlier when we introduce proximethicane. So if we look here at this graph, you can see here the 12 to 13-year-olds comparing readings at 20 and 30 minutes, and we look at the y-axis, we can see there's really very little difference. There's no clinical difference between 20 and 30 minutes. If we look then at the 6 to 7-year-olds in the right eye, this is the eye that had a pre-installation of proximethicane and then also followed by cyclopentolate. There really is next to no clinical difference. These differences here on the y-axis are tiny. And then if we look at children in the left eye, and we didn't choose proximethicane as a comparator for the left eye, and we found that indeed still not much difference between 20 and 30 minutes. But here on this slide, you get a better view altogether if you just bear with me here. What was the main difference? So comparing, for these are all to do here with children who are 6 to 7 years of age. We can see here in the top corner here, maybe if I get my laser pointer going here, you can see. So in this graph here, we can see the difference, the mean difference between 10 and 30 minutes was 0.19 diopters, very little. Between 20 and 30 minutes was 0.08 diopters, so next to nothing. And then for the left eye, cyclopentolate only, it was 0.27. So we're really not doing too badly. Well, it's slightly, okay, we're slightly clinically significant here. Not huge, but it was 0.27. But for the left eye with cyclopentolate only, 0.13 diopters between 20 and 38 minutes. So I think we're okay here. In reality, cyclopegia is not always used. Many optometrists avoid routine use of cyclopegia. In school screening, we never use it. So what can we do better? So we've looked at the repeatability, in other words, the accuracy. We've looked at the efficiency, in other words, the time, and now need to look at scale. When we want to find children with myopia or pre-myopia, ideally, we need to get into the public health realm here. We need to screen to find them. And in this paper here, what we did is we looked at different screening tools because we know in this part of the world anyway, we use uncorrected visual acuity. And if we look here at our RLC curve, you saw many of those earlier on, especially in Garrett's talk, you can see here the red line here is our gold standard, this red line. So we're right up here to the top corner. And this is spherical equivalent using, post-cyclopegia. Okay, so this is what the perfect situation that we can't achieve in screening. And now we're comparing all these other tools, axial length, the ALCR ratio, parental myopia, non-cycloplegic photo screening. Now, the non-cycloplegic auto-refraction here is using a spot screener. So it's not just it is not your traditional closed field auto-refractor. But what we want is one, which is never going to happen. But what we want for our area under the curve is to get it right up here. In other words, greater than 0.9. So for myopia detection with visual acuity, uncorrected visual acuity alone is not enough. We're getting a 0.72, which is mediocre at best. For pre-myopia, if we think 0.5 is useless, this is basically worse than useless. So no good when it comes to detecting premyopia. So the current screening is not fit for purpose for myopia and premyopia. What we do know when we think about it clinically is that visual acuity is acceptable for established myopia, but that's too late. It's too late. It's not good at identifying risk. So VA detects consequence, not trajectory. So we really need to think at public health level how we screen in schools. Now look at non-cycloplegic spherical equivalent, and this again is using the spot vision screening device, which is useful. You don't prescribe off it, but we actually found it was pretty useful when it comes to screening. So for myopia, the area under the curve was 0.84, pretty good. That is for premyopia 0.67, which is mediocre, but we're still talking better than visual acuity. So the message here is that refraction alone without cyclopegia is insufficient for risk stratification, but it is giving us useful information. So maybe if we combine it with one other tool. So I suppose we know the cyclopegia improves repeatability, it reduces accommodative noise, and it improves monitoring accuracy. But let's think about the scale and screening. What about if we combine a few tools? And what we have here is we've combined axial length and non-cyclopegic auto-refraction, and we're getting an excellent discernment here of 0.94. We're really getting up here into fantastic sensitivity and specificity. We're also not doing too badly here for premyopia. So it shows to us that if you add in biometry, axial length into your algorithm here, we are getting amazing improvement in our discrimination. And I think really my message here would be, or the global message could be, that myopia management is structural management. I think we need to include biometry into our screening and clinical armory. So practical model for optometrists, if possible, cyclopegia, 20 minutes adequate. I would suggest using Proximate K, and I find it fantastic, and there are no tiers. Axial length and baseline, monitor axial growth. If you are in a jurisdiction where you can't use cyclopegia, I don't think we can avoid it. I would suggest using biometry for your repeat, for your reviews, but at the beginning, I think at baseline, we need to refer on to one of our colleagues who can use cyclopegia. Is Mahindra a valid alternative? I use it a lot. I think it is fantastic for my review appointments, and the results are quite good, but there is some noise when it comes to hyperopia. It tends to underestimate it, but it is useful clinically, so I would recommend using it. It's a pragmatic tool. But for definitive risk classification, premyopia, cyclopegia remains superior. So my final message here is let's commit to measuring myopia properly. If we want to prevent myopia, we must measure structural risk, not just the refractive consequence. We've looked here at accuracy, efficiency, and scalability. And my final word here is let's measure structural risk, not just the refractive consequence. And as Gareth said earlier, cyclopegia is essential at baseline. Thank you for the opportunity to talk here today, and I look forward to dealing with any questions or talking to you later on. Thank you.
Thank you, Dr. Siofra Harrington, for that excellent and insightful presentation, clearly outlining the clinical importance of accurate myopia evaluation and the role of cycloplegic versus non-cycloplegic methods in practice. Now, we move on to our next talk, Adult Myopia Progression and Management Strategies. It is my pleasure to invite Dr. Pavan Kumar Verkicharla from India. Over to you, Doctor.
Thank you. Thank you so much for the introduction and the invitation to speak in this wonderful platform today. Firstly, very happy World Optometry Day, and thank you organizers, the United Optometry Forum, for organizing this biggest virtual myopia conclave. So today I will be talking about the adult myopia progression and the management strategies. And these are my financial disclosures, but nothing to be seen in relation to this talk. So let me start with this quote, which says the once a myope is a lifetime myope. Well, if that's true, then myopia progression in adulthood is also expected, and it should not be seen with a surprise. Now, let me take you through some of the recent literature published by Mulmoor et al. As a part of the IMI white papers, which shows the myopia progression in adults coming from different countries. And you see this column here, which shows the data where myopia progression is noted as low as 5% by more than 0.75 diopters to close to 47-48%. And in fact, Lohmann et al. Has shown about 86% of the adults having myopia progression by some account. Now, talking about myopia progression, we need to also understand that myopia onset is also not that uncommon. Now, if you look at this again, a similar table like the previous one, it shows the criteria used for adult onset all the way from 15, 16, 18 to 20. These are multiple papers from different countries. On the last column, you would see that the percentage of adult onset, it ranges all the way from 19% to about 81%, and depend on what type of study, from where it is originating. But you want to understand that myopia onset in adults is also not that uncommon. Now, in India, we did the study to understand what's the progression of myopia in young adults. We got the data from the hospital-based setting, calling it as a real-world clinical data of 2,683 individuals who are 18 to 30 years. And we got their spectacle prescription at 2 different time points. And based on that, we wanted to investigate what's the progression of myopia in young adults. So we got all the way from -0.5 to -15 diopters. And then we got individuals with 18 years of age to about 30 years. We looked at what factors really influence, and we found that younger the age, I mean, young 18 to 20, young adulthood, if you may want to call, the progression of myopia is relatively higher as expected. Whereas if somebody is about more than 20 or more than 26, it will drop down a bit. But what is important to note is somebody with high magnitude of myopia seems to continue to have progression even in their late teenage or even in their young adulthood. Whereas merely based on the male versus female, there is not much of a difference there. But presence of astigmatism, as you see on the last plot here, presence of with the rule astigmatism, against the rule, or an oblique astigmatism led to greater myopia progression compared to the ones without any cylinder. Now, in the clinical setting, you have an adult complaining to you about myopia progression. You want to be a little careful, or want to be extra careful if you may want to use. Anybody beyond 18 years comes to you and says there is increase in minus power, you want to ensure this is a clear case of myopia progression and is real based on the changes in axial length and other parameters. Check for any of the accommodative spasm, ensure there is nothing to do with keratoconus, all the systemic factors are ruled out. Measure the axial length. I think it's mandatory. In children, we say that it's important, but I would say in adults, it's crucial for you to eliminate any forms of other myopia kicking in. Ensure the directed examination is done, classify them as low, moderate, or high, because I've already indicated somebody with higher magnitude of myopia at higher risk. So you may want to classify them, are they at low risk, moderate risk, or high risk. Once it's axial in nature, then do a proper counseling, put them on myopia control strategy, then follow them up much more regularly as 6 months. Now, what myopia control strategies can be used for somebody with adult myopia progression? I think anything can be used, all the way from lifestyle modifications to the optical to the pharmacological management. And we need to understand that the site of action is different for all of these options that we have. But point to note is that the evidence or the clinical trials have largely included children, maybe until 15, 16 years of age. We have extremely limited evidence or nil evidence to say that these options actually work in individuals who are aged 18 and above. Now, on the screen, what you're seeing is the efficacy of myopia control options in children. But do we have a figure like this for adults? The answer is no. Now, there are multiple challenges that comes in while managing myopia in young adults. Firstly, like I've indicated, the lack of clinical trials. We do not have what's the normal distribution of the data. I mean, thanks to the IMI white paper that sort of shows us very diverse range of the myopia onset percentages, and then very diverse range of myopia progression. Whenever you prescribe myopia control options, I think that the young adults are much more sensitive to this. So you want to be careful. It's not like children, they now verbalize, they indicate what is really wrong with the lenses, or they can perceive even the smallest blur that's seen through the lens. The compliance, I think, goes for a toss here, because child, they are under the control of the parents. But if they are young adults, then there is always issues with the compliance. In young adult, there are multiple confounders that come in because they started work much more recently. There is university setting coming in. Even if you invite them for lifestyle modifications, the practicality comes in. I think there are a lot of challenges that need to be discussed. So what do? You have a child, you have an adult. The goal is common when we want to control progression and the axial length. Progression pattern, I think in children, it is much more common, much more faster, and with the norms indicating until 15, 16 years, there will be progression. So it's much more predictable. If you look at the adult, these progressions are relatively slower and really variable, like I have shown in a couple of slides through the IMI figures. You have variation from all the way from 5% to 80%. And somebody can have 0.5, and in some cases you also have one diopter variation. Of course, these numbers will come down if you talk about one diopter variation, but the numbers are there. And myopia progression will continue even in young adulthood if they have high myopia. What would be our first clinical approach? In the child, I think we assume progression, we start the risk assessment. In adult, you want to ensure this is a case of axial in nature and verify true myopia progression before you really label them as a progressive myopia. In adults, the problem is also that they may not undergo the regular follow-ups or the 1 yearly examinations. So you don't have clear data to establish or to label them as progressive myopia. Therefore, a follow-up is extremely important. In child, the confounders for progression are relatively fewer. But in adults, you want to rule out spasm, which is much more common in that age group, eliminate other systemic factors or the keratoconus. We have a lot of evidence to say that myopia control options work in children. Unfortunately, there is weaker evidence in adults. Axial length is extremely critical and crucial when you really have an individual aged 18 and above. Lifestyle advice, I think it's easy and straightforward for us to implement in children. But in adults, I think it is only going to play a supportive role. Like I said, they must be working individuals. Going outdoors is difficult. The role of outdoors in teenagers or young adults, there is less evidence, and it is tough to really get the lifestyle modifications, much like how we do in children. Optical treatment, you can proactively prescribe in child, but in adult, you've got to be really selective because adults are sensitive to even the smallest blur that you see. We advocate that whenever you prescribe the myopia control spectacles, I think the tolerance levels could be relatively poorer in young adults. They have high sensitivity, and especially if they're driving, they will come back. I have a couple of cases where I prescribed and the young adult indicated, I drive, when I do a reverse, it's getting a little difficult. So whenever there is a problem, root out the cause where it could be going wrong, ensure the centration is proper, educate them about the adaptation, communicate clearly, set the expectations right, educate them about the head movement. Now, when you talk about what myopia management options should be utilized, sorry, I'm in the airport and this announcement. So we have impaired guidelines that we follow for the children. Same thing can be utilized for the adults as well. First one is definitely you want to rule out refractive forms of myopia. My apologies. Yeah, map the risk factors. Pick a progressive myope, advise appropriate myopia control treatment. You have multiple, ensure education is given before you put them on any treatment. Combine treatment only if it is required in young adults. Start with monotherapy always, consult them in 4 to 6 monthly, and slowly take them off some treatment only when you know that consistently 1 to 2 years there's stable refraction, and monitor closely before you take them off. So overall, to summarize, myopia management in child, I think it's expected, and you would treat early to ensure you have better outcomes. In adults, the game is a little different, but keep in mind that progression is possible. Verify first it's axial in nature. Ensure this is case of axial myopia and a progressive myopia. Provide them with treatment strategies that's much more personalized to that individual. There are challenges currently in relation to adult myopia management with lack of evidence. But at the same time, we cannot ignore these individuals because we don't have evidence. You will have to do the off-label treatment, and because we need to start somewhere. I will quickly take you through case 1, where I've started myopia control after 18 years, bifocal treatment given. You see the curve, it's really flattened, and this is young adult. Case 2, 17-year, but atropine twice daily was instilled at the age of 20 years, and we could still plateau the curve. Case 3 is 24-year-old, only one eye kept on progressing. We got them on contact lens only for the left eye, and we could ensure the power is stable for the back-to-back 6 years. I think to conclude, each case is extremely different when we talk about myopia management. Adult myopia management definitely needs a holistic approach, while these cases all look different. With this, I thank you for your attention and wish everybody a world happy optometry day. Thank you.
Thank you, Doctor. Pavan Kumar Verkicharla for that insightful and clinically relevant talk on adult myopia progression and its management strategies. Now, we move to our next presentation, when myopia isn't the whole story, ERG in detecting inherited retinal disease. It is my pleasure to invite Dr. Andy Malam from the UAE. Over to you, Doctor.
Hello, my name is Andrew Malam. I'm a consultant pediatric ophthalmologist at Cleveland Clinic, Abu Dhabi. Now, many of the talks that we'll be hearing today in this Myopia Conclave really relate to primary myopia, the typical school-age progressive myopia, which we all see day in, day out. And that's completely reasonable because the majority of what we see is primary myopia, and a lot of the trial data that we rely on to guide our myopia management is based on primary myopes. However, there are certain situations where things don't quite add up, or there's some associated signs that we'll go through that really make us think that, or need to think that there may be something else going on, and maybe the myopia we're seeing is just a sign of something much bigger, whether that be a multi-system syndrome which may have potentially life-threatening implications, or even a retinal pathology, a retinal dystrophy, which may have sight-threatening implications for the family or the patient in question. And so for the purpose of this talk, I'll be focusing on those retinal conditions, and in particular, the role of this special test called the electroretinogram, or the ERG, and how it can help us identify and diagnose some of these conditions. Now, I'm aware we have a large audience with a very wide range of backgrounds, and so some may be very aware of the electroretinogram and some may never have heard about it. So I'll just recap how it works, and then critically when we should be thinking about requesting it or sending the patient into the eye service in a hospital, and then a few case examples from Cleveland. So just to recap, the retina is like a very complex circuit, and when light falls on the retina, it's detected by certain receptors called the rods and the cones, and when light falls on them, they actually change the charge or the potential across their membrane, and we can detect that change when they receive their stimulus, and then that message is then passed on down the retina to its connections and eventually to the brain. And now the rods are very important for detecting low levels of light, so they help us see when it's dusk and dark, and the cones are much more important for high levels of visual acuity, and they are focused in the fine vision area in the fovea, whereas the rods are excluded from the fine vision area and found elsewhere in the retina. So when patients have problems with these cells, it's not uncommon to develop myopia, and they often complain of problems seeing in the dark, or they're very scared in the dark, or they have problems seeing in bright lights. If the cones are misbehaving, they may have colour vision deficits. And with the electroretinogram, now there are a few different types of electroretinogram, but we'll focus on something called the full field electroretinogram, which is a global measure of retinal function. We use this special stimulator here called a Ganzur stimulator. So the child or the patient sits there, and it provides a diffuse uniform flash of light to the entirety of the retina. And then, just like an ECG detects heart electrical activity, these skin electrodes detect retinal electrical activity in response to that light. So it really helps us understand, is the retina working and responding appropriately to different light sources? Now there are different electrodes you can use, but basically for children the skin electrodes are the most appropriate. Now it produces an output, you don't need to worry too much about this, but just basically what we can work out from this electroretinogram by placing the patient in dark conditions before doing the test, and then putting them in light conditions and doing the test, we can understand what's happening with the rod and cone system, and also the inner and outer retina. So it really gives us quite a nice understanding of what's going on, and we produce these outputs. So if you don't remember anything else, this is the key slide. So when to consider it. So for me, the two most important things are when the vision doesn't correct to 20/20. You've tried your best, you've got a good refraction, but it still doesn't correct to 20/20. You have to think, is there something else going on? And definitely if the patient is reporting problems seeing in the dark when you ask them, or they clearly don't like to be in bright lights. Now sometimes we see this little wobble in the eye, nystagmus, and now clearly that needs to be investigated further. And in my area of the world, we see a lot of recessive conditions, so often there's a family history of inherited retinal diseases. And we always talk about when the refraction is bigger than the age. That is important, but I find that less frequent in the retinal dystrophies, but we do see it for sure, and I'll show you an example of it. And then of course, if we image the retina in more detail, we can see anatomical abnormalities. Well, then clearly we need to investigate that more. So just a few case examples from Cleveland. So the first one's a 7-year-old. So best corrected vision's already reduced, 20/80. So we know we need to look at this in more detail. And then when we look at the refraction, they're already a high myope. And in this case, actually, the spherical equivalent is bigger than the age. And to top it off, they also have a little wobble of the eye when we look in detail, and a little head posture, which is common when they have a little wobble for certain types of nystagmus. And then we always remember to ask them specifically, do you have any problem seeing bright lights in the dark? And they do. So clearly in this case, they're ticking a lot of boxes. We need to look at the retina in more detail. And this is the multimodal imaging that I performed. So the Optos, you can see there's some dulling of the macular foveal reflex there. The nerve fiber layer shine isn't as crisp. And the autofluorescence doesn't show anything major, but the OCT of the macula does show some mottling of the ellipsoid zone on both sides, of course. So we know there's some anatomical changes. What we don't know at this point is if this is isolated to the macula, in other words, a maculopathy, or if there's a generalized, more diffuse retinopathy that's occurring. And the only way to tell the difference is by performing a full field ERG. So that's what we do. Now you don't need to worry too much about these slides, but basically what it shows us is that when dim conditions, when we use a small stimulus, they don't respond appropriately. But when we increase the strength of the stimulus for the rod system, they get this exaggerated response. The cone system is a little bit abnormal. normal as well. And then we see this big response when we brighten the flash to the rod system, and we get this abnormal flattening here as well. And this is absolutely characteristic for one particular condition called KCNV2, or cone dystrophy with supernormal rod response. So in this condition, it's KCNV2, the electroretinogram can actually provide a genetic diagnosis. Basically, there are 3 conditions where the electroretinogram can give you the diagnosis exactly, and KCNV2 is one of those. And that's really important because this is a progressive condition, and there's implications for the future sight of this child, and also for the genetic counselling for the family as well. So it's really important that the diagnosis is made so they understand the situation. Now, the second case, again, was 7 years old, but the vision's only slightly down, but crucially, it's not 20/20, it's down despite our best efforts. And the refraction shows that they're not quite above their age, but, you know, it's a reasonable myopia for their age. And there's no nice diagnosis, but remember, you always ask specifically about night blindness in these conditions or problems at seeing at night, and they do report they can't see very well at night. They've got nyctopia. But when we do the multimodal imaging, actually everything looks pretty normal. So at this point, we don't know, is just because anatomically the retina looks normal, is there still something going on? And the only way to functionally assess the whole retina is with the ERG. And unlike the previous example, instead of getting an exaggerated response when we increase the flash strength, we get this what we call electronegative response. And in cases where children have myopia and a normal retina, but the ERG is abnormal in an electronegative way, we often think about things called congenital stationary night blindness. And when we did the genetics, that's exactly what they had. Now, unlike KCNV2, congenital stationary night blindness is generally a stationary condition, so we don't expect their vision to deteriorate further, and that's a very different situation to be in for a family. And finally, I'll just finish with this one. So we have a 14-year-old. This was interesting. This was one of 2 twins, actually, and they both presented in the same way, but I'll just talk about one. So best corrected vision was down, and they were high myope already at 14. And when they had been seen in other places, they were told that the child actually was making up their reduced vision. And they'd seen a few doctors, and they all said the same thing. This is functional. They're not reporting the test accurately. And that was partly because when they went to different doctors, their vision was different. So they performed differently for different people, and that was unusual. But when I asked her specifically, she didn't say I had night blindness or problems seeing in bright lights as such, but she said changing light conditions was challenging. So we did the multimodal imaging. Again, it all looked normal at this point, but we don't know, just because it looks normal, is it actually functioning normally? And so when we did the ERG, she also had this electronegative waveform. And so at this point, we know that there is some genuine organic retinal pathology occurring, and it's not that she's making it up as such. And so when we sent genetics, an unusual result came back, which was a variant in the RGS9 gene, which can cause bradyopsia. And bradyopsia is a condition where the photoreceptors, the rods and the cones, struggle to switch off after being stimulated. So there's a prolonged recovery of the visual cycle, and this can manifest in patients as struggling to adapt between dark and light conditions, even following moving objects, or variable visual acuity, because depending on the light intensity when they're being tested or just before being tested, that can affect their performance. But what was unusual is we've never seen an electronegative ERG in bradyopsia before. It's never been reported. So we went back to her and asked her specifically about the symptoms they get in bradyopsia, and she did say, actually, you know what, it is a very difficult changing between dark and light conditions, and I do have problems following objects. So that is correct. And now the electroretinogram in bradyopsia, it has a very characteristic pattern if you do a special test, and that test involves increasing the time between flashes. And when we do that, bang, she's exactly performs as we would expect for bradyopsia. So we know that that diagnostic test, the genetics, was correct. And in fact, we presented this as we've never seen this before. So the ERG was critical in confirming her diagnosis. Now, just to recap, so for this talk, I just had a look at the last 30 cases of kids with myopia with retinal dystrophies, and all of them had vision below 20/20. That's critical. And the vast majority had nyctalopia and photophobia. So those are the two most important things to ask for. A third had refraction over their age, and 20 had nystagmus. So in summary, these are the most important things to consider if you're seeing a myopic kid. So in particular, if the vision doesn't correct to 20/20, if they're reporting problems seeing in night or low light conditions or in bright lights, or if they have any of these other features, you must consider sending these patients to a hospital eye service to get a specialist review. And this is particularly important in this modern era where we are getting emerging gene therapies, and so it's really important we have an early and accurate diagnosis for any retinal problems, and also for some emerging therapies such as light therapies, where patients who have an underlying retinal disorder, of course, may not be sensible candidates for these therapies. So it's really critical we get the correct diagnosis. Thank you.
Thank you, Dr. Andy Malam, for that excellent and thought-provoking talk, highlighting the critical role of ERG in identifying inherited retinal diseases beyond myopia. Now we move on to our next presentation, Syndromic Myopia, How and What We Will Do. It is my pleasure to invite Dr. Ramesh Kekunaya from India. Over to you, Doctor.
Thank you very much for the kind invitation. A very happy Optometrist Day to everyone who are connected here and who are listening. Am I audible?
Yes, sir. Please carry on.
Okay. So I'll be talking about managing syndromic myopia, when and how to treat. So these are my financial disclosures. None of them are related to what I'm speaking right now. Refraction in children, come what may, we have to do it. Sometimes it can be difficult. Sometimes this myopia can be associated with some kind of syndrome, and sometimes it may not be associated with any problem. And as you all know, this is a beautiful article by, Flincroft et al. It talks about how do you really, take care of myopia management in terms of monitoring, myopia control, and myopia correction. All of them are different. So some of them could be related to genetic, and some of them could be because of, peripheral parts like exposure to sunlight and other things. It may not be completely related to your environmental. And sometimes it could be a combination of epigenetics, family history. It can be even related to proteomics and other things. Many animal studies, as well as other things, have shown. And we have plenty of treatment in terms of gene therapy and drug-targeted therapy for many of the things. When you see, I'm going back here. So when you look at the myopia, once it is there, they have a high risk for cataract, glaucoma, retinal detachment, and myopia maculopathy. It can be mild to moderate to severe. And it can be bilateral, which can lead to emmetropic amblyopia. High myopia in kids because of axial length. It could be because of retinal dystrophy or syndromic myopia. It could be because of lenticular problem, especially in retinopathy of prematurity. And they do have, approach of contact lenses. If they have emmetropia, amblyopia, you can give alternative patch and look at the risk assessment and then plan it. And timing of anti-myopia strategy also becomes important. For example, this patient had -11 diopter lens, but if you look at her beyond, what exactly you see, she has a stubby finger. And if you look at the axial length, it is 22. It's not really telling that it's a high myopia. Axial length of 22 in her is normal. But can you see something here? The lens thickness is 4.34 and 4.30. This is way beyond for a child with that kind of lens. And if you look at the K1 and K2, they are not too bad. This is as expected for a child. So that particular patient had microspherophakia. But if you look at this child, he has an anteverted nose, mild low set ears. When you look at the retina, it's severely tessellated, so there are some peripheral lesions. When you look at the vitreous, there are some changes. This is a classical high myopia with vitreoretinopathy. And if you see this, there is a loss of photoreceptors and thinning of choroid, and there are posterior staphylomatous changes. And there are two types, and in fact, there are many other types as well, but most common is type 1 and type 2. Type 1 has a membranous type, and type 2 has a bead type. If you see membranous versus bead type of vitreoretinopathy, then you are looking at high myopia due to Stickler syndrome. Why it is important? You need to recognize when and how to treat them. And this is the membranous-like, and these are some of the tessellations, what you see in them. And sometimes when you do in patients with retinal dystrophy, you will see this ring autofluorescence, and this already I have shown. And this is the patient with the minus 7.5, but he has been asked to do all of this. ERG showed subnormal responses, and he has hearing loss, cleft palate, mid-facial hyperplasia with Pierre-Robin sequence, early osteoarthritis. Hence, they will have joint pain as well as joint hypermobility and sometimes spinal abnormality. And in the heart, he had mitral valve prolapse. And you have call 2A1, call 11A1, call 11A2, LOXL3, and LRP2. These are all the types what you see. And there are typically 4 major types: type 1, type 2, type 3, and type 4 to type 6. Only the type 3 Stickler will have a non-ocular variant. And what am I showing here? When you deal with myopia, look beyond the eye. If you see some of this, that is a syndromic myopia. As a myopia practitioner, it's very, very important to differentiate between the myopia which are syndromic and which are non-syndromic. So if you look at this cohort, the median rate of progression of myopia was 0.08 diopter per year in those with type 1 Stickler, and 0.12 per diopter those with type 2 Stickler. That suggests that it's a very, very minimal progression. And if you see something on the occiput here, if there is a gap, there is a high myopia, this is no block syndrome, because the face tells a lot whether it is a syndromic myopia or non-syndromic. So this is one of the patients with significant thinning of choroid, and there is also a stretching of retina there with posterior staphylomatous changes. So this is some of the other systemic features of no block. This is also called 18A1 gene is involved here. And obviously, they have classical cutis aplasia, flat nasal bridge, mid-face hyperplasia. They can have occipital encephalophyseal, which is very, very common in these patients. So this is one more, the LTB-P2 variant. They can also have megalocornea with lens thickness like this. You can see 24 is the axial length, and we could not really measure the thickness. And Trabolsi syndrome also can have. These are all some of the patients I'm sharing just to make sure that you all are familiar with this syndromic myopias when you look at them. And then there is ROP related. In ROP, it's mainly the lens thickness related myopia, actually. This is what is the reading for them. So is there a role of peripheral refraction? Is it axial, lenticular, or monitoring and measuring is important? It's very important to differentiate which category they come in this kind of patients is important. So the other category is pseudophakia and aphakia. Here, axial length as well as optic disc diameter and the cupping and the intraocular pressure makes a big difference in terms of monitoring them. Whether the capsular size makes a difference in terms of peripheral refraction, we don't know. That could be considered. This is one of the Marfan syndrome. They can also have high axial length, and sometimes they may be not having it, but they may have progressive axial length growth. One of the characteristics is they can have a flat cornea, as you can see here, 38.28, 38.86. It's very flat, this particular.
Oui, bien sûr.
CSMB.
Bah ouais, c'est ce que je trouve aussi assez étonnant, mais
Is there any issue?
No, you may continue.
Okay. This is the congenital stationary night blindness. They can also have it. You can see the ERG pattern here. They can also have high myopia. So classification of high myopia can be primary and secondary. Primary can be isolated, and they can have entire retinal and metabolic disorders, as you can see here. Secondary can be syndromic, as we discussed here, and it can be due to anterior segment abnormalities. So this is what you have to really look into when you are looking into a high myopia case. So in infants and high myopia, this is one of the beautiful paper by IMI. You can see if there is a myopia in diopter which is greater than child's age, or at least there is one other feature, as you can see here, that means you are looking at a different myopia here, not the routine myopia. So this slide is very important if you want to screen who has high myopia versus a typical school age myopia. Once again, reiterating, myopia in diopter greater than child's age in years, or at least one other features, what you can see in this patient, in this flow chart, it's important. And if you want to assess, investigate, diagnose, and manage in a hospital setting, you need to go into the management pathway. You need to go into the relevant findings, and then you can take the action here. It's a very, very large, material here, but it's very, very important. High myopia, family history, medical history, examination, visual functions, eye movements, biometry, cycloplegic refraction, anterior and posterior segment examination, including vitreous, can tell you where you are going. And relevant findings in terms of axial length, phase, all that. If you are in a hospital setting, you need to go do all of this. And you need to even get investigations like OCT, ERG, corneal topography, gonioscopy, depending upon what you are looking at. So in a hospital setting, this works. In a screening, this works. If you are very busy, if you want to send them to a pediatrician or a pediatric ophthalmologist, you can always do it after this step. Then your approach should be history, general examination, ocular examination, and investigation. And in summary, I would say associated ocular and medical condition which can have impact on child's health, refer to specialized investigation or perform specialized investigation if you can. MDT, that is a multidisciplinary team evaluation and management is required. Biometric evaluation to distinguish between axial and non-axial types of myopia is important. As always, look beyond the eye. then you may not miss any of this. And management requires careful case-by-case approach due to the clinical heterogeneity they have. And we have very, very limited evidence base. However, if you see a progression in any of this, probably on a case-to-case basis, you can try any of the anti-myopia strategy depending upon that particular case. Thank you very much for your kind attention. I'm happy to answer any questions if you have. And once again, happy World Optometry Day, and enjoy the rest of the meeting and the talks. Thank you.
Thank you, Doctor. Ramesh Kekunaya, for that insightful and comprehensive talk on syndromic myopia and its clinical approach. Now, we move on to our next presentation, Binocular Vision in Myopia Management. It is my pleasure to invite Diana Mohammed from Malaysia. Over to you.
Okay. Hi, Assalamualaikum warahmatullahi wabarakatuh, and a very good day to all present. Thank you to the organizer for holding such a grand conference online. It's my pleasure to present on my topic today entitled Binocular Vision in Myopia Management. Myopia is a global health concern with prevalence escalating especially in East and Southeast Asia. Various myopia control methods has emerged in order to prevent risk of sight-threatening conditions that arise from myopia complication. Beyond genetic predisposition, environmental factors are key contributors to myopia. In this current modern digital world, increased screen exposure is associated with reduced outdoor activity and prolonged near work. These sustained near tasks impose higher accommodative demand, a factor well documented to be associated with the onset and progression of myopia. Traditionally, myopia management focused on dioptric power and axial length only, but current research is now linking the missing part of binocular vision role in myopia management. When viewing a near object, accommodation is initiated by contraction of the ciliary muscle, resulting in increase in crystalline lens power, and at the same time, convergence occurs to contraction of the medial rectus muscle, and sensory fusion will take place to provide single binocular vision. The accuracy of binocular vision and accommodation plays a crucial role to sustain prolonged near work. Research showed myopic eyes exhibit accommodative instability characterized by fluctuating or inaccurate accommodative response. This leads to an inability to maintain a stable, clear retinal image during sustained near tasks. High lack of accommodation creates hyperopic defocus, and this peripheral retinal blur, potentially driving axial elongation. In addition, the biomechanical influence through transient elongation creates during accommodations are accompanied with choroidal thinning and scleral stretching. The magnitude of the transient axial elongation is correlated with the accommodative demand. Continuous of transient choroidal thinning and scleral stretching restricted the equatorial growth, contribute to more prolate eyeball shape and causes permanent axial elongation, and these trigger and worsen the myopia. Myopes often exhibit a distinct set of binocular vision characteristics. It has been speculated that myopes have a decrease in blur sensitivity and tend to tolerate blurred retinal image, and this may lead higher near lack of accommodation. Myopes also tend to have lower accommodative facility and less stable accommodative response. Near heterophoria is normally out of normal range towards iso posture, and this also lead to high ACA ratio. Myopes also have the tendency to use a shorter working distance for longer period, and this is substantially increase their accommodative demand. Through this binocular vision characteristic, it indicates that myopia management is not only about managing the elongation of the eyeball and correcting refractive error, but to include binocular vision assessment as part of comprehensive myopia management. These are three reasons why this is important. First, binocular vision assessment help to detect early signs of myopia risk in children, which allow for timely and proactive intervention. Secondly, binocular vision findings directly guide practitioners in selecting the most effective and appropriate myopia control method for each individual child. Thirdly, through binocular vision, the assessment we can identify if the children who already undergoing myopia control, whether they need some additional binocular vision therapy or intervention to ensure optimal visual function. Certain binocular vision anomalies and clinical signs appear as predictive factors long before the child's refractive error actually shifts into myopia. These clinical signs may act as an early warning sign for practitioners to start intervention proactively. Increment of ACA ratio each year is a sign of impeding myopia. A study done by Muti et al. In 2000 found that ACA ratio can begin to elevate up to 4 years prior actual onset of myopia. If the value of ACA ratio is greater than 5.84 diopter per diopter accommodation in pre-myopes, the risk of developing myopia within a year is about 22.5 times, and this can be a clinical predictor for rapid onset juvenile myopia. The risk of developing myopic shift can be also predicted when a low hyperopic child aged 6 to 7 years old presented with a combination of esophoria and high lack of accommodation. And as for intermittent exotropia, studies showed 50% will develop myopia by the age of 10 and have the probability of having high myopia by the age of 20. Other than predicting myopia risk in patients, binocular vision can also act as a therapeutic key factor used to monitor effectiveness of myopia intervention. Normally, in myopia intervention, we will try to counteract the underlying myogenic factors. In the market, special myopia control, ortho-K, and contact lenses were designed to minimize accommodative lag and reduce hyperopic peripheral defocus. Current research showed that optical intervention induced changes to binocular vision and helped to restore the binocular vision function for comfortable vision, while atropine works through biochemical pathway to slow down the axial elongation. So this method normally should be combined with reduction of excessive near work to help lower the accommodative demand. Atropine has been a pharmacological method to control the axial length progression. Although 0.05% concentration of atropine have better control of axial length, it is advisable to monitor binocular vision status, especially atrophoria, functional reserve, and accommodation. This study, done by Woodman-Peters et al. In 2025, reported that the use of 0.05% atropine significantly reduced amplitude of accommodation facility, positive relative accommodation, and near fusional vergence with esophoric shift, and a reduction of near acuity was found after 10 days of use. So children who have high near work demand may experience visual discomfort and may need to be prescribed additional lenses to support his or her near vision. Therefore, caution should be made and binocular vision monitoring should be done closely when atropine initially prescribed to myopic children, especially those with low accommodation baseline. However, a study done by Weipan et al. Reported that these short-term changes in accommodation and binocular vision will gradually return to baseline level within a year, concluding that atropine is safe for children. As for AutoK, after 1 year of use, myopic children reported to experience exophoric shift at both distance at near and far, accompanied by improvement in accommodation function, fusional reserve, convergence, and also stereopsis. Studies show that AutoK decreases accommodative lag just 1 week after use because the lens produces positive spherical aberration. Feng et al. Reported AutoK is also beneficial in restoring binocular vision in convergent insufficiency myopic children. Now we move to myopia control spectacle lenses, specifically the focus incorporated multiple segment or DIMS lens. This lens has been established as effective in controlling myopia among children by providing clear central vision while inducing myopic defocus in peripheral retina through its lenslet design. This lens effectively reduces lack of accommodation and improve in ACA ratio and stereo acuity. However, a 24-month study in Malaysia among Malay children noted that the near point of accommodation receded by 2 cm over time, which exceeding the clinical significant threshold of more than 1 cm, and there is also a reduction of accommodative amplitude. Dual power in DIMS lenses may cause myopic children to under-accommodate when looking through the positive lenslet and causing exophoria and therefore contribute to the reduction of near point of convergence. This research also found that distance positive fusional vergence increase, suggesting there is some vergence adaptation happening to maintain binocular stability. Ma et al. In 2025 also observed children wearing DIMS lenses with convergent access progress faster axial elongation compared to normal myope children and other vergence dysfunction. Conversely, DIMS is beneficial for children with divergent access, where they noted there is a slower progression among these children. Clinically, these findings suggest the needs to monitor the near point of convergence annually when prescribing DIMS lens and precaution on patients with underlying convergence insufficiency and convergent access. From this discussion, we can conclude that baseline binocular vision should be made mandatory before deciding to choose the best myopia management for our patient, and continuous binocular vision follow-up is important to ensure patients are visually comfortable with myopia management. Literature suggested for binocular vision assessment that are crucial to monitor during myopia management, which is the near point of convergence, the phoria and the fusional reserve, the accommodative response, and also the ACA ratio. Utilizing this assessment brings us to one golden rule for our practice, which is if you detected a binocular vision problem, especially in patients with strabismus, amblyopia, or any significant BV dysfunction, it is advisable to manage the binocular vision problem first to optimum level before introducing myopia control. This is important to ensure no disruption of binocular vision when applying myopia management in our patient. So before I end, I would like to remind all of us that first, binocular vision assessment is no longer optional. It is mandatory in managing every myopic children. And there is no one-size-fits-all approach. So every child with myopia should be tailored their myopia control strategies according to their binocular vision diagnostic profile. Thirdly, we should always update ourselves with the integrate the evolving evidence that happening around so that we can give the best for our patient. And thirdly, myopia management is not only about diopter and also axial length, but it is also to integrate the functional and optimal visual comfort to support a child's daily activities. So with that, I end my talk. Thank you for your time and your dedication, and happy World Optometry Day.
Thank you to all our esteemed speakers for this session for such insightful and valuable presentations. Now we move to the panel discussion. I would like to invite Mohammed Hout to lead the discussion and request all the speakers of this session to kindly join the panel. Over to you.
Thanks a lot, everyone, for this wonderful session. It was very fruitful and truly engaging. So, as we know, the binocular vision assessment nowadays is no longer optional in myopia management, as discussed. It is mandatory to manage every myopic child. And as you said, Dr. Diana, in your presentation, that the patient should have an individualized treatment based on their case in order to tailor myopia control based on the case and the patient specific binocular vision diagnostic profile. So this question is for really everyone. So in case the child has any binocular vision deficiency, okay, in your opinion, what is the best tailored strategy in order to assess this case? How should we start, in your opinion?
I think Diana's mute.
Yeah, based on my experience, the best thing is to start with the binocular vision assessment as the baseline. And if the child is not having any binocular vision issues, so you have a lot of options. Any myopia intervention such as atropine, the optical intervention, it will not be any problem. But for those with binocular dysfunction, for example, the accommodation insufficiency ones, perhaps the best for some country, they may have limited resources of lenses. They can use the bifocal options for those with myopic patients with accommodation insufficiency. They can try to use the bifocal because as is written in research, patient with accommodation insufficiency may benefit with the binocular bifocal usage. Yeah. And before starting atropine, for those with accommodation insufficiency, maybe we need to start with visual therapy first before starting them with the atropine treatment.
Anyway, we can always start with a combination of treatments in case we needed to. For example, vision therapy with atropine or vision therapy with the next generation ophthalmic lenses, or maybe orthokeratology in some cases. And what is the preliminary eye exams for the binocular vision deficiencies that you do usually in the clinics?
Yeah, in our clinic in Malaysia, whenever we do the binocular vision assessment, we actually do all of the assessment, the accommodative component, the Virgin's component, but I don't think it is like feasible to everyone to do that. That's why from my presentation, I suggest that at least 4 binocular vision assessment to be done, which is the ACA ratio, the FORIA, the fusion divergence, the near point of convergence, and accumulation response.
Yeah, this
Yes.
is what I do as well. What we do in the clinics as well. We check the accommodation. We check the accommodation response, FORIA and the fusional reserves, the NPC, and last but not least the AC over A. Yeah, this is what we do as well. And I like in the last presentation of the doctor, the classification of high myopia between primary, secondary, and how it is divided into multifactorial, and the primary, secondary, how it is either ROP or prematurity or monogenic. So this would really help all optometrists or eye care professionals in order how to diagnose myopia or how to tailor the treatment based on the case, on the age, on the lifestyle, on the genetics. So it's a very important table that I took a screenshot about it. Do you have any comment on this chart, doctor, as well?
Yeah, I think again, let us not make it very, very complicated, because as a profession, you will have a limited knowledge. But if you use this classification, if you see a baby, maybe for 3-year-old, with the refraction is -5, that is something we are looking at, not as a routine thing. If you see a 7-year-old with -1, you are looking at a school age myopia. So if you see something unusual, if you see the vision is not improving completely, if you see in the face something abnormal, you're not seeing that the child is not, resembling one of the parents, either the mother or a father. Most of the times they are. These are all very, very simple things. If they have something cleft palate here, just if you take 30 seconds, 40 seconds, if you ask maybe a minute extra history, you will get that. My whole point there was, when you treat this patient, 80% could be a progressive school age myopia, but there'll be 10 or 15% or 20% of the patients who have systemic thing. That you should not miss. That's the only thing I want to share.
Yeah, thank you so much. I agree as well. Myopia management nowadays is now no more optional. It's mandatory, and it should be accessible to everyone, because as we know, it's becoming an epidemic. And in my opinion, and in many eye care professionals' opinion, more than half of the population will be myopic by 2050. I think so, with the running of the behavioral and environmental factors, with the genetics. So our eye health is as much as important as our systemic health. So we should always really address myopia management in everywhere, even with our friends, our family, whenever we visit a clinic, whenever we have a chit chat or a talk with any colleague. So really myopia management nowadays should be a message in order to save the lives of many people, because it has an economic burden as well on the long run. So this is very important. Anyone has any other question? Okay, so it seems everything was super clear. Thank you so much for the wonderful speakers. Nothing to add. It was fruitful, and it was an honor for us as well to attend these excellent sessions filled with really fruitful informations for everyone. Happy World Optometry Day for everyone, and see you soon.
Thank you.
Thank you, Mohammed Hout, for leading such an engaging and insightful panel discussion, and sincere thanks to all our speakers for their valuable contributions to this session. We now move to a special session by EssilorLuxottica Group. It is my pleasure to invite Dr. Rahila Shah from the UAE for her talk, Essilor Stellest, Latest Clinical Update. Over to you, Doctor.
Hello, can everyone hear me?
Yes, it's clear now.
Okay, and can you see my screen?
Yes.
Okay, so my video is not working, so I apologize for that. It's lagging on my end. So I'll be presenting without video, and when I can, I will log back on with video. Okay?
Sure, no
Is that
worries.
fine? Okay.
Yeah.
So without further ado, thank you for your patience all. Good afternoon. As you all know and have been shared, my name is Dr. Rahila Shah. I am the Medical Affairs Advisor at EssilorLuxottica. Today, I will be sharing the latest clinical updates on Essilor lenses, focusing on the evidence behind their role in myopia management. So before we begin, this session is for educational purposes and should be interpreted alongside your clinical judgment. What's changed in myopia management is that we're no longer relying on short-term data alone. We now have FDA-authorized evidence alongside long-term clinical outcomes. So today, I will walk you through what that evidence looks like and what it means for our patients. So let's start with what our journey is going to be. So a quick overview here for today's session. We'll start with a brief recap of the Stellest lens design, how it works, and how it's dispensed. Then we'll move into the US clinical trial, which supported the FDA market authorization for Essilor Stellest lenses. And finally, we'll look at the China study, including the 2-year results and the long-term data out to 6 years, showing the sustained impact of the Stellest lenses in managing myopia progression. So let's start with a quick overview of how Stellest lenses are designed. At the center, you have a single vision zone. So this provides clear single vision. And surrounding that is the HALT technology zone, which is responsible for controlling myopia progression. Now, instead of thinking about the details of each lenslet, it's easier to think of this as a structured pattern across the lens, arranged in multiple rings. What this design does is it creates a signal in front of the retina that helps slow down eye growth. And because this zone covers a large portion of the lens, this effect works in all directions of gaze, not just when the child is looking straight ahead. So as a recap, the lenses are spread across 11 rings. The shape Hello, I think I lost you guys. Okay, I'm just going to start back. Sorry, the lenses are spread across 11 rings, and these lenses provide a volume of slowdown signal in front of the retina following its shape. And the lenses cover 40% of the lens surface. This results in myopia progression control function in all directions of gaze. So from a fitting perspective, this is very simple. We only need monocular PDs and segment height, just like a standard single vision lens or progressive. The reference point and marking make alignment straightforward. So the treatment zone is naturally positioned correctly. There is no need for additional or complex measurements, which makes this very easy to integrate into everyday practice, especially when compared to some of the other lens solutions. So before we go into the details, let me quickly outline what we'll cover. The clinical evidence for Stellest lenses is based on 2 key randomized clinical trials, one conducted in the US and one in China. First, we'll look at the US study, which is a multi-center randomized double-masked trial with 2-year results currently available from a 3-year study. Then we'll move into the China study, also randomized and double-masked with long-term follow-up data extending out to 6 years, and now into its 7th year. Together, these studies give us the strongest clinical validation and long-term insight into myopia control. So now let's turn to our most recent data from the Stellest lens US prospective randomized double-masked multicenter trial. This trial included children aged 6 to 12 years with mild to moderate myopia and, importantly, no prior myopia control treatment. Patients were randomized to either Stellest lenses or single vision lenses and followed over a 3-year period, with 2-year results currently available. And at the 2-year mark, the majority of patients in both groups completed the study, giving us a strong and reliable data set to evaluate outcomes. Looking briefly at the participant demographics, the average age was around 9 to 10 years, with a balanced distribution between males and females. So overall, a fairly representative pediatric population. It's important to note that 91% of the participants completed the 2-year follow-up, which gives us strong confidence in the data. And in terms of compliance, children wore the lenses on average 10 hours a day and at least 6 days per week. So this reflects realistic everyday wear. So the key question here is, what were the outcomes? So looking at myopia progression over 2 years, children wearing single vision lenses progressed by around minus 0.9 diopters, which is very much aligned with what we expect in untreated populations. That translates to a 71% reduction in myopia progression over 2 years. Notably, this difference was statistically significant. Now looking at axial length, which is the key structural driver of myopia, children in the single vision group showed elongation of around 0.45 millimeters over 2 years, consistent also with what we expect. But in contrast, the Stellest group showed only a 0.21 millimeter elongation. That is a difference of 0.24 millimeters, representing a 53% reduction in axial length elongation over 2 years. And this was also statistically significant. So a key point here is that this level of myopia control did not come at the expense of visual quality. Children wearing Stellest lenses maintained 20/20 vision on average at every visit, and 97% achieved 20/20 or better at 2 years. There was also no significant difference in high or low contrast visual acuity compared to single vision lens wearers. And in terms of visual symptoms, such as blur or halos, these were similar between the two groups. Just to highlight a few additional key findings from the study, first, 34% of eyes showed no myopia progression over 2 years, compared to just 5% with single vision lenses. And if we look at slower progressors, 75% progressed less than half a diopter versus 36% in the control group. What stands out is that the effect was seen across all age groups, with the strongest impact in younger children, which reinforces the importance of early intervention. And this effect was consistent regardless of the child's initial prescription. Finally, in terms of safety, there was no clinically significant lens-related adverse events, with a very favorable safety profile overall. So here we are seeing not just an average reduction, but a meaningful shift in how many children are actually progressing. So just to summarize the key takeaways from the US clinical trial. Over 2 years, Stellest lenses slowed myopia progression by 71% and reduced axial elongation by 53% on average. This was achieved without compromising visual acuity, with no significant differences compared to single vision lenses. And overall, the lenses demonstrated a strong safety profile, with no lens-related adverse events reported. So this is the US data. Now, let's look at what happens over the long term. So building on the US data and FDA authorization, we can now turn to the China study, starting with the 2-year results, and then I will follow them up with the long-term data extending into 7 years. Now, looking at the randomized clinical trial conducted in Wenzhou, China, this was a prospective randomized controlled study with children assigned to either Stellest or single vision lenses and followed every 6 months. At 2 years, we see a 55% reduction in myopia progression and a 51% reduction in axial elongation. Importantly, though, when we look at children with full-time wear, at least 12 hours a day, the effect increases to 67% reduction in progression and 60% reduction in axial length elongation. So again, we're seeing consistent efficacy with even greater benefit when compliance is high. Now that we've seen the strong 2-year results, let's look at how the outcomes evolve beyond year 2 and what this tells us about long-term performance of the Essilor Stellest lens. Following the initial 2-year study, the trial was extended to look at long-term efficacy and performance in older children. Now, an important point here. Once efficacy was established at 2 years, it was no longer ethical to keep children in single vision lenses. So all participants were switched to Stellest lenses. To maintain comparison, a new control group was introduced at year 3. And after that, comparisons were made using extrapolated controlled data based on established models. What this allows us to see is the cumulative effect over time. By year 5, this increases to 1.75 diopters and 0.72 millimeters in axial length. On top, you will see the 3-year data, 5-year data, and 6-year data, and what the cumulative control was. So the key message here is the effect is not only maintained, but continues to build over time. This is something we do not typically see with many interventions. And importantly, the study maintained a 72% retention rate over 6 years, which supports the reliability of these long-term findings. And now let's look a little bit more closely to the most recent 6-year data. Now looking at 6-year outcomes, these children were now in their mid to late teens. And importantly, we continue to see the sustained effect. Over 6 years, Stellest lenses achieved a cumulative slowdown of 1.95 diopters compared to the extrapolated control group. This demonstrates a long-term treatment effect, even as children move into later teenage years, with efficacy still evident in the 6th year of wear. And when we look at axial length at over 6 years, we see the cumulative reduction of 0.81 millimeters compared to the control group. This reinforces that the treatment effect is sustained over time with continued control of axial growth, even into the later teenage years. Now, building on the long-term data, here are some additional clinical insights from studies conducted outside of the US. First, in children wearing Stellest lenses full-time, 9 out of 10 showed eye growth similar to or slower than non-myopic children. Over 5 years, this translates to saving the equivalent of about 3 years of myopia progression. Importantly, the risk of high myopia is also reduced, with only 9% progressing to high myopia compared to 38% with single vision lens use. We also see no evidence of rebound when treatment is stopped, and very rapid adaptation, with most children adapting within just a few days. Lastly, in terms of age profile, the French Myopia Institute recently released a protocol for managing myopia in children and adolescents, recommending that options such as the Essilor Stellest lens be recommended for children and young adults aged 4 to 20 and above. So overall, We're not just slowing progression, we're meaningfully changing long-term outcomes for these children. Finally, I know that the study was mentioned earlier on in the day, but I did want to take a second and look at this external evidence. This slide shows findings from a 2025 systemic review and network meta-analysis, including 12,000 children across 74 studies. What this allows is a direct comparison across different myopia control interventions. What this review revealed is that among all interventions evaluated, spectacle lenses with highly aspheric lenslets or Stellest lenses were among the most effective in slowing axial elongation. So this reinforces what we've seen in clinical trials already, with strong evidence not just internally, but across the wider literature. So to conclude, Essilor Stellest lenses are the first and only FDA-authorized spectacle lens to slow myopia progression in children. In a 2-year randomized clinical trial in the US, they demonstrated a 71% reduction in myopia progression and a 53% reduction in axial elongation. And beyond the US, long-term data show that this effect is sustained over time with continued benefit into teenage years. Together, this represents a meaningful advancement in how we manage childhood myopia, providing a clinically validated, non-invasive solution to help change long-term outcomes for our patients, and an opportunity to intervene earlier and more effectively than ever before. I also wanted to just take this opportunity to say thank you, and also that we here at the medical team at EssilorLuxottica are here to support you, and we remain present, committed, and available to you, especially during this time and always. So thank you for your time and attention today, and I will be happy to take any questions during the panel discussion.
Thank you, Dr. Rahila Shah, for that excellent and insightful presentation. We also extend our sincere appreciation to EssilorLuxottica Group for their valuable support in making this event a success. We now begin the session, Global and Regional Myopia Trends, Implications for Clinical Practice. It is my pleasure to invite our first speaker, Dr. Eric Encampira from Mexico. His topic, Myopia Screening in Public Health, Standards, Challenges, and Opportunities. Over to you, Doctor.
Hi everyone, I'm Dr. Eric Encampira and I will be talking about myopia in public health today. First of all, I would like to thank the scientific committee for this kind invitation. I have no financial disclosure relevant to this talk. Until relatively recently, myopia was widely considered a harmless refractive error that could be easily corrected with spectacles, contact lenses, or refractive surgery. Over the past 2 decades, however, there has been a profound shift in how the ophthalmic community understands and approaches myopia. This change is driven by several factors. First, its rapidly rising prevalence. Second, its association with a higher risk of ocular disease and long-term visual impairment. Third, the development of evidence-based interventions aimed at delaying onset and slowing progression. We know the prevalence of myopia has increased sharply in recent decades, making it one of the most widespread eye conditions globally. Lee and colleagues suggest that early projections, such as estimates that by 2050, nearly half of the world's populations will be myopic and 10% will have high myopia, may be overstated due to limitations in data representation and modeling assumptions. They highlight the importance of developing more refined region-specific forecasting models to more accurate capture real-world trends and better inform public health strategies. The prevalence of myopia and high myopia is unevenly distributed worldwide, with strong influences from geographic, urbanization, and lifestyle. Rates in China, Japan, South Korea, Singapore, and Taiwan are substantially higher than in other regions, making East and Southeast Asia the most affected areas. It is estimated that around 80 to 90% of the teenagers between 17 and 18 years old are myopic, while 10 to 20% will develop high myopia. This marked increase began after the Second World War and is largely attributed to environmental and behavioral influences, particularly intense educational demands from an early age, prolonged near work, and reduced time spent outdoors. Evidence from epidemiological studies supports these trends. For instance, longitudinal data from China show that the prevalence of high myopia in urban youth nearly doubled over a 15-year period, rising from 7.9% to 16.6%. Similarly, Japan reports a significant burden of disease, with myopia-related macular degeneration being a major contributor to visual impairment. Overall, regions with modern East Asia education systems consistently show higher myopia prevalence compared to those with Western-style education, limited formal schooling, or no formal education. In other regions globally, there is evidence suggesting that myopia prevalence is also on the rise. In the most recent National Health and Nutrition Examination Survey, the prevalence of myopia among young adults aged 20 to 39 years was reportedly to be nearly 50%, with high myopia affecting around 7%. However, these estimates are based on non-cycloplegic refraction, which is likely to result in a considerable overestimation of true prevalence. Other published data has shown that the prevalence of myopia among individuals aged 18 to 24 in the United States increased markedly, rising from 27% in the 1971 to 1932 period to 38% in between 1999 and 2004, while high myopia increased eightfold over the same period. In South America, a meta-analysis by Guedes and colleagues reported an overall myopia prevalence of 8.6% among children and adolescents between 3 and 20 years old. However, the analysis was based on a relatively small number of studies, and prevalence estimates varied considerably, ranging from 0.8% to 47%. In Africa, the reported myopia prevalence is 4.7%, and for high myopia 0.6% among children aged 5 to 18 years. Region-specific estimates within Africa indicates prevalence rates higher in the Northern Africa and the lowest in the Western Africa. Ethnic disparities in myopia are well documented, with Asian population exhibiting a greater risk of both onset and progression compared to Caucasian and African populations. For example, pathologic myopia affects approximately 1 to 3% of Asians, compared with around 1% of Caucasians. We can see in this map the prevalence of myopia around the world. In 2015, visual impairment from uncorrected myopia was estimated to cause a global productivity loss of $244 billion, roughly 0.3% of the world's gross domestic product, with $6 billion linked to myopic macular degeneration. This highlights the importance of effective strategies for myopia prevention and control. Given that prevalence can reach 40 to 90% in some regions, cost effectiveness should be evaluated at both individual and population levels. Barriers and challenges facing myopia prevention and control. The first barrier is the lack of awareness. Awareness of myopia remains low globally. In Ghana, only 49% of adults had heard of myopia. In Israel, although most parents believe progression should be treated, only 22% knew of available treatments. In Saudi Arabia, over 1/3 of parents were unaware of refractive error, and nearly 2/3 have received no information during pediatric visits. In Spain, about 40% of parents were unaware of myopia control strategies, relying mainly on informal sources. Consistently, global practice still favors single vision spectacles despite their limited role in slowing myopia progression. The second barrier is affordability and accessibility. Cost and access barriers are not limited to low-income settings. In the United States, myopia control options such as HAL and DIMS spectacle lenses and low-dose atropine lack FDA approval and are typically not covered by insurance, resulting in significant out-of-pocket costs for families. These challenges disproportionately affect socioeconomically disadvantaged and marginalized groups, including racial and ethnic minorities, non-citizens, and migrant communities who experience high rates of uncorrected refractive error and reduced follow-up care. Additional barriers such as transportation, language, and lack of insurance further compound disparities. Financial constraints also reduce the effectiveness of vision screening programs and limit adoption of advanced screening technologies. Overall, addressing broader social determinants of health is essential to improving equitable access to myopia care and vision services. Third, lack of continuing professional education. A substantial proportion of eye care practitioners worldwide remain insufficiently informed about evidence-based myopia control strategies. An international survey of 3,195 practitioners revealed persistent reliance on outdated approaches, such as undercorrection and single vision spectacles, despite clear evidence of their ineffectiveness in slowing myopia progression. Looking ahead, the standard of care is expected to shift toward comprehensive myopia management, necessitating more frequent and longer clinical visits. Workforce analysis from the UK and Ireland indicate that this transition may increase short-term demands on eye care professionals. However, with targeted workforce expansion and enhanced training, services are projected to accommodate the increased demand without becoming overborne. Management and strategies. Because myopia induces a spectrum of structural changes, there is no clearly safe threshold, even though degrees of myopia are associated with an elevated risk of vision-threatening ocular conditions. That's why all strategies must aim for early myopia detection in order to early stop progression. It's considered that slowing myopia by 1 diopter, the chance of developing maculopathy is reduced up to 40%. Vision screening guidelines increasingly recognize myopia as a major cause of visual impairment. In 2022, the American Academy of Ophthalmology and the American Association for Pediatric Ophthalmology and Strabismus identified myopia as a high priority condition, and the World Health Organization emphasizes early detection in preschool and school-age children, although specific diagnostic criteria remain undefined. While there is general agreement on the importance of pediatric screening, guidelines vary in terms of timing, frequency, target conditions, setting, and personnel. As a result, current approaches may lack sufficient sensitivity to detect early onset and progression of mild myopia. China developed strategies for myopia management because uncorrected myopia in China was estimated to result in a 1 to 3% gross domestic product loss due to reduced productivity. In response, since 2018, the government has implemented comprehensive national strategies, including setting myopia reduction as a key performance indicator for local governments, conducting biannual nationwide screening, expanding health education, lowering the cost of intervention, for example, reducing the cost of ortho-K lenses, and introducing the double reduction policy to reduce the academic burden and encourage outdoor activity in children. Despite these coordinated efforts, robust evidence on their long-term effectiveness in reducing myopia prevalence remains limited, requiring further investigation. Taiwan initiated large-scale myopia prevention earlier than mainland China, beginning with the Taiwan Student Vision Care Program in the 80s, which implemented routine school-based screening and various environmental and treatment interventions. Early efforts had limited impact, likely due to insufficient evidence-based approaches. However, the 2010 Tian 120 initiative, promoted at least 2 hours of daily outdoor activities, was associated with a measurable reduction in myopia prevalence among primary school children. In the US, vision care is accessed through multiple non-traditional pathways, including school-based programs, community partnership, and community health centers. In conclusion, the global increase in myopia poses a major public health and economic challenge. Although effective management strategies exist, access and affordability remain significant barriers. China's experience highlights the impact of coordinated government-led intervention. Moving forward, improving data, expanding access, strengthening practitioners' capacity, and increasing public awareness will be essential to effectively address the growing myopia burden. Thank you.
Thank you, Dr. Eric and Campira, for that insightful and informative talk on myopia screening in public health, highlighting key standards, challenges, and opportunities. Now, we move to our next presentation, Patterns of Myopia Progression in Childhood, Evidence for Clinical Practice. It is my pleasure to invite Irene Sophia Joseph from the UAE Scientific Committee member of UOF. Over to you, Irene Sophia Joseph.
Good evening and hello to all. I will just share my screen first. Okay, so today I'm going to talk on the patterns of myopia progression in childhood, evidence for clinical practice. So as the topic goes, I'm going to talk about a lot of studies. Please bear with me, but I'm going to try to keep it as simple as possible. All right, to start off, we know myopia is not just a simple refractive error now, which can be corrected with just spectacles. It's becoming a global public health challenge because it increases the risk of sight-threatening complications later in life, such as glaucoma or macular myopic degeneration, or even retinal detachment. So understanding the specific patterns of progression during childhood is very critical for developing effective intervention strategies. So let's look at a few evidences which explains the natural history of progression of myopia and the factors that influence that. So first we'll look at the age of onset and gender. The CLARE study published in 2015 shows that the age of onset is the strongest predictor for final severity of myopia. So children who develop myopia at 7 or 8 years of age progress significantly faster and often even by more than 1 diopter every year compared to those who develop it at 11 or 12 years of age. So early onset myopes have more years for progression before stabilization, hence they are at higher risk for reaching the high myopia levels. So another study published in 2023 from Ireland analyzed the records of almost 4,000 kids from 40 practices, and they found that faster myopia progression happened among younger children, among females, and among those who presented with a high level of myopia at the initial visit. So approximately 94% of the 7-year-olds progressed at least by 0.25 diopters within the 18 months, compared to just 62% of the 12-year-olds and 29% of the 17-year-olds. So they found that myopia progression progressively slowed with increasing age. There were even other studies much earlier from 2005, 2008, and 2009, which showed similar results. Coming to gender, there were many studies published which showed that the female portion of the cohort progressed faster than the male portion. So this could be attributed to reasons like the hormonal changes, estrogen levels, and related to ocular parameters, or even because of the early onset of puberty and growth spurts in female than male, and also maybe just because of the lifestyle factors, which included lesser outdoor time or increased indoor or studying and near work time among females. So another study from France in 2022 showed that they first analyzed the data on refractive error, gender, and age from almost 700 optical centers. So they analyzed more than 100,000 children and studied the progression of myopia over 6.5 years. And they found that progression of at least 0.5 diopters every year occurred in the first 2 years in population that had younger age, say 7 to 12-year-olds, and in the group who presented with spherical equivalent of -4 diopters at the first visit, and also in the female portion of the cohort. So that was their study's finding. Another factor is ethnicity. We have a lot of evidence showing that myopia prevalence is much higher in the Asian countries compared to other countries globally. And we have the global trend study from the Brian Holden's Institute stating about the prediction of the prevalence of myopia in 2050. But there's also a publication in 2025 where they did a systematic review and meta-analysis in China with projections from 2020 to 2050. They found the prevalence of myopia and high myopia, and they also projected prevalence for overall myopia and high myopia in the different years. So if you look at this graph from 2020, 2030, 2040 to 2050. So they divided it as urban population and rural population. And if you look at the urban population, for example, we see that from 2020, from 40% myopia prevalence is going to increase to 63% in 2050. And high myopia from 6.2% to 18.8% in 2050. So it's much higher in the Asian country data. So we also look at another study where it's the Claire study again. Here they found that the Asian American children significantly progressed much faster compared to their other ethnicity counterparts. Another study from Tanzania, a hospital-based study, they found that 4 factors remained independently associated with progression. So one was the age. So older children, more than 13 years, were protected. That means the younger kids progressed faster. And also there was increased risk if the children had more than 2 hours of near work per day, or if their TV viewing distance was less than 2 meters, or if they had a positive family history. Other factors like environmental factors, let's look at near work first. So we all know, we've seen it in the clinic, that intense near work is definitely a risk factor for myopia. We've seen that practically in our clinic post-COVID. But this has been recorded even as early as 1813 and 1886, where they saw that once there was a shift to advanced study and rigorous curriculum, they found that the prevalence of myopia increased. And also in 1969, they documented higher prevalence among school children compared to their parents and grandparents. And the other 1993, the very famous study from Israel, where they significantly found that the male Orthodox rabbinical students who were forced to do 16 hours of reading every day ended up with myopia as compared to their female counterparts. So near work definitely has an effect. Another study in 2020 analyzed almost 4,000 Taiwanese children, and they found association between progression and 2 behaviors of near work. One was if the reading distance was less than 30 centimeters, and if the near work duration was 30 minutes and more, then the progression was much faster. Also, a study from India showed that children progress faster if their near work per week was 42 hours when compared to spending less than 35 hours. So progression was happening. So next factor is the time spent outdoors. Yes, a lot of cross-sectional studies and longitudinal studies all showed significant association between increased time spent outdoors and reduced myopia incidence. Also, randomized controlled trials, 2 from China, 2 from Taiwan, showed that incorporating 40 to 80 minutes of recess time outdoors reduced myopia incidence significantly. But the 2017 systematic review suggested that the increased outdoor time is effective in preventing onset of myopia, but it's not really effective in slowing the progression once the eyes have already developed myopia. Another factor is seasons. There are many studies which show that there's also a change in the progression, the rate of progression of myopia in different seasons. So they found that during winter months, the progression was faster. So this was not just in the cohorts where they wore single vision or regular glasses or correction, but the same pattern was also shown in groups who were undergoing myopia control intervention. So the pattern was the same. In summers, they progressed less. Genetic factor, you're well aware of this. Parental myopia is an important risk factor. But it's not just one. It reflects both the genetic influence and the lifestyle factor. So there's a concept known as genetic nurture, which describes how parents influence the traits through the environment they create. So children with myopic parents are more likely to grow in an environment that encourage activities like reading indoors, more time spent studying than spending time outdoor. This increased the risk of myopia. And there is some research also suggested that purely genetic contribution from parental myopia is just about 5% of the variation of the child's refractive error status. So this estimate that we usually use in the clinic, that if one parent is myopic, the risk of the child developing myopia increases 3 times, and if both parents are myopic, increases 6 times, helps, but it's not entirely significant because this doesn't take into consideration the level of myopia in the parents. So nowadays, they say that the polygenic risk scores, which combines information from many genes, can explain around 20% of the variation and therefore is a more powerful tool in predicting myopia risk. So some takeaways from this, just that we need to keep in mind certain factors, even for the progression of myopia. When we see patients in our clinic, we just need not look at the risk factors for incidence of myopia, but we need to keep in mind factors like the age. Earlier the child presents with a higher level of myopia, then it's definitely we need to intervene with myopia control measures quicker. Keep in mind the level of myopia, keep in mind their lifestyle, working distance, also the seasonal variation. So if you're examining them in summer or winter, keep that in mind, and the gender differences. So that will help us offer the best visual hygiene advice and myopia control measures for our patients. So thank you so much, and we'll meet again at the panel session after the next talk.
Thank you, Irene Sophia Joseph, for that excellent and insightful presentation on patterns of myopia progression in childhood. Now we move to our next talk, myopia in the Middle East, prevalence, risk factors, and regional insight. It is my pleasure to invite Dr. Muteb Al-Anazi from the Kingdom of Saudi Arabia. Over to you, Doctor.
Well, hello, everyone. I'm pleased to be here today with you to share with you this presentation. My name is Muteb Al-Anazi. I'm an associate professor at King Saud University, the Optometry Department in Saudi Arabia. And I'm also a board member of the Saudi Society of Optometry. So the myopia in like anywhere else in the world, in the Middle East, we experience the increase of myopia and myopia prevalence. And as we see that the urbanization and the near work, the main factors that drive this increased global prevalence of myopia, as we know, it's expected to be 50% of the population by the year 2050. And we've seen a lot of changes in the Middle East as well and the rest of the world, but the prevalence is still lower than if we compare the Middle East region in terms of the prevalence of myopia to for example, the East Asia. We've seen the prevalence is still lower, but it's rising. So if we look at the recent studies, it's the systematic review meta-analysis study that was done on children aged between 5 and 17 years old, and we found that about 6% of these children from these studies are myopic. This puts the rate of myopia or the prevalence of myopia at moderate prevalence compared to high rates that we've seen in East Asia, like from the 40 to 80%. If we look at the method or the gold standard for diagnosis, usually we use cycloplegic refraction for diagnosing myopia. We've seen there are higher pooled myopia prevalence with the cycloplegic refraction, which is about 6.33%. If we compare the cycloplegic refraction, the methods, we've seen the lower prevalence, which suggests that non-cycloplegic underestimates the rate of prevalence or the prevalence of myopia in children. So there are some studies that we've seen different prevalence of myopia in different regions of the Middle East in children. And we've seen the rates that from 4% all the way to 14%. There is one study in Egypt that showed the prevalence of 55%. It could be related to the diagnosis method and the population itself. If we look at the young adults and adults, also we see some variation. These are some young adults and adults have been in these studies. If we look at the medical students, we've seen these students or this population, they have significantly higher population compared to the general population of adults. For example, in the UAE, it has the lowest because of the adults older than 40 years old. So the prevalence of myopia in the Middle East is definitely rising. It's in a moderate range right now, but it could be at a higher rate. If we looked at now we're going to move to the factors. In general, when we talk about the factors, there is a very important question that we ask ourselves: is myopia driven by genetic factors or environmental factors? And there are several points to discuss here. So if we take a look at the evidence of genetic influence, we've seen there is a lack of strong genetic evidence, and there's no causal gene has been identified in the studies. But if we look at the evidence from environmental influence, we've seen there is the myopic epidemic increase, a fast increase in prevalence. That's one of the important evidence. And also we've seen the experimental models on animals, different animal models, that we've seen image deprivation, that we can change the ocular growth in these animals by introducing the stimulant that will environmental stimulant that will change their ocular growth. And also the proven efficacy of myopia control treatments that we've seen, or we have several or many clinical trials that show significantly clinically meaningful myopia control effects. And this is evidence that support the environmental influence. So that brings us to the question: is it just environmental or is it genetic? And I think the answer is an interaction of both. We cannot just ignore entirely the genetic component, but we have to think at it as all the factors at once. So here are the myopia, the myopia risk factors. If a child have the genetic factors, either like a parent or both parents are myopic, that child, their eyes are more susceptible to environmental factors. If they get exposed to environmental factors like near work, they're going to be susceptible to that effect. They're going to have myopia at an earlier age, and also the myopia progression is going to be significantly more than a child with no family history or no genetic component of myopia. So you usually think about the myopia risk factors as a genetic environmental interaction which is the interaction between the genetics and the environmental, which drives the development of myopia. Going back to the Middle East, if we look at the genetics, there are several studies that suggest the positive family history is one of the strongest predictor And also in a study that was done in the UAE, medical students with the first degree relatives, they have about 7.6-fold greater likelihood of having myopia. And talking about gender as well, females have slightly higher prevalence, as we've seen in the studies, about 7.25% compared to the males who have 6% of myopia prevalence. Female students tend to have threefold of higher risk of having refractive error than males. If we looked at the environmental factors, there are several factors to talk about. For example, the urbanization, that we've seen the change in the lifestyle in the Gulf area and also in the Middle East. The near work, screen time, there are studies showing the increase the screen time. For example, in the medical students in the UAE reported like about 93% they're using electronic devices more than 5 hours per day. And also on top of that, we have outdoor deficits, which means the time outdoor is known to be a protective factor against myopia. For example, in Saudi Arabia, there is 88% of children in recent studies shown that to have insufficient outdoor time. So the question is like, why is outdoor time is reduced in the Middle East? Why they do not have the children more outdoor time? There are several factors to that, or several reasons. So we have the extreme climate. So if we're talking about the Gulf region, also the Middle East, there are the majority of the year, I would talk about maybe half of the year, a bit more, that the climate or the temperature gets exceeding the 40 degrees Celsius, which makes it a bit difficult to play outside for children. Also on top of that, there's air pollution and dust storms. Also, the urbanization that we talked about makes there is less safe green spaces for outdoor activities for the children. Also, the traffic, especially in major cities, the traffic concerns usually make the parents prefer the indoor versus outdoor for their children. Lifestyle and cultural, now we have seen the screen-based entertainment, the academic pressure, all that, and also the effect of COVID-19 pandemic that we still see until this day, that online learning become more normalized, and these habits are very slow to reverse. So the pandemic effect is we've seen that makes we shift now to a distance learning, and also that studies have shown that during the pandemic period, that we've seen children have a significant acceleration of myopia progression, and that's been reported in several studies as well. There are other factors also to explore, and in my opinion, I think sleep is one of the important factors. And for example, the sleep that we know sleep or short sleep duration disrupts the circadian rhythm, dopamine release, and regulation, and that can affect the ocular growth. And there are some studies that linked the less sleep with higher myopia, but the data are still limited. So, for example, if we take a look at children in Saudi Arabia, there are several studies reporting that 70% of children do not get sufficient nocturnal sleep. 70% also have bedtime resistance. Almost 60% have sleep onset delay. And this is, on top of that, they have significantly increase of screen time, which is associated with the sleep problems. And this is worth to look at these problems, especially with the sleep pattern, to see how that will affect myopia development and progression. Also, another point is diet and nutrition. We've seen our diets, especially for children, change so much in the last few decades, and I think this is a very important research area to explore how is that going to impact the ocular growth and myopia development. My last point here is to talk about the eye healthcare perspective. So we did a study in Saudi Arabia to see how is the perspective from eye health cares, specifically optometrists. So we had a survey of surveyed about 175 optometrists to see about their knowledge, their practice, their diagnosis of myopia, the treatment they're providing, and what are the limitations. So the term of the knowledge versus practice, the awareness of myopia is high among the optometrists, but the adoption of the evidence-based treatment for myopia is low. For the diagnosis, about 60% uses cycloplegic refraction, which is the gold standard, but 40% do not. And about 40% do not perform any ocular biometrics, which is very important for tracking progression. For treatment choices, 2/3, they still use a single vision spectacle as a primary management, and 80% recommend the outdoor activities as a primary treatment. For the adoption of treatment barriers, lack of experience and insufficient supports were ranked to be the highest barriers reported. In conclusion, myopia in the Middle East is still in the moderate range, but shows clear rising trend and a significant variation within countries. There are key factors that includes the genetics, for example, family history, gender, the female, and also rapid urbanization, leading to reduced outdoor time and increased near work. The COVID-19 pandemic accelerated the growth of myopia progression. There's a significant gap exists in the practice with the adoption of the advanced management strategies is low, and also due to the lack of experience or support. Multi-pronged approaches are needed in this region for example, public health campaigns, clinical protocols are standardized, and also enhance the practitioner training that should address these problems and help with the myopia management in the region. One of the positive steps that have been taken is the establishment or launching the Myopia Arabia org is a platform launched by the Saudi Society of Optometry that serve the region. So the goal is to make it as a platform for the region for the general public, as well as connect them with the eye care professionals in the Middle East to provide with the knowledge, also to provide with the services that are needed in this region. And thank you very much.
Yes, hello. Hello, Dr. Alanazi and Dr. Encampria.
Hello, good to see you.
Wow. Good to have you here for this session. And just a few questions to discuss on the topics we discussed. I know it's just a couple of topics, so it's going to be quicker. For Dr. Encampria, so you were talking about, very important topic about public health and myopia in the, globally too. So we're looking at screening models. Do you think there's a cost-effective screening model you can suggest or something that's happening in your region?
Well, unfortunately, where I'm practicing, I currently live in Mexico. We don't have a program, for my understanding, we don't have a program that has been applied recently. What we have been doing is programs in schools, in children, during every once a year. There are campaigns, optometric campaigns, where they refract children and discover if they have any refractive disorder, no? I still don't know if there's one screening procedure that works best from all the others, because as I was presenting, China has been leading the programs to detect myopia in schools. They have been doing searches, they have been doing screenings twice a year in the schools, and that may have been something as a game changer. But I don't know if there's one single method that may work among the others.
All right. Yeah, that was also in my list of questions. So what is your recommendation for frequency of screening? I'm sure when the prevalence is much higher, twice a year is also a very good option. But I truly believe if there's a nationwide method followed on a regular basis, especially for school children, I think that will help. And Dr. Alinazi, is there a practice method for screening in Saudi Arabia?
So thank you. I think my answer is very similar to there's no national base screening. In the school, before the child goes to school in the first grade, that's been enforced by the Ministry of Education that they get their eyes checked. So we're trying to, as the part of the Saudi Society of Optometry, to have this eye exam to involve more than just checking for visual acuity, for example. In terms for maybe that would be a way to get more data about the prevalence of myopia and the level of myopia in children. And that's what we're hoping for, yeah.
What I do in my practice, what I do also in my practice, usually when I have a small child or young children, I usually use optical biometer too. So besides cycloplegic refraction, I always, independently the amount of myopia, I use twice a year or maybe between once or twice a year, an optic axial length measurement.
True. I think as clinicians, we can totally incorporate this in our regular day-to-day practice. I do myopia management on, almost like 80% of my patients undergo myopia management. So many years before we started incorporating measurement of biometry into regular clinical practice, not just if you're looking at myopia or no, even pre-myopes we can pick up if you're going to include more number of examinations, especially the axial length elongation measurement. That's an excellent point. And about the studies happening, Dr. Lanazi, you gave a lot of data. That's very good to know about the regional data. But I still think there's a lot of work to be done in terms of research in the region, especially even prevalence. You must have seen that there's a very few number of studies available currently, right? And I'm sure as a group, as an educational institute or as an optometry organization, are there any research happening in terms of more prevalence studies, not just in the country, but in the region?
I'm not aware about the entire region, but in the country of Saudi Arabia, we have attempts to have a national based study for studying the prevalence, because all the attempts that I read about the prevalence of myopia, it's either area specific for inside Saudi Arabia, or it's about a specific group of people.
Hospital or
yeah,
group of
hospital based or university students, or it doesn't give you the full picture.
True.
So there is an attempt right now to have a national base that's for Saudi Arabia. I don't know about the region, because you have to have all these countries all together, and then you have the efforts. It's a lot bigger effort.
I think every country needs to do that, especially in the Middle East region. We do lack a lot of data on that. So I think that's very important to do more research. And other specific question I had was talking about guidelines for awareness or myopia management. Again, do you think a region-specific guideline will be mandatory? Any points on that?
For guidelines, so
For awareness of myopia and for management guideline.
Yeah, the example that I mentioned is the myopiaarabia.org. It was launched about less than a year ago. We are trying to make it the platform for practitioners as well as the patients, the parents, who anyone has a question about that. Also, we are listing all the products, and it's still, if I did a study that I showed in my slides that it was in 2000, published in 2023, and I think if I do it again right now, I will have a significantly different result, because the awareness has not maybe among the population, but certainly among the eye care practitioners, they have more awareness about myopia, the available treatments, and then in the market of Saudi Arabia right now, we have many options. If we talk about 4 years ago versus now we have more options that are available to be prescribed for our patients for myopia management than before. So it's just changing rapidly.
I think that's the same case with UAE. So definitely awareness among clinicians has improved a lot. And we also mentioned in both your talks, you mentioned about the awareness of the clinician in terms of upscaling your skills. So you said about the perspective of the optoms, and Dr. Encampria spoke about, getting more knowledgeable in terms of management, right? Before you even incorporate the method, you need to know the method by yourself as a clinician. So that kind of education among clinicians also is very important. I think platforms like this and many other sessions are helping with that.
Definitely.
So thank you so much.
Thank you.
And Rahila, I'm not sure if you're part of the discussion, or thank you for your talk. Excellent about your, your product and the science behind myopia management. So yeah, thank you.
Yeah, it's always good to know what what you're prescribing to understand what's best for patients. I always say what's best for our patients is best for our patients. And we need to use our toolkit and just do the best for them and manage myopia because, as we all know, it is a public health issue at this point.
Sure, true. All right, thank you.
Thank you.
Thank you.
Thank you, Irene Sophia Joseph, and all the speakers of this session for such an insightful and engaging discussion. We now move to a special session by Zeiss Vision Care MEA. It is my pleasure to invite Dr. Ali Abdul Razak Al Mifraji from the UAE for his talk,
Zeiss MiyoCare.
Real Life Performance. Over to you, Doctor.
How are you? It's a pleasure to be among an amazing group of people to discuss about a very important subject, or we could say a global crisis now emerging. I've been listening to amazing talks since this afternoon. I'm so impressed that the world has come together. So welcome to beautiful Dubai. In spite of everything, we continue to fight and go on. Now, let's give you some real insights about real life performance about myopia. Today, I'm going to talk about how the global crisis emerged, a little bit brief history, and the effect of COVID-19, reaching up to the end, where we choose some real life cases that we succeeded with Zeiss MiyoCare of different perspectives. So starting with the global crisis. Now, previously, during when I was a medical student, when I was a resident, not far away, like 10, 15 years ago, we used to describe myopia as a refractive error, nearsightedness that occurs when the eye grows too long or the cornea is too curved, causing light to focus in front of the retina. This is what we were taught, and what we used to tell our patients. But by the global crisis that was just stood out by the WHO, it told us that by the year 2050, 50% of the world's population will be myopic. That's about 5 billion people. Now, this changed the whole definition. Why? Because it's not just about thicker glasses. It's about what happens with it. You've got 10% risk of retinal detachment when you've got more than -6 diopter of myopia. We've got a 40% risk of myopic macular degeneration, in addition to the glaucoma and cataracts. Now, this, as I said, led to the shift of the definition from correcting the vision to managing the eye growth. We mentioned this. This was published by the Singapore National Eye Center. It's an amazing astronomy study that just shows you the more we go with the numbers, the more the complications that will happen to our kids. Of course, all the data are telling us that we're shifting towards the myopia. So after all this data, should we worry? We were just looking about the tip of the iceberg, while the hidden pathology was hidden just under the iceberg. Let's give you just a brief history of how we used to manage myopia. So pre-2000s, it was just about single vision glasses. Just give your kids glasses and go and let's see him after 6 months, 1 year, whatever. And we had the undercorrection myth. Historically, some practitioners, they undercorrected prescriptions, mistakenly believing that it will slow the growth, while researchers after that have proven otherwise. Also, the paradigm shift, now my medical condition. And in addition, that we have new tools. We have heard a lot this afternoon or this evening about the new tools that we need in our clinics in order to manage myopia correctly. So we saw the previous talks that I will go through this very briefly, that the age range for normal axial length per year, this is very important for us to know, that 6 to 9 years should not be more than 0.2 millimeters per year. The more we grow older, this axial length shift will decrease. Reaching up after 13 years should not be less than 0.05 millimeters per year. In myopic children, we have fast progressors that may exceed 0.3 per year. We have to know that every 0.1 millimeter increase in axial length, this will increase minus 0.25 of myopia, which is a huge number. That means every diopter will increase 2.5. So all what we're talking about today, whether practitioners, whether opticians, optometrists, ophthalmologists, pediatric ophthalmologists, it's about trying to get the axial length slowed down. Now, this time, 6 years ago exactly, we were locked down and we were giving online lectures just as we are now. We were attending online meetings. I remember every day logging into the WSPOS lectures every Saturday. But what this led to our children, it led to the digital glue effect. Children, they were locked down, they could not spend time outdoors, and they were glued to their devices. And this led to loss of the protective factors, the homeschooling, the online schooling. It's removing the protective dopamine hit that the natural sunlight will provide for our retina. Now, we remember all these images when we were struck by COVID-19. We were confined home, and the children looked up to us. We were glued on our devices, and so were they. They went back to school, but online schooling resumed till now, till this day. In Dubai, there is online schooling. When we tried to take it away from them, the dopamine went down, the child became angry with us. Believe it or not, I have seen toddlers of the age of 7, 8 months carrying a mobile phone or an iPad just like that. No one knew the hazards behind all this. And after 6 years, we should really know. So how would we manage? First of all, behavior. The power of sunlight. We should aim at least for 60 minutes to 120 minutes in natural sunlight. Also, the working distance. Try to avoid keeping the screen close proximity. These lovely handouts from the myopia profile, I still now give to the families. Spending time outdoors, the 20-20 rule, the elbow rule, the 2-hour rule, which is very important. This is what I usually tell all my patients, more than 2 hours on the screen after schools. Now, the screen time rule limits. Just today, before I came to you, I had the child who was 1.5 years of age carrying her precious iPad with her in the pram, in the trolley. So at under 2 years of age, no screen time at all. 2 to 5 years of age, 30 minutes to 1 hour is the max. And 5 to 17 years, 2 hours. Now we know very well this is not the reality we are in now. Even with our kids, we cannot oblige them to go less than 2 hours per day. So let's deep dive into how to manage. First of all, we manage with behavioral foundations. Now, the second solution is the optical solution. The first thing we do is the optical management. And here we jump deep, and we're diving deep into the Zeiss MiyoCare. Now, the Zeiss MiyoCare and the MiyoCare is unique. It uses cylindrical annular refractive elements with concentric rings, and these rings, they are aimed in order to slow down the progression or strike the hyper opaque shift or reduce the hyper opaque shift that happens with single vision glasses. It has proved a 70% reduction in the axial growth average, and it is available in two designs, the MiyoCare and the MiyoCare S for older children and teenagers. Now, the Care is very unique because it consists, in addition to the annular cylindrical microstructures, as you can see, so it provides the myopic blur to the peripheral retina, and at the same time, it provides a central zone. Now, how unique it is, it's this, the functional zone between the cylindrical annular elements and the fill factor, this functional zone size and the correction zone. This is unique for the Care technology. All the RCTs that were published showed a very good reduction, very good adaptation, and very good near and distance vision. And continuing with the RCTs, the largest published study, over 1,500 children with multi-center trials, showed that was in China, where we know that myopia is mostly prevalent there. It showed that the clinical trials, it was safe, it provides very good slower progression. Now, let's go to the other optical surgeries that we have. Of course, just before I go, I should mention that it's not only Zeiss MiyoCare, it's the other lenses too. But these are the ones that provided, and they provided efficacy, and this is what I was talking about today. Going to the optical management, the MiSight have also proven very good efficacy in children, in older children, especially teenagers who do not like to use glasses all the time. In addition to providing free from glasses during the day, whether to perform sports, in addition, they will provide good vision and slow down the myopia. Ortho-K, we listened to Irene about the Ortho-K and how effective it is, especially if your child does not like to wear the glasses, do not like to wear the contact lenses. It will also provide, it has proven that it does provide very good results in slowing down myopia and glasses free during the day for the children at school. The low dose atropine, I know it's not available in many countries, but for those who have it, you are lucky. I would say you are very lucky because it can be used alone. It has many doses, 0.01, 0.025, 0.05, and it can be used alongside the MiyoCare, the MiSight, and the other glasses that you can use. Now, as I said, the market has 3 or 4 main lenses. All have proven their efficacy, whether the ones from the Stellest, from Essilor, whether the ones from the MiyoSmart, from Hoya, and the Zeiss MiyoCare, and also the other companies that are emerging. So why do I choose MiyoCare over the others? I'm not saying this is an advantage, but it is an advantage that is unique for Zeiss. First of all, we already mentioned that it has very good clinical evidence and effectiveness. Number 2, the adaptability. I would say they are very, very adaptable. Very adaptable. Within days, the child just clicks with them. The unique technology that reviews that balance between efficacy and effectivity and wearability. So this this Care technology, as I said, is very unique. Number 4, the main concern for all the families, even here in Dubai. The first thing the family asked me, what's the cost, doctor? And I would say that Zeiss has gained a very good reputation and very good competition among those, giving it a good brand with a very, let's say, reasonable price. In addition to that, it gives warranty for the power change, for scratches, and if the child is not adapted, it just switches into the other. And which is more important, the customer care, the partnership, and I believe that all the companies should have this. What's more important than giving the glasses is to follow up the child after the glasses. Sometimes, let's say most of the time, the families, they adhere most to the optician or the optometrist or the optical shop, rather than bothering themselves on coming to the pediatric ophthalmologist. So they should provide very good support for the families and follow-up, and providing them with the good knowledge about the glasses that you should give. And that's what we sense with the MyoCare for the last 3 or 4 years we've been working with. Let's give you some real insight and real cases about the MyoCare. So our first child, he's a teenager. He's 14 years old. Of course, he'll use the screen 4 to 6 hours between school and after school, limited outdoor activity, and has academic needlework. So at 2022, he was 10 years of age. His refraction was -1, axial length 24.2 millimeters, and he was using single vision glasses. Then next year, 2023, he became -1.5. The axial length grew to 24.45, and we started Atropine with him. At that time, the family did not want to start with the MyoCare. It was not available in the market, actually, here in Dubai at that time. 2024, he is 12 years. Although the growth should be less, he jumped to an increase of -1 diopters, increasing the axial length to 24.95. Now, this myopia progression happened despite what? Despite using the Atropine drops, which was surprising for me because usually children responded very well to Atropine. So we started the Zeiss MiyoCare at 2024, 2025. It was around this time. He was 13 years of age. And we gave him the MyoCare S from the start. I was hectic about using the MyoCare. Maybe you won't adapt to it. It's something new. So 2024, 2025, I just examined him 4 weeks ago. It has stabilized, and you've got only 0.2 millimeters increase in the axial length. So what do we, the bottom line for this, early myopia progression between 22 23, it was around 0.5 diopters per year, axial length more than 0.25 millimeters. This is a typical pediatric myopia progression. Starting with the 0.01, which we don't have here in Dubai, the family got it all over from India. In spite of that, the myopia progression increased. We could not find the 0.05. So as I said, with the high digital device exposure, the low outdoor activity, we started the MyoCare intervention with the MyoCare S. As we can see, the numbers speak for themselves. Axial elongation was only 0.07 over 2 years. This is less than even the physiological progression. And the expected axial elongation for this age group should be 0.2 to 0.3 millimeters per year if it is left untreated. That is more than 1 diopter per year. Let's go to case number 2. This is a 15-year-old female, also a teenager. She was wearing single vision spectacles for 3 years. Moderate needlework, girls tend to be more obedient than boys. And the daily smart use is only for 3 hours per day. Same thing, single vision glasses, 2023, 2024, she continued. The family did not approve of using any myopia management. 2025, last year, I initiated the MyoCare after the refraction jumped from 0.5 to 1.5. Then the family believed me that, yes, let's go on. Since then, it has been stable for a whole year with another only 0.2 millimeter increase in myopia. So the progression rate is consistent here. We've got it back to normal, to what it should be. This case will illustrate to you that single vision glasses, in my opinion, they do not exist anymore for myopic children or teenagers. They should be stopped. We should go on to myopia control glasses. Whatever is near you, whatever you're happy with, whatever works for you, you should go on for the myopia control glasses. Our last case is an 8-year-old boy. He came for an initial referral after blurring of vision from school. He could not see at the board for the past 3 or 4 months. Both parents were myopic and have underwent LASIK surgery. So we have a high genetic predisposition, and we have an increased newark and digital exposure. His unaided visual acuity was 6/12, both eyes. Cycloplegic refraction, I know we talked a lot about cycloplegia, was -1. Axial length 23.20. Anterior segment and fundus were normal. This is early onset childhood myopia. So we treated with Zeiss MiyoCare the hard type, the normal MiyoCare. And we told the family he should wear it fully because he's got strong family history. We increased the outdoor activity and we reduced the screen exposure to 2 hours. So the basic, after 6 months, we could see that he's remained at -1. Axial length 23.2. It increased just minimally, 0.04. Visual acuity remained 6/6. Adaptation was not just very good, it was excellent. Why is this case important? As I said, you've got a child with parental myopia, you've got high risk. Here you go on for myopia control glasses. Do not wait to give him single vision glasses until he progresses more. The same case, he had excellent adaptation, as I said. Finally, what are our take-home messages from my side? First of all, early detection, intervention in childhood myopia that are critical. Do not wait. Do not give second thoughts. Just jump in, be brave, and give the treatment. Single vision spectacles to correct vision, but they do not control the myopia. Stop using them. Myopia progression is influenced by genetics and environment. Genetics we cannot control, environment we can. Reduce the screen time, increase outdoor activity. The Zeiss MiyoCare, as we show, provides a peripheral myopic defocus, helps slow down axial elongation, and maintains a clear central vision, giving it a good adaptation. The most important thing is the regular follow-up. Instead of telling the child to come every year, every 6 months, no. See him every 2 months. Maybe you can collaborate with the optometrist you trust. He can go and see the optometrist every 2-3 months and come back to you every 6 months. That will be a good teamwork, and it will provide some sort of comfort for the family that both you and the optometrist are teamworking for the child. You're taking care of their child. This is what the family want to hear from you at the end of the day. Thank you so much. Thank you for everything, and I hope to see you soon. Bye-bye.
Thank you, Dr. Ali Abdul Razak Al-Mafreji, for that excellent and insightful presentation on Zeiss MiyoCare and its real-life performance. Now, we move to the second talk of this session by Zeiss Vision Care, Zeiss Myopia Management Collective, Next Generation Innovations. It is my pleasure to invite Dr. Peter Essig. Over to you, Doctor.
So, hello, everybody. Can you hear me? I hope that you can hear me and also see my screen. Perfect. All right. Also, thank you very much from my side to the UOF to have such a nice celebration of the World Optometry Day. And thank you also, Dr. Ali, for your really nice talking insights. It was really great. From my side, I would like to share with you the keynote of the day regarding Zeiss Myopia Management Collective. We can also call it Next Generation of Innovations. So what I would like to guide you through today is, first of all, some brief introduction. We've been listening quite a lot about myopia today, so it will be just a brief overlook. Continuing with some Zeiss Myopia Management Collective, what it actually is, why we have developed it. Further on, Zeiss MiyoCare as a fundamental pillar for further innovation. We will move on with foundations of the new lens, with the new lens design of Zeiss MiyoActive, and also be talking about the availability of the lens, and then some further tools of the Zeiss Myopia Management Collective. So the introduction, as we all quite understood, I would say so far, is that myopia really moves fast. Yeah, so the prevalence of the refractive error in children is really, really fast. We all know the famous statement of Brian Holden Vision Institute that by 2050, about 50% of mankind should be myopic. But the thing is that to avoid such bad scenarios, we need to start to act now. Yeah, so to tackle the burden of 2050, we need to act now accordingly. And why is it actually? I mean, it's been also said quite many times today. It's not about just the refractive error itself, which can be then later on corrected by any random minus lens and kiss the patient goodbye. It's more about the secondary eye problems, right? And we know that the over elongation of the eye then imposes a risk of a secondary eye disease, as for example, maculopathies, opening glaucomas, cataracts, retinal detachment, and so on. And in those cases, those conditions are then rather irreversible, right? So then it's much better to avoid it rather than to face it later on. If we take a look on the local data from the Middle East Africa region, we can actually understand that not only Asia alone has such threat in terms of myopia prevalence. So for example, here a study from Taif in Saudi Arabia covering more than 3,500 children actually found that 50% of children, or more than 50% of children, were actually having refractive error, out of which about 33% were myopes. The second important information is if they compare the prevalence of 7 to 9 years old to 16 and 18, the prevalence nearly doubled. Yeah, so just within a really short period of time, about 3 years or about 9 years, the prevalence doubled. Yeah, so even for us in the region of Middle East Africa, myopia is definitely a risk. And besides all of these risks, so to say, it also has a social influence, right? And we can again learn from China here what the consequences of myopia can actually be. And we know that in China, the prevalence and the consequences of this refractive error is so bad that the children of nowadays unfortunately have to study under such conditions behind a bar, yeah, so that they maintain a proper gaze position in order to slow down the elongation of the eye from near work. What is really cool to see, on the other hand, not just throw the bad news on you, but also some good news here, is that if we take a look on the percentage of patients using respective optical interventions over time, we will find out that the only myopia control spectacles, so really the designated optical interventions for myopia control, are the only solutions which are on the rise. Yeah? And all the others, which are rather inefficient, as for example progressive additional lenses or single visions with some undercorrection, are on the decline. Yeah, so it's really nice to see that the general audience of eye care professionals, but also the parents, really consider it as something meaningful and really helping the children with their vision, yeah, in the long term. So this is really great news. So yeah, myopia moves fast, so we have to definitely move faster than that to be able to tackle it. And this is why we are at Zeiss having Zeiss Myopia Management Collective. So what it actually is, it's a target to have Zeiss as a frontrunner in myopia management and a reliable road for all the healthcare professionals and eye care professionals to really guide the patient through myopia management in a successful way. So our goal is really to empower all the eye care professionals and healthcare professionals with comprehensive myopia management ecosystem we called Myopia Management Collective. Because we know that myopia management is a complex thing. It's a complex problem if we talk about myopia. There are many, many arguments why the eye actually elongates. We have seen or heard multiple of them today. So therefore, it rather requires a complex solution. And this is what we are calling Myopia Management Collective. So it's not about a single product, it's about a product portfolio. So here we are talking about a suite of products, solutions, services, really designed to outspace myopia, delivering the expert care that your patients deserve. And we will definitely come back through it. And now just make a step back and start with Zeiss MiyoCare, which has been for us a first microstructure lens for myopia management, as you all know, and it's considered as a fundamental pillar for further innovation as of now. So Zeiss MiyoCare, you of course all know it. We have seen a nice talk from Dr. Ali today on the cases and everything. So just briefly here, first to mention is that for Zeiss, it was our first microstructure myopia management spectacle lens, and actually first one available in the region of Middle East Africa. It has those circular elements on the front surface we call a CARE technology. CARE is actually an abbreviation for cylindrical annual refractive elements that are actually holding a defocus condition in order to shift the peripheral image in front of the retina. To maintain the good variability of the lens, we also have a clear zones in between those elements to preserve the variability. On the other hand, to preserve any sort of hyperopic defocus, meaning the image falling behind the retina, we also treated the back surface of the lens accordingly. There are two options, as you all know, MiyoCare and MiyoCare S. The first lens to go is MiyoCare, which can be considered also as a hard design. The lens is defined by the central zone diameter of 7 millimeters and 4.6 diopters of the defocus of the respective CARE elements. On the other hand, Zeiss MiyoCare S is like a soft design, which is then defined by 9 millimeters of the central clear zone and 3.8 diopters of the CARE elements. So just a brief dispensing guideline. I'm pretty sure everybody is aware currently about it. First way is to start with Zeiss MiyoCare, irrespective of the age. And then just in cases the children might have report some issues on adaptation as halo or glare perception, one can switch to MiyoCare S. And since it's covered with the Zeiss warranty, this switching is just for free. Both Zeiss MiyoCare and Zeiss MiyoCare S is also available as a stock lens for the price affordable option, as also Dr. Ali raised the concern that price might be the reason why not to start myopia management. Also, this has been taken into consideration here. So for the Zeiss MiyoCare lenses, just briefly, it's a product or it's a lens solution that has been quite a long time on the market. So by now we are already collecting 3 years efficacy data from the Asia and 2 years efficacy from the Europe. For the 3 years efficacy data, they will be presented at ARVO annual conference. So this, if you'll be in the United States in May this year, definitely don't hesitate to pass by. But also to mention here, Zeiss MiyoCare lens really can reduce the occurrence of fast progression of about 3.5 times. And as said, the product availability was here since 2022, first in China. And as mentioned, first microstructure myopia management solution by Zeiss. In terms of some data here, so first summary of 2 big studies we ran with that optical lens. One with the European cohort, which considered about 234 children ranging in the age 6 to 13. This study ran for about 24 months, and over this period of time, we have seen spherical equivalent reduction of about 0.4 diopters and axial length 0.22 millimeters. On the other hand, we also ran the study in Asia. Of course, we know that in Asia, the situation is a bit more dramatic because of the behavioral and genetical factors playing pretty much against us, but still we enrolled a big number of children to the study, also starting from the very young age to really push the lens more towards the critical part. And the 24 months data showed spherical equivalent reduction of about 0.4 diopters and 0.2 millimeters in axial length, respectively. Besides the reduction, which has been always reported, we are also taking care about whether or not the solution really accommodates towards an emmetropic target, right? And This is, for me at least, something which is more tangible, right? Because if you report just the reduction or percentage of efficacy, you are highly dependent on the group of the single visions, right? And since we are really not sure what's like behind the scenes, how the children really behave, you know, outdoors, indoors, or what is happening, I mean, while the study is going on, it's really necessary always to see whether or not the respective optical intervention really supports the normal healthy emmetropic growth. So that's why we here established the third column in each of those clusters, really reporting the emmetropic target for particular children based on ethnicity and the age the study was actually run for the respective for the two respective studies. So besides having this drop from single vision to MyoCare, we are really accommodating towards the normal healthy emmetropic growth. Yeah. So with Zeiss MiyoCare, the children's eyes grow as they should. In terms of adaptation, I think that Dr. Ali also talked about it, but just to have it here, some numbers about it. We've seen pretty much same sort of adaptation compared to single vision, and there was no really a difference in terms of clinical or statistical relevance between Zeiss MiyoCare S, Zeiss MiyoCare, or single vision. So more than that, we've seen that till 3 days, all the children really adapted. And thanks to all of this, Zeiss MiyoCare is the most prescribed myopia management lens solution in the region. So what more? We know that myopia management lenses have been shown to be clinically efficient, but also what we know is, from the clinical perspective, that the lenses have highest efficacy in the first year and then tend to temper with the ongoing time. So the fundamental questions for the further innovation I'll be talking about now is how to level up the efficacy, what are really the crucial insights we have gained here, and how to maintain the clinical efficacy over time. And this brings us to the chapter number 4, which is foundations of the lens design of Zeiss MiyoActive. So first of all, there are two key insights. And first is the sustained efficacy. Yeah. So as said, we know that the level of efficacy really tends to temper over time. Yeah. So the active stimulation here of the visual system is needed to reduce this sort of burden from reduced efficacy. On the other hand, high ceiling, or the high efficacy / anti-ceiling, let's call it, stands for a variety of interventions that have been shown to reduce the progression of myopia, while most of them are simply on par. Yeah, so we cannot see really a big difference. So to mitigate the myopia's potential long-term issues or health issues, interventions are needed that actively level up the efficacy. So the first foundation of the new lens design I would like to talk about now is the uniformity of signals. Yeah, and what do I mean by that? That the intensity, type, and the stimuli and the timing of the stimuli needs to be varied. Yeah, so we know that if there will be a uniform defocus, let's call it like the function or the defocus design over space and time, this will simply support the saturation. And this is the main reason why over a long run, myopia management simply decreases in efficacy. So to prevent this saturation and maintain efficacy. We can also have it as a link with normal muscles, that soreness is normal at first, but then our muscles will simply adapt pretty quickly. In the world of vision, we can actually make such an example with the blackboard. Yeah, so if there will be simply one word written repeatedly or a simple command over again on the whiteboard, for example, like here, print hello world, over time, we will see simply a decrease in the, or at the end, no activation of the neural response, and the firing of the neural synapses will simply decrease. Yeah, because the visual input will always be the same. To tackle it, If we change it a bit and stick still to hello world, but switch to console.log or printf or print, the command will simply be different if in any single time and space point. Yeah? So this is what we can call a dynamic stimulation, and the varying key signal, which is then the key to preserve from the saturation of the image. The second foundation of the lens design I'll be showing later is the gaze-lens intersection. And we've been studying here what is actually the eye movements like in children wearing these sort of lenses. And we've learned that they are big eye movers. Of course, the eye movements depend mainly about the activity the children are on, like walking outdoors, looking at the book, playing soccer, copying from a blackboard, and so on. But the distribution in all of those cases is really, really wide, which also gave us another piece of knowledge how to design the lens accordingly. Yeah, so studying here the gaze lens intersection with standard single vision and myopia management spectacle lenses has also been conducted here. And the third thing here, the third key foundations, or the, let's call it key characteristics for myopia management lenses, is something we have learned also from the past. Yeah, so in the first box, we know that the visual signals in the fovea are not really essential for refractive development, yeah, but rather the periphery of the retina really plays the crucial role. And secondly, the growth signals from the periphery, as said, affect refractive error development. And more importantly, also the size of the central zone really influences the clinical efficacy and variability. And with simultaneous competing myopic blur, signals for refractive development are directed towards the anterior part of the myopic blur. This is why we are shifting the image in front of the retina, and at the same time we are minimizing the hyperopic defocus from the clear zones between the elements. The journey towards the lens was a combination of more than 100 years of innovation in spectacle lenses, and namely in myopia management more than 20 years. We learned from our previous lens, which was called MyoCare, or which is called still MyoCare. Third pillar was then the elements delivered to myopic defocus with a varying signal at the retina. And for all of these, we first created 5 designs, which were then underwent in the clinical trial, working on the same principal mechanism, just with some mild changes to really see what is the best effective one. So I just wanted to show you the amount of effort and the amount of investigation and investment we do in terms of effort and thinking about it to really make it as best solution for your children as possible. I was talking before about the defocus, yeah, so in terms of gaze-specific defocus. So here we are having single vision lens, and if we let the eye to move behind the lens, of course, since we are talking about a single vision lens, there will be not really much defocus appearing here. If we take a look, on the other hand, about MyoCare lens, and again, we will let the eye to move behind the lens, we of course will be expecting some specific defocus. However, here the thing is that it's repetitive and uniform. Yeah, so the signal pattern is uniform over time. Yeah, so this is something we really wanted to tackle. And this is why the MyoActive comes to the game, yeah, because here, if again we let the eye to move behind the lens, the highly spatial variant signal will be present behind the lens. And also, if we move the eye within one element of the lens, which you will see on the next slide, even here we are varying the optical output of the element. Yeah, so there is really variety of the signaling towards the retina to really make the tempering of the efficacy as low as possible over time. And this is the lens. So you are now, one of the first who have ever seen it by now. This is called Zeiss MiyoActive. So here we are talking about a MOVE technology, which is micro-optical variable elements, providing randomly arranged elements of varying power for highly spatial variant and dynamic signal for an active retinal response. So this is the main target of the lens. So the key characteristics, again, is a dynamic stimulation by varying optical signal at the retinal, leads to active neural response for higher and sustained efficacy. So we've been the first one who really questioned us how to do it, and this is the solution. The second one, elements induce a myopic defocus that is varied at the retina. And the third one, clear zone, that stays at the same level as MyoCare, 7 millimeters, thereafter coming with a treatment zone. The mean surface power of the cylindrical elements here vary from 1.5 to 5.5 diopters, randomly arranged in the concentric layers, to really give you the unique spatial configuration of the stimulus in any given meridian. All other solutions will only support the uniform power profile. The fill factor here again stands at 0.5 to preserve the variability of the lens. Unfortunately, so far, I cannot share with you any scientific outcomes, although I would love to, because they look really amazing. But here comes my second invitation to the ARVO annual conference. So if you'll be in Denver, Colorado between May 3 to 7, everything will be shared there. So if you'll be there, please do not hesitate to visit us in May at ARVO. To give you just a small hint how it actually is, this is actually how the Zeiss MiyoCare appeared compared to the peers, showing a really nice reduction in terms of spherical equivalent over the 6 months randomized control trial. But at ARVO, much more will be shown. To gain the insights from both research and real-world use, the lens will be available at Zeiss Vision centers and experts starting from mid-April, starting in polycarbonate 1.59, with full warranty of power change, non-adaptation, and scratches and cracks. This will stay the same as for MiyoCare. It will be available from sphere 0 to -9, combined with cylinder up to +6. In terms of non-adaptation, one can again proceed with either Zeiss MiyoCare S or any sort of single vision lens from our portfolio, as said, for free. To complete the cluster of Zeiss Myopia Collective, a next tool will be the Zeiss Myo 200. So here we are talking about the biometer, which is designated to myopia management. So here we will receive the data of keratometry values and axial length measurements. It heritages the strategy of our IOL master. So the PCI standing for partial coherence interferometry, if I'm not mistaken, which has been considered as a gold standard axial length measurement. So this device has it as well. The key functions here are that the measurements are really fast, takes about 7.5 seconds. It's really comfortable for children. And by a click of a button, you get the axial length and corneal radius. It will have a 10-inch touchscreen and a hand joystick so that you can easily manipulate with it. Also, it comes with a full connectivity. So if you are a user of any other Zeiss devices, it will simply communicate with other Zeiss devices through our software. This device will be available from October 2026 at a very affordable price then. How the report then looks like, the device will support you on any sort of risk analysis, treatment effectiveness, data interpretation, categorization recommendation, and the consumer report. So you can also make the whole myopia management much more tangible for the parents. Another thing we are coming along with is the orthokeratology lens. So we know that not all children are willing to use spectacles. We are aware that not every kid can wear it. That's why Ortho-K is also definitely a next piece of puzzle to the whole ecosystem we want you to provide with. So this will be also available from us as a first ever in-house designed Zeiss contact lens ever made. What is very necessary again as well is a communication. So delivering the information, what is myopia about? What is myopia management? Why do you do it as eye care professionals? The crucial point is actually, I believe, not between now me and now you as an audience, but I believe in the clinical practice between you and the parents, right? Because the parents are then the decision makers whether they want it for the children or not. So this is also another thing, we are aware of it, and that's why we designed this sort of Myopia Kids Corner, which is a self-explanatory indoor installment talking about myopia management, talking about why do you do it, what is myopia, and so on. And to do everything in a rather playful way, we are also having our Pupilo mascot, who tries to keep all the children in a cheerful mood, although visiting clinics and hospitals. Education comes also first to all eye care professionals. So that's why also Zeiss Myopia Management Collective composes of various trainings to build confidence, enabling your team to deliver the exceptional care you actually aim for. Engaging training session keeps your staff aligned and informed, and our trainings modules equip professionals with the knowledge and skills for effective myopia management. So you just can jump on any sort of searching engines and search for myopia management in Zeiss Hub. It's just for free. Everything is certified, so you can simply go through this as well if you wish for. So the take-home message here from my side is that we as Zeiss established the Zeiss Myopia Management Collective to effectively fight myopia epidemic. It's a comprehensive suite of product, solutions, services to really outpace myopia, delivering the expert care that your patient deserves. Yeah. So it's really a bunch of things I wanted to guide you through. So if you are talking about MyoCare, MyoActive, the new lens, the Myo 200, or the educational portal, the Kids Corner, everything like this is for us a new way of understanding how a service to you should look like. And this is what we called Zeiss Myopia Management Collective. By that, I thank you very much for your attention. I hope you enjoyed it. And before the next speaker will jump in, I would like you to scan this QR code, please, because you can also play a short quiz with us today. There are, I think, 10 questions, mainly from today's talk of mine. So if you wish to win some nice prizes and spend some time on the Zeiss booth, please just scan the QR code and enjoy. Thank you very much all for your attention.
Thank you, Dr. Peter Essig, for that excellent and forward-looking presentation, highlighting the next generation of innovations in myopia management. We also extend our sincere gratitude to Zeiss Vision Care for their unwavering support and continued contribution to this event. We now move to a special session by Amico Group. It is my pleasure to invite Dr. Tanios Gerges for his talk, Alcon Toric Contact Lenses. Over to you, Doctor.
Yes, we can see.
Okay, perfect. So my name is Tanios Gerges, and I am the training manager for Amico Middle East. As you all know that Amico or Al Amin, we are the exclusive distributor of Alcon contact lenses in the Gulf region. And we're going to talk today about the contact lenses and in particularly about Alcon toric contact lenses portfolio. But before we start, we just want to re-highlight the importance of contact lenses in the life of our patients and in the life of our business and our practices. So we as eye care professionals, we have the main priorities of satisfy and retain our customers, plus is to grow the revenue and profit in our practices. And contact lenses in general will do both, because the contact lenses it's a great tool to improve the patient's life. We always say that eyeglasses is number one. Eyeglasses is my right hand. Everyone who needs vision correction, they should have eyeglasses. But eyeglasses is not enough in the life of our customers, in the life of our patients. So when we introduce contact lenses to the life of our customers, 80 to 90% of these customers, if we introduce the right lenses, they will report an improve of life, a better self-confidence, improve in quality of life. They will do a lot of diverse things that we all know about. So contact lenses and eyeglasses will provide the perfect life for our customers. But also when it comes to business, you know, when we introduce contact lenses to our business more and more, when we introduce contact lenses as a support again to the eyeglasses, we can report that 3 times, it can generate 3 times the revenue of a spectacle only patient. So in the life of our customers, when customers are using eyeglasses and contact lenses, they can generate to our businesses up to 3 times more revenue. So just, we always talk about this. Contact lenses and eyeglasses, it's a perfect combination for your business and for your customers. But again, when we talk in particularly about astigmatic customers, astigmatic patients, there is a bigger opportunity, because we all know that around 50%, actually 47% of our patients are astigmatic, but only 10% they are wearing toric contact lenses. Around 68% they are wearing only eyeglasses, and 22% they are wearing spherical equivalent contact lenses. Why we're doing that? We're doing that because there is challenges. We all know about the challenges of fitting toric contact lenses. We all want a contact lens that it will reduce the share time. It will have an easy fit. We need also to have the trials lenses available. We need lenses that provide comfort and stable, clear vision. And we want a good service from the supplier and from the distributors. So, but I want to, specifically talk about the 22% of people that they are wearing spherical equivalent. These people, they need astigmatism. They have astigmatism and they need toric contact lenses. But the majority of eye care professionals, they are fitting them with spherical equivalent for the challenges that we talked about. So if we look to the numbers, you all know that when we fit spherical equivalent contact lenses, even for low astigmatic patients, the studies is telling us that if we do spherical equivalent for astigmatic patients that have less than -1 cylindrical power, in good lighting, they are losing 3 letters. Imagine 3 letters. And when we dim the light a little bit, they're gonna lose around 5.5 letters. That means a full line. They're gonna lose it. They will not see clearly. So we are wasting our time when we fit spherical equivalent. And if we go to higher astigmatic patients, between -125 to -2 astigmatic patients, in good lighting and in dim light, they're gonna lose 11 letters. So the data is telling us these patients, regardless of the challenges that we have, if we don't fit them with the toric contact lenses, we're wasting our time and we're giving them a bad experience about contact lenses. Because when we don't fit them with the right lens, the experience will not good and they will not come back to our practice. So how Alcon will help us with the variety of Alcon contact lenses, astigmatic or toric contact lenses, how it will help you as eye care professionals to provide your customers with the right lens so they will have a great experience when fitted with toric contact lenses. In our portfolio, we have a technology called Precision Balance 8-4 lens design, which is the contact lens. It's the stability design that's gonna keep the contact lenses stable in all head position. Let's watch this quick video. Sorry, I need to reshare quickly. Sorry. Okay, I will stop sharing quickly and reshare with the sound. So okay, so let's watch this quick video.
Astigmatic patients don't have time to wait for their contact lenses to catch up with them. They need a lens that settles fast and gives them outstanding vision. The Precision Balance 8-4 lens design features stabilizing points at 8 and 4 o'clock for lenses that settle in just a few blinks, and with less than 5 degrees of oscillation. Alcon's portfolio of toric contact lenses offers your patients confidence-inspiring stability and outstanding comfort that lasts all day. So wearers can take on their day from any angle, confident that their contacts will stay in place. Offer astigmatic patients the ultimate stability of Alcon's Precision Balance 8-4 lens design.
So as we saw that Precision Balance 8-4 is across the toric contact lenses in Alcon portfolio. It's the same design for stability. And this design, it can fit up to 98% of wearer that will experience less than 5 degrees of oscillation in all head position. And again, this technology is totally different than the traditional prism ballast that we used to have in the market. We know the limitation of the traditional prism ballast, but with Precision Balance 8-4 lens design, it is engineered to work with the eyes blinking mechanism. It has scribe mark at 6 o'clock that allow for quick and easy identification under the slit lamp. It's stabilized at 8 and 4 o'clock to allow for a thinner area at 6 o'clock to reduce the lower lid interaction. We all know that the problem used to happen with the lower lid interaction and also with the neovascularization. Also, now with the Precision Balance 8-4, we can enjoy a wide prism-free optic zone for a better night vision, where people used to report, blurry vision during driving at night or reading small letters at night. Also, I want to show you also a quick video that shows that these contact lenses, which the most important thing, that it is stable in all head position. If we can see in this video, we fitted this lady with Precision Balance 8-4 Alcon toric contact lenses, and we marked the lens so we can see it in the naked eye. This lady now, she's in a normal position, the lens is stable. The problem used to happen is when we tilt our head. So this lady, she went home, lying on the couch, watching television, looking for her smartphone. Now, even in this position, the lens is stable and it's not moving. It's less than 5 degrees of oscillation, again, in all head position. Now she went to the gym, she's doing yoga, she's doing gymnastics. Even in this position, the lens is stable. And this is what the customer wants. This is what the eye care professional wants. They want a contact lens that it is predictable and it doesn't move, and it will give a great result. Also, what we offer in Alcon and in Amico, we are offering a lens that it will fit the same success rate as in the spherical contact lenses. 95% first lens fit even without trials. And for the remaining 5%, if anything happen, we in Alcon and Amico, we have something called satisfaction guarantee. So even if your customers or you're not happy from the lens, you can return it back and get another lens. So all of these elements will create, comfort for you, and it will create a great experience for your customers. Also, we're supporting our eye care professionals with a fitting tools. We call it Alcon Fitting Hub. So I highly recommend you all to scan the QR code on this screen, and it will lead you to a fitting hub where you can put any prescription and you just press calculate, and it will give you the right contact lenses that you need to order for your practice and for your patient. So this fitting tool is equipped with, a calculation prescription. Now you don't need, you don't need to do your own calculation. It's again to gain time and to gain share time in your practice. You just need to put your prescription there, prescription of your customers, and it will tell you the right lenses that you need to order from Alcon. It will give you all the options. So in Alcon, we have 3 great contact lenses. Now it's available in all markets. For your support, it's 2 daily disposable contact lenses and 1 monthly contact lenses. These contact lenses, it's not only about the technology of the stabilization design, but it also provides great comfort, great end-of-day result for your customers. So why is that? Because these lenses is equipped with something we call water innovation contact lenses. These lenses is basically, it will increase the water on the surface of the contact lenses, on the front surface where it's touching the eyelid, and on the back surface where it's touching the cornea. And the technology, we call it water gradient technology. With the water gradient technology is a great technology where nothing is touching in the daily total 1 for astigmatism, nothing touching the eyelid or the cornea beside a cushion of water. Also, it's equipped with the highest oxygen transmissibility in all toric contact lenses, a DK over T of 127 at -3, -125, x 180. And it inclusive also with something called Smart Tears technology. It is unique, only available in daily total 1 for astigmatism in Alcon portfolio. This Smart Tears technology, it's going to stabilize the pre-lens tear film. It's going to prevent the tear evaporation, and it reduces contact lens related dryness. We all know that dryness now is a big thing, is a big challenge for our customers and for our clinics, because the higher usage of digital devices, less blinking, more dryness. So now Smart Tears technology is gonna reduce the contact lens related dryness and is gonna reduce the usage of eye drops. So daily total 1 for astigmatism is our premium contact lenses in the toric portfolio. We cover up to 2,300 parameters, almost all the axes up to -225 power. So daily total 1 for astigmatism is the premium contact lenses, but also we have another daily disposable contact lenses. The name is Precision 1 for astigmatism. It comes also with Smart Surface technology, where the water reaches up to 80% on the surface with the core of silicon to provide a lot of oxygen. So this Smart Surface technology and Precision 1 for astigmatism is a great contact lenses, but with affordable prices. So for people who can't afford to pay for daily total 1 for astigmatism, they can always go for Precision 1 for astigmatism. Again, all of these contact lenses is equipped with Precision Balance 8.4 for great lens stability. Also, we cover another 2,300 parameters in Precision 1 for astigmatism. But we didn't cover only the daily disposable contact lenses. We made sure that we're going to provide also the monthly user of contact lenses, great contact lenses, a contact lens that all the eye care professionals, they can upgrade the old users of monthly contact lenses to Total 30 for astigmatism. Total 30 for astigmatism, again, it is equipped with the water surface, water gradient technology. It reaches up to 100% water on the surface, again, on the front surface and the back surface. So nothing is touching the eye beside a cushion of water. But in order to keep the contact lenses wettable from day 1 to day 30, because this is a monthly contact lenses, we added another technology. The name is Saligen. It's coming from 2 words, cells and intelligent. So the intelligent cells, we are biomimicking, imagine, we are biomimicking the epithelial cells on the cornea. So we created a contact lens with polymer nanofibers that it's mimicking the epithelial cells and the glycocalyx on on the cornea. So we have now a contact lens that it is similar to our cornea and is going to do the same job of the cornea, of maintaining the water and expelling all the lipids and the bacteria that is going to accumulate during the whole month. So total 30 for astigmatism, it comes with 4,392 parameters. So imagine now we have 2 great daily disposable contact lenses and a great monthly contact lenses for your satisfaction, so you can offer it to your patients and you can use it in your clinic. Let's watch this quick video before we wrap up.
Alcon's Precision Balance 8.4 lens design is engineered to deliver ultimate fit success by optimizing stability, comfort, and vision. The Precision Balance 8.4 lens has a unique modified prism ballast design with 2 stabilization points at the 8 and 4 o'clock positions. These have been optimized to work with the lens material, base curve, and edge design, keeping the lens in place and resisting rotation throughout the day. A scribe mark at the 6 o'clock position makes it easy to measure rotation to ensure a quick, precise fit. This design also minimizes interaction with the lower lid for increased comfort and stabilization, whilst maximizing oxygen transmissibility at 6 o'clock. When it comes to stabilization, thickness differential in the lens and eyelid pressure are key factors. Primary eyelid forces orient and stabilize the lens on the eye. Unlike spherical lenses, which have the same refractive power in all meridians of the lens, focusing light into a single point on the retina. Toric lenses have different curvatures in different meridians of the lens, oriented perpendicularly to each other. These curvatures correspond to the lens's cylindrical and spherical powers that correct the eye's astigmatism and ensures that light rays from all meridians are focused correctly, merging into a single sharp image point on the retina. No matter where you are and what you are doing, Alcon's Precision Balance 8.4 lens design offers outstanding stability, comfort, and vision, with lens wearers experiencing less than or equal to 5 degrees of oscillation. Now, there's no need to avoid low astigmatic correction. Offer your patients an exceptional contact lens experience with Alcon's toric contact lens portfolio.
So again, with this great diversity of toric contact lenses in Alcon portfolio, with the great parameters, with the satisfaction guarantee program, and with the lens that you can fit it as easy as a spherical contact lenses, there is no excuse now for us to offer the right lens even for low astigmatic patients, because again, our customers, they deserve the best, and our business is gonna create great loyalty whenever we offer toric contact lenses for our patients. The thing is, what are these opportunities? To whom we can offer contact lenses, and specifically toric contact lenses? Definitely for new wearers. It is our job. It is our job as eye care professionals to start the conversation with our customers. Our customers, they don't open proactively the conversation about asking about contact lenses. Why? Maybe because they don't know or they are afraid. It is our job as eye care professional always to offer the contact lenses itself as a support for the eyeglasses. Just offer it, and better response you will get from the customer. Do not wait for your customers to open the conversation about contact lenses. Let's be proactive, we as eye care professional, to open the conversation and to offer always the right lens. Also, the second opportunity is the upgrade. Still, in our markets, there is a lot of customers, they are using old contact lenses, old generation of contact lenses. It is time to upgrade them. People, they are ready to pay more, but they don't know. They don't come to ask for new technologies because they don't know about these new technologies. So it is our job to introduce these new technologies, give it as an option, because the new option is going to improve the life of our customers, and it's going to improve, again, the loyalty for our business. And we still have a lot of people, they are using hydrogel contact lenses, they are using eye drops, and all of these symptoms can be solved with Alcon new technologies in water innovation contact lenses. And the final thing is the masked astigmatism. There is a lot of people, they are using spherical equivalent. They don't have the perfect vision. It is our job, again, to rectify this, to solve their problems, and we give them the toric contact lenses to give them the full correction. All of these are great opportunities for our business, and hopefully with the support of Alcon toric contact lenses portfolio, we will be up to the challenge. We will be there to support you and to support your customers. With that, I would like to wish you a great event. Please stay safe in these difficult times, and thank you very much. Take care.
Thank you, Dr. Tânio Sgherghis, for that insightful presentation. We also extend our sincere appreciation to Amico Group for their valuable support in making this event a success. We now begin Session 10, Evidence-Based Interventions for Myopia Control. It is my pleasure to invite our first speaker, Dr. Elizabeth Chetty. Her topic, Addressing the Global Epidemic with Novel Clinical Approaches. Over to you, Doctor.
Hello, everyone. Today, I will be taking you through a few management options for myopia control and highlighting a few things you should consider for your patient journey. Before getting into the treatment strategies, I think it's really important to go through the terminology, as we often tend to use these terms interchangeably. The International Institute for Myopia, or IMI, put together white papers, which are evidence-based reports designed to provide consensus, clinical guidance, and comprehensive reviews of the rapidly evolving science around myopia management. The IMI report from which these definitions were taken from can be accessed from the QR code at the bottom left. Myopia correction is simply providing regular spectacles or contact lenses to correct the refractive error and nothing more. Whereas myopia control is going one step further by providing an evidence-based method of visual correction for myopia that will not only correct the myopia but also slow down the progression of the disease, and efficacy of the treatment must be tracked over time. It was best to define myopia management exactly as it was provided in the paper. It is an all-encompassing approach to managing the disease that does not just include correction of the refractive error and interventions to slow down axial elongation, but also includes risk assessment, early detection, lifestyle advice, monitoring of disease progression, and the management of complications. In light of risk assessment and early detection, it is necessary to define terms such as hyperopic reserve and premyopia. Hyperopic reserve is the level of hyperopia present at a specific age that could act as a buffer against the development of myopia. If that reserve is too low at a given age, then that may indicate a premyope. Keep in mind, this is demographic dependent, as evidence suggests that Asian children may require a greater hyperopic reserve than children of other populations to reduce their risk of developing myopia. Evidence from a study done in China suggests that a good hyperopic reserve for children under 3 years is more than +2 diopters. Children between 4 and 5 years should be greater than +150 diopters, and children at the age of 6 should be more than +1 diopter. This means that if a 6-year-old child has a refractive error of a +0.5 diopter, then they may be considered a premyope, and other risk factors should be considered. Along with determining the cycloplegic refraction, other risk factors should be considered when determining the likelihood of a child becoming myopic. Factors such as age, as younger children tend to progress faster. Genetics also play a role, as 2 parents that are myopic pose a higher risk factor than 1 parent that's myopic, or than no parent that is myopic. Limited outdoor activity and increased neowork also contribute to the likelihood of becoming myopic, as do certain binocular vision issues, such as increased near esophoria, for example. The more risk factors noted, the more likely the child will end up being myopic. If you are still uncertain in how to assess risk, there are great online tools available, like this one from the Brian Holden Vision Institute, which you can access with this QR code. Here we have a Caucasian 6-year-old little girl with a +0.250 diopter refraction and 1 parent who is myopic. According to this calculator, she would be considered slightly high risk. Remember to also take into account the environmental aspects, such as how much time she spends outdoors or how much time she spends working at near distances. Now, if we were to calculate this risk just by changing the ethnicity to Asian and changing the refractive error slightly to plano, you would see that the risk increases significantly. This reminds us to keep in mind that demographics should be considered when assessing risk. Now that we are clear on all the different myopia terms and we have established risk factors, we can move on to some of the myopia control treatments that are available. This is a summary of some of the most widely accepted myopia control treatments. We are actually really lucky to be practicing in optometry in this era, as there's so much more available to us today than there was just 10 years ago. So let's go through each of them in a little bit more detail. In terms of the premyope, there is a big push to diagnose premyopes, as there is so much clinical evidence available that supports the positive effects of delaying the onset of myopia. It is really important to do a cycloplegic refraction on all children. This is a strong indicator for myopia onset, as it aids in establishing the hyperopic reserve. The hyperopic reserve, along with age and other risk factors, can be used to determine if the patient may be a premyope. All children should be advised on behavioral and environmental changes that can be easily made, but those with a high risk of developing myopia may benefit from being considered for early treatment. Whether treated or not, premyopes must be monitored closely. In terms of spectacle lenses, the earliest forms of myopia control included undercorrecting, progressive lenses, and bifocal lenses. Undercorrection has been proven to not work, and in fact, sometimes it actually exacerbates the myopia progression. Progressive lenses have been shown to have the same effect as single vision lenses that merely correct myopia but does not actually control progression. Bifocal lenses, however, with a 2 diopter add and a 3 basin prism, have been successful in moderately controlling myopia. However, now there are so many novel design spectacle lenses available on the market that we have a much better effect on controlling myopia progression. So really, there's no need to consider the older options for myopia correction. Newer designs like the Holt and the DIMS work on the premise of slowing myopia progression by creating defocus or peripheral defocus, whereas lenses that do, like the dot technology, works by scattering light to create more natural contrast. In terms of contact lenses, orthokeratology is a long-standing vision correction option and has been shown to be effective in slowing myopia progression by the myopic defocus created by the reshaping of the cornea. The efficacy of this treatment has been shown to increase when used in combination with atropine. There are also many soft lens designs in the market, including center distance multifocal and extended depth of focus designs. However, the dual focus soft lenses are currently the most effective in controlling myopia progression as far as contact lenses go. In terms of pharmacological interventions, low-dose atropine works by altering retinal and scleral signaling pathways that control eye growth, ultimately slowing down axial elongation. While the ATOM study promotes the use of a 0.01% and the LAMP study promotes the use of a 0.05% atropine, the dose that is ultimately used will be dependent on what is available and the tolerance and side effects experienced by the patient. Rebound effects of the higher doses of atropine need to be kept in mind, especially when halting myopia control, because one may have to taper the drop rather than just stop it suddenly. Tapering can be done either by decreasing the drop frequency or the concentration of the atropine. Other pharmacological agents such as 7-methylxanthine, caffeine, and hypotensive eye drops have all been investigated for myopia control, but none of these agents have been shown to be clinically effective in slowing down the progression of myopia. Light-based therapies have become quite common these days. So repeated low-level red light, this is an emerging therapy that can be used either on its own or in combination with other contact lenses or spectacle lens therapies, but not with atropine therapy. Red light therapy works by using red light of 650 nanometers wavelength to help prevent the changes at the back of the eye that usually causes myopia to worsen. In myopic eyes, the choroid often becomes thinner and has reduced blood flow, which is linked to lower oxygen levels in the sclera. The red light therapy may improve blood flow in the choroid and and make it thicker as well. So by doing this, it can help increase oxygen supply to the sclera. As a result, it may slow down the eye from getting longer, and in some cases, it has actually caused the eye to slightly shorten. Blue light therapy for myopia control is a novel approach to controlling myopia, but is still in the experimental phase. It is currently being investigated in a smartphone-based virtual reality app. It targets melanopsin-containing retinal ganglion cells in the eye's blind spot to trigger dopamine, which is a neurotransmitter that helps to regulate eye growth. So long-term evidence is still required to endorse this as a possible myopia control therapy, especially with safety concerns around blue light exposure. So we've all heard the phrase that every diopter counts, and so does every millimeter. There's a lot of research out there, so I turned to the IMI report that summarized interventions for controlling myopia. You can access the paper with the QR code on the top of the slide. These bar graphs are generated from the summarized information provided in the report. So it appears that atropine and red light therapy have the greatest efficacy in controlling myopia. That being said, though, I think anecdotally as optometrists, the majority of us will still tend to prescribe the contact lenses and spectacle lenses that were created for myopia control. It could come down to availability of products, cost, patient comfort, and compliance. And if none of this was an issue, and if I was asked what therapy I would prescribe, I would always come back to my patient. I would prescribe whatever they will commit to using, because all of these therapies are great, but it will not work if it's not actually being used. Please always remember that prescriptions for outdoor time is free. Always remind your patients about the behavioral and environmental changes that should be made along with the therapy that's being prescribed. So how do we measure any successful outcomes? So the normal average axial length growth is around 0.1 millimeters per year in the normal emmetropic eye. The CLEAR study, for which you can use the QR code to access, further breaks down that expected axial length growth according to the different age groups. So basically, the axial length rate of growth should decrease as the child ages, and at full emmetropization, the eye should be around 23 millimeters or so, with differences between the genders. Abnormally high increases in axial length, which would be around more than 0.2 millimeters per year, could signal a higher risk of myopia onset, and children with axial lengths greater than 23.7 millimeters may also indicate a higher risk for myopia. The CLEAR study also showed that in their sample of children, the mean age of stabilization was around the age of 16 years. Keep in mind this is an average age, meaning that there were patients that were older, and that indicates an important point to remember in terms of thinking of our progressing young adults. So generalized success metrics indicate that slowing axial length to less than 0.2 millimeters per year or a change in refractive error of less than a half a diopter can be considered successful. However, that is relative to age. So for example, for a 14-year-old, you would want to see less than 0.2 millimeter change in axial length, whereas in a 5-year-old, a change in axial length of 0.3 millimeters may actually be seen as successful. In terms of research, success is usually measured if there's around a 50% efficacy when compared to the control group. So for example, if the control group increased by 0.4 millimeters in axial length and the treatment group grew by 0.2 millimeters, then the treatment would be considered successful. Overall, you would want to target keeping the axial length under 26 millimeters. There are also great tools available, like those found on the BHVI website, which you can scan the QR code to get to. I find these particularly useful to explain to parents the importance of myopia control. So even though we have over 30 years of data and evidence, there are still clinicians out there that believe that undercorrecting myopia in children is still an option. So to wrap up, I would say one of the most important key takeaways is that you should never undercorrect a myopic child. If anything, just try to fully correct it, even if you're not planning on doing myopia control. However, if you are not doing myopia control, it wouldn't be a bad idea to then refer that child on to somebody who is comfortable doing myopia control. And if at the end of all of this, you still haven't learned anything from me today, then there is one thing I can leave you with. These are all the links to fantastic resources. There's an overwhelming amount of myopia data out there, and these platforms are great at sorting through all of it and providing the most sound evidence and advice. Lastly, these are my references. So if you didn't manage to scan the QR codes, This is the list that you can look at. Thank you.
Thank you, Dr. Elizabeth Chetty, for that insightful and impactful talk on addressing the global myopia epidemic with novel clinical approaches. Now, we move to our next presentation, multifocal soft contact lenses for the treatment of myopia progression. It is my pleasure to invite Irene Gan from Singapore. Over to you, Irene.
Hi, I'm Irene Gan, an optometrist from Singapore. So today I'll be sharing about soft contact lenses for myopia management with special focus on multifocal contact lenses, like what they are, why they matter, and also how we can use them effectively in children with myopia. So as optometrists, we are no longer just correcting vision, we are actively managing long-term ocular health. Myopia is not just increasing, it is accelerating, especially in urban environments and across East Asia. And the issue isn't just that children need thicker glasses. Higher levels of myopia significantly increase the lifetime risk of retinal detachment, myopic maculopathy, glaucoma, cataract. So when we talk about myopia management, we're not just talking about clear vision, we are talking about reducing long-term eye health risks. Soft contact lenses work by imposing myopic defocus, essentially sending a signal to the eye to slow down the axial elongation. So they are also very practical, no frames, stable vision in sports, and high satisfaction in children. And the commercial landscape is expanding rapidly. We now have multiple designs and also options in the market. This slide summarizes 3 common optical designs used in soft myopia control contact lenses and multifocal contact lenses. So now let's go through them one by one. First, extended depth of focus lenses is also known as EDOF. The rationale behind this design is to improve retinal image quality across different distances. So instead of having a very distinct zones, these lenses manipulate higher order aberrations to extend the depth of focus. So what this means is practice is that the retina receive a more continuous range of focus rather than switching between discrete zones. So these lenses are typically monthly replacement soft lenses, and the optical profile you see below, it shows a smoother variation in power across the lens. Next, dual focus contact lenses. So these lenses is what we call the simultaneous defocus, and there's a central zone that corrects the child's distance vision, surrounded by concentric rings that provides additional positive power, usually around +2 diopters. And the idea is that while the patient sees clearly through the distance correction, the surrounding treatment zones create a myopic defocus on the peripheral retina, which helps to slow down the axial length. And these lenses are usually daily disposable lenses, which also help to improve hygiene and also compliance in children. And finally, the center distance multifocal contact lenses. So these lenses, it works slightly differently. They have multiple optical zones, typically distance in the center, and intermediate and near zones surrounding it. So the optical profile gradually changes in power from the center towards the periphery. So in myopia control, this design can create a peripheral myopic defocus, although it was originally developed for presbyopia corrections. So these lenses can come in daily disposable or monthly replacement options, depending on the brand. So if you look at the images at the bottom, the colors represent the power distribution across the lens surface, while the graph below shows the power profile across the diameter of the lens. So overall, although these lenses look familiar at first glance, but the optical strategies are quite different. So earlier we talked about EDOF lenses and how they extend the depth of focus. So the goal is to maintain usable vision while reducing the retinal thickness that may drive eye elongation or axial length. So this concept is not just theoretical. There is clinical trial evidence supporting EDOF designs, including studies from the Brian Holden Institute, as well as the SEED study conducted at LV Prasad Eye Institute in India. And on the right side, you can see some examples of the commercial lenses that incorporate this EDOF principle. So overall, EDOF represents another optical strategy in myopia control, using higher order aberration manipulation rather than discrete treatment zones. Concentric ring lenses is a very common design in myopia control soft contact lenses. So the goal is to maintain good visual quality while creating peripheral defocus to slow down axial length elongations. And these lenses are marketed as myopia control lenses for children. Another design that I discussed earlier is the progressive or center distance multifocal design. So in this design, the center of the lens corrects the distance vision and the plus power gradually increases toward the periphery. So this gradual increase in the plus power, it creates a peripheral defocus, which is believed to slow down the axial length elongation. And evidence also suggests that the higher addition powers tend to reduce stronger myopia control effects compared to lower adds. So for example, the Blink study showed that greater efficacy with high addition lenses compared to medium addition designs. So clinically, the challenge is to finding the right balance while delivering enough myopic defocus to control the progression without compromising distance vision or comfort. Myopia control soft contact lenses and most multifocal contact lenses are available primarily in spherical powers. However, some options do provide toric parameters. So now it is important to note that while these toric designs exist, they are not always specifically trialed in toric form for myopia control. But clinically, they provide an important pathway for children with astigmatism who otherwise might not be suitable candidates. So this really expands our ability to manage more patients, especially in populations where astigmatism is common. Now let's briefly review the key clinical trials that shape our current understanding of soft lens myopia control. First, the 3-year randomized controlled trial in children aged 8 to 12 at initiation. So the results showed that 59% less refractive progression and 52% less axial elongation, and compared to a single vision daily disposable controlled lens, this is clinically effective. Next, the Blink study, which compared high ad plus 2.5 diopter, a medium ad plus 1.5 diopter, and a single vision contact lenses over 3 years. The high ad group demonstrated significantly slower progression and reduced axial elongation compared to medium ad and single vision lenses. So this tells us something important. Addition power matters. And then we have the Brian Holden 2-year RCT, which evaluated lenses that either impose myopia defocus or manipulate retinal image quality through an EDOF concept. So both approaches slowed down the progression of myopia. However, greater efficacy was observed in compliant wearers, so which reinforces a clear clinical reality. Adherence is not optional, it directly influences the treatment success. Okay, now let's talk about the evidence landscape because that's where many misunderstandings happen. So you'll notice that currently we do not actually have direct head-to-head randomized controlled trials comparing one lens brand against another. When we talk about contact lens options for children, daily disposables are often the preferred choice. And there are a few reasons for this. First, they simplify care. So with daily disposables, there's no cleaning or disinfection step involved. So that means we eliminate a major area where hygiene mistakes can happen. And for children and even busy parents, that simplicity really helps to improve compliance. And second, children are actually very capable of handling daily disposable lenses when they are properly trained. Clinical trials have shown that children as young as about 8 to 11 years old can successfully wear and manage them with the right guidance and support. And the third point is safety. Of course, the risk of microbial keratitis is never zero with contact lenses, but studies show that daily disposable wear is associated with a relatively low risk. And one analysis estimated roughly 1 to 2 cases per 10,000 wearers per year, and which is reassuring when we think about prescribing contact lenses for younger children. So overall, daily disposables offer simplicity, good handling success in children, and favorable safety profile, which is why many eye care professionals lean toward them when managing pediatric patients. Finally, this is where everything becomes practical. First, patient selection. We need to consider patients' age, maturity, hygiene habits, sports participation, refractive error, and also their astigmatism needs. And second, the lens selection. Always choose a design that provides sufficient myopic defocus while maintaining good distance acuity. And where possible, daily disposable lenses are preferred for simplicity and also for safety. Third, fitting and optimization. Always assess centration, movement, comfort, and also patient's binocular vision, and refine within the first 1 to 2 weeks if needed. And finally, follow up and monitoring. Always track axial length if available, monitor patients' subjective refraction, check their adherence, and also manage their symptoms early, because successful myopia management is not just about choosing a right lens, it's about managing the patient the whole journey. To summarize, soft myopia control lenses come in different optical design families. They are concentric rings, progressive or peripheral at designs, and EDOF. So there isn't a single best lens that we can rank confidently currently, because we do not have direct head-to-head trials. So comparison across studies must be interpreted cautiously. We do see a signal that stronger treatment optics, such as higher addition powers, may improve control, but that always needs to be balanced with visual acuity or visual quality. And in real-world practice, outcomes are strongly influenced by lens centration, patient comfort, and patient's visual acuity. And most importantly, adherence to wearing time. So ultimately, successful myopia management is not just about the product, it's about how well we prescribe the lenses and how well we fit the patients and also follow up with the patient. This is the end of my presentation. I would like to wish everyone a happy World Optometry Day.
Thank you, Iron Gan, for that insightful presentation on multifocal soft contact lenses and their role in managing myopia progression. Now, we move to our next talk. How were myopia control spectacles developed? It is my pleasure to invite Dr. Rafael Iribarren from Argentina. Over to you, Doctor.
Very pleased to be here in the World Optometry Day. I will share my screen with my presentation. Can you see my screen?
Yes, Doctor. Yes.
I will speak about how myopia control spectacles were developed, because I have been going to ARBO meetings since 1998, and I have seen a history to happen that I will try to describe now. My conflict of interest is that I work for a company called Novar that designs spectacles for myopia control. The first thing I want to mention is that in the years 1970, Raviola and Wiesel, Josh Wallman, and Tom Norton developed in monkeys, chicken, and tree shrews models of myopia that were the first models to appear in Nature. And then beautiful pictures like this taken by Sivak were present. Myopia was produced by foam deprivation in the first years until Frank Sheffield came to the research in myopia, and in 1988 discovered that negative lenses in front of chicken eyes growing during 7 days produce incredible amounts of myopia. And from that time, it was clear that the eye could detect the focus. So Wallman, after many years, published a review in 2005 before passing away, in which he showed that negative lenses produce increased ocular growth and positive lenses produce increased choroidal thickness and decreased ocular growth. By that time, in 2002, he had discovered something very important that has very importance in spectacles for myopia control. He published a paper showing that positive lenses were much more strong than negative lenses to produce a signal to slower eye growth. And then many things happened. How was peripheral defocus discovered? This has to do with also a paper published in Science by Josh Wallman, in which he showed that half a lens or half an occluder produce growth in half of the cheek eye. And then came the studies of Earl Smith in monkeys in the early 2000 years, in which he discovered that half a lens or half an occluder produced growth in half of the eye. And then he did something wonderful. He did a laser ablation of the fovea, and he discovered that foam deprivation recovery and negative lenses also controlled eye growth, even with the fovea ablated. So then came a little amount of papers showing that occluders and lenses with holes, this is one by Frank Scheffel, but at Arbo there were many posters showing that holes of different diameters could also produce foam deprivation and lens-induced myopia, but the hole had to be very little because bigger holes didn't produce an effect, and that is important for what we know now. We know now from this paper in IOBS that the most important area for detecting the focus studied with electroretinogram is the area between 6 and 12 degrees, just the area of the retina that has the 3 types of cones. And Frank Scheffel did a wonderful experiment showing that this area was the one that was responsible for moving the choroid in humans. So by 2010, Neil Charman had the guts of publishing that usual lenses that we were prescribing for myopia control were in fact probably increasing the progression because images in the periphery were producing hyperopic defocus that would increase ocular growth. 1 year later, Antins and Phillips in Ophthalmology published this first trial, which ended in a contact lens that we have now in the market today. At that time, they showed in 18 months that the lens could decrease myopia progression just by having annular rings with a 3 millimeters distant optical zone in the center at the corneal plane. Then by 2020, I had the first lens produced by Carly Lam in 2017. This is a photograph of an optician friend of mine that he took very beautiful photograph. And we took with this lens photographs of the fundus of the eye with an OCT machine showing that the dots of the little lenslets were falling just in this area sensitive to the focus. There's a very nice paper, an invited review by David Hutchinson and Neil Charman again, showing the different designs that we have in the market. These designs, the first ones tested more than 20 years ago, have not much effect in myopia progression, but these newer ones are much more useful, as we have seen in many presentations today. By 2005, I met Ian Morgan for the first time, and he was studying at that time a little pilot study in which he put +3 lenses in front of myopic children's eyes. He presented this as a poster in Australia, and he showed that putting for half an hour a +3 lens in front of the child eye, he could arrest myopia progression. So by that time, in 2020, we developed our lens for myopia control that has a distance zone in the middle for distant vision with the optical correction and a +3.5 like the one that had Ian Morgan used. And we showed that the focus fall in this area sensitive to the focus. One interesting thing of our lens is that this is a prismatic effect produced by a -1.5 spectacle that I use for distant viewing. And this lens apparently has no prismatic effect because the power is in the middle in that central zone. We have published that compared to the REPCA controls in the Atropine study in the USA that were progressing, our children did not progress with this special spectacle. One important thing in these spectacles, all of them, is the frame adaptation and the centering. Here you can see a multifocal lens in front of the grid of Excel grid, and you can see perfectly the corridor and the distance zone. This is our lens, and you can draw the optical zone and put it in the eyes of the patient to be sure it's well centered. This is crucial. Another thing is crucial is the vertex distance. We made visual fields with 8 millimeters whole frames, and we showed that if the vertex distance is very short, like in the left side, the focus falls outside the needed area, while if the vertex distance is 12 millimeters, the focus area falls in the same place that it must fall. And last one, here you have people looking at the tennis. You can see that they move their heads and not their eyes. During saccadic movements, the eyes are blind. Here you have a friend reading with multifocals, and you can see clearly that he moves his head and not his eyes because the corridor is very narrow. And here you have a child using our lens, and you can see how he moves his eyes, staring around as he says to look. So we are studying eye movements. In conclusion, much has been done all these years, and we have now lenses for myopia control, but we have a lot more to learn. Thank you very much.
Thank you, Dr. Rafael Iribarren, for that insightful and informative presentation on the development of myopia control spectacles. Now, we move to our next talk, RLRL therapy in pediatric myopia, treatment response, safety, and monitoring. It is my pleasure to invite Prof. Himing Guang from Hong Kong. Over to you, Professor.
Hello, everyone. This is Ming from Hong Kong Polytechnic University. Thank you so much for the invitation from Dr. Carla. Now, for the opportunity to present repeated low-level red light therapy in myopia. This is my conflict of interest declaration. Light exposure is very important for myopia. So a couple years ago, we already proved that increased outdoor time is able to reduce the incidence of myopia. So the idea is whether we are able to emit the light directly on retina as a way to treat or control myopia progression. So this is a randomized control trial published at the end of 2021, where in the clinical trial, we use a home use device. So this is basically a low-level red light, we call it low-level red light therapy device, home use, and then twice a day, 3 minutes per session with 4 hours interval, 5 days a week treatment. So in this clinical trial, we enroll the low and moderate myopia patient, and this is the 1-year clinical trial result. So if you look at axial elongation, so the red light therapy is able to control around 70% of the axial elongation. And more interestingly, the treatment response is stronger among those people with higher degree of myopia, say -3 to -5 at baseline, in comparison with the children on a lower degree of myopia category. So this is, you can see the difference between the control and the intervention. And if you look at spherical equivalent outcome, 80% of the spherical equivalent progression is able to control by the red light. And again, consistently, higher degree of myopia, you receive a treatment, stronger treatment benefit or response. And the back-end system, we are able to monitor the compliance. So when the compliance of the children reach 75%, the treatment efficacy on spherical equivalent can be around 90% efficacy or control on the spherical equivalent progression. So this is a clinical trial. The first time we demonstrate a consistent colloidal thickening in a clinical trial in comparison, of course, with the single vision like control arm. And also the OCT scan demonstrate there's no structural damage or changes on the neurosensory layer in this group of children participating in the clinical trial. So this is a 1-year trial, and then on the 24 months, like 2 years, we ask the patient come back. So for those children who stop the treatment on the 2nd year, we observe a modest or rebound on the spherical on the axial elongation. So therefore, we recommend people or children, if they want to stop the treatment, they should follow a tampering protocol at least to minimize the rebound. And this is a 3 years clinical trial where we 3 years data for the viewer, a multi-center viewer study, where the study demonstrates the treatment benefit is able to maintain even among the children who use the devices for more than 3 years. More than 3 years, the treatment benefit is able to control, is able to maintain or sustain among those people. And another clinical trial is interesting. They adding the red light into the treatment protocol, into the children who receive autokeratology treatment. And then they demonstrate 2 benefits. One is fully control on the axial elongation. And second, because the children use auto-K. So in the daytime, they don't need any glasses. They don't need any glasses or any contact lens. So in other words, this is to me, it's an ideal scenario where the children don't need glasses in daytime, and then they also have a myopia progression fully controlled. Another study combined the red light with the DIMS lens, and then they demonstrate very interestingly. So this is a DIMS lens control, and this is RL alone. Putting this together, they observe a synergic effect when you put these 2 treatments together. And another study in Shanghai demonstrate a very strong treatment effect or treatment benefit among the highly myopic children. In the definition is -4 diopters or greater. So this everybody, all the children receive red light demonstrate a consistent axial shortening, and around 50% of the children, their axial shortening is greater than 0.05 millimeters. So it's a clinical significant axial shortening in the higher degree of myopia children. This is consistent with what we observe in our 1-year clinical trial. So this is another independent high myopia trial where they demonstrate in a high myopia children now defined as -6 diopters or greater, they observe a consistent axial shortening and also a hyperopic shift as well. Again, far majority of the children, they have a axial shortening if you are high myopia. And this is the first trial demonstrate among the peak myopia children. With the red light, they're able to prevent around 50% of the onset of myopia. So this 50% of the peak myopia children will not become myopia. So there are many randomized control trials in the non-Chinese or non-Chinese population in Japan and United States, in Spain, and so on. So these are a couple of papers just recently published in a non-Chinese population. This is in the Spanish children, a randomized control trial. They demonstrate even in a low and moderate myopia, they demonstrate a consistent or even stronger treatment response among the non-Asia or at least like Spanish children and everybody. Axial shortening. So this is this is Australia ACO trial demonstrate axial shortening in the Australia children. So again, the treatment benefit or treatment response appears to be stronger than the Chinese children in the Australian children. So even in 2023, there's already a systemic review and meta-analysis published. They're putting at that time the 13 study, including 8 randomized control trial, and they consistently report a hyperopy shift on the spherical equivalent change, and then axial shortening in 6 months, axial shortening when they pull all this data together, and also a consistent colloidal thickening as well. So this is Professor Jason Yam's study, a major review. They document and they prove that red light appear to be the strongest treatment for myopia control, which is of course very much stronger than the outdoor intervention and many other interventions as well. So this is surprisingly, we try to use a randomized control trial red light as a keyword. We identify a lot of paper published on a randomized control trial published on this specific topic. And then we also need to pay attention to the safety. When people talk about safety, first of all, we got to understand what kind of light. When you say light therapy, what type of light we're talking about. So this is a low-level laser on the 0.29 milliwatt through a 4 millimeter pupil. So which is much lower or weaker than the photocoagulation, like a couple thousand milliwatts. So this is called low-level laser or photobiomodulation. So the device is also interesting. If you haven't seen it, this is a device. At the bottom of the device, there's a small computer that mandate the children. They have to use the username password to log on the internet. If they match with the system, and then the light is turning on. So in another word, the light on and off is controlled by a system like this. So one day you have to follow. I mean, this treatment on and light on and light off have to follow the protocol. So this is a built-in solutions that you can a back-end system here can really monitor the laser energy at a real-time basis. The device has also received regulatory approval in CE and Europe, and also many other countries, Malaysia, New Zealand, Australia, and so on. The study pulling all these the different treatment modality together and try to look at the event rate for the side effect, and it kind of suggests the ILRL side effect event is only 0.088 per 100 patient. So the event rate for the side effects is extremely low. So another study interesting, they just present the multifocal ERG where they demonstrate there's no change on the photoreceptor response after the red light treatment, and there's an increase on the transmission response function on the retina and the bipolar cell and all this Muller cell, this P wave. So there's also a study in UK. I think they assessed whether there's any color, like a permanent color vision changes, and then they observed there's only temporary impact. Of course, after the red light, there would be a color vision change, but then it will return to baseline after 5 minutes. There was a side effect patient report in 2023 with disruption on the IS. This is like an outer segment of the photoreceptor. But then there's interestingly, the retinal expert from Japan, they proposed this patient is a preclinical Stargardt disease by comparing when a problem happened, there's choroid is invisible, but then after stop the treatment, so the choroid, the lipofuscin is clear, and then is able to see the choroid again. So again, this case actually suggests that this we call it super responder because they receive a very strong treatment benefit. And also the after image is very long, this after long, like 5 minutes. But then it's important, this changes is detectable by OCT and is recoverable. So there's a study report of rare cases like scenario where they observe this, we call it metabolic deposit on the RPE layer. But then this metabolism deposit is we do not have visual acuity decline, and then it will be resolved after if you stop the treatment for 0.5 or 3 months work, 3 months, and then you won't see this changes will disappear. So Lisa Ostring, Dr. Lisa Ostring report recently published safety. It basically is a laboratory testing on 4 red light devices, and then they report a rate. Some of the devices reach or exceed MPE minimum exposure requirement. So for the ANSI limits, and then they raise a theoretic safety concern. But then another laser expert, Professor John Marshall, who maybe some of you will know him, is a pioneer of ophthalmic laser science, and he's a physics actually, the inventor of laser. This is a YouTube video I recommend you to watch, and he kind of explained that ANSI limit is designed for accidental exposure, not for therapy, and this minimum MP exposure tend to be conservative. But then he also reminds us in the laboratory test for ANSI is that using 7mm pupil size. But then in the real world, it's normally less than 3 or maximum 4mm pupil because that pupil with constriction with the red light, when the light is on. So he kind of conclude the retinal injury risk is negligible. So then in conclusion, red light is similar to many other treatment. It's no treatment is 100% safe. So as a clinician, we got to assess the benefit risk ratio for our patients. So we and then, of course, we have to adopt a risk minimization strategy following the clinical guideline, and also we got to take, for example, regular OCT and visual acuity testing to make sure there's no structural changes on those children who receive red light. With that, I would like to conclude my talk, and thank you very much for your invitation again. Thank you.
Thank you, Professor. Let's move on with our next topic and call our next speaker. Our next speaker is from UAE, Dr. Imran Javed, and he shall take us through low-dose atropine in myopia control. Is 0.01% enough? Over to you, Dr. Imran.
Yeah, it's visible.
Perfect, thank you. So thank you very much, and happy World Optometry Day. So I'm going to talk about low concentration atropine in myopia control. So is 0.01% enough? So if we look at the background to some of this, I mean, atropine at 0.01 is the most prescribed pharmacological intervention for myopia control worldwide. But the LAMP study and several meta-analyses since have questioned the efficacy of this concentration, especially when compared with higher concentrations, particularly 0.05%. And there's a questionable impact on axial elongation versus spherical equivalent progression. And that's been highlighted in literature over the last 5 years or more. And we know that one of the problems is that higher atropine concentrations lead to deleterious effects of near vision, blurring and photophobia. And there's a dose-dependent response, but also for rebound progression. And that's the biggest issue here. So we need to balance efficacy versus tolerance and acceptability over many years of treatment. So atropine is not something that you can use for a year or 2 years. And so if we look at some of the the landmark studies around this. So this table here just summarizes the ATOM study and the LAMP study. So if we look at this, the ATOM 1 study, which was way back when, looking at 1% atropine. Then the ATOM 2 study looked at 0.5, 0.1, and 0.01. And this study is really what led to the birth of, or the boom in 0.01% atropine for myopia control. But if you look at the 2-year results, actually that wasn't the most potent myopia control effect within the study, the most potent being 0.5%. And we'll explain why that is a little bit later. And then following this, to look at in-between concentrations to mitigate the risks of rebound, the LAMP study looked at 0.05, 0.025, and again 0.01, and found that actually 0.05 was by far the most efficacious dose. But again, so you might be thinking, so why am I going on about 0.01%? But one of the key, and if you look at this graph here, you kind of think that even more now, because at 1 year, the mean slowing of axial elongation across the studies listed here was 0.07 millimeters, which is kind of negligible, and a mean slowing of myopic dioptric progression of about 0.2 diopters, which again over a year is pretty meaningless. But one of the issues that the ATOM 2 study had was that they didn't have a control group. And even within the LAMP study, they only had a control group for the first year of the study. And so comparing efficacy against no treatment, and then determining whether 0.01% is or is not effective is particularly challenging. Looked at a control group, historical control group from the ATOM 1 study, but if you look at the growth within that cohort, the axial elongation was about half of what you'd expect for an East Asian child within of that age. And so some work done by Noel Brennan, Mark Bullimore, and the team produced this fantastic paper, The Influence of Age and Race on Axial Elongation. And we use this in clinic every day. And if you look at the data from that paper and look at an East Asian child aged 9.5 and project how much dioptric and axial length progression you could get over the next 2 years, you can work things out and then extrapolate that to work out, well, was it in fact meaningless or not? And interestingly, if you do that to the ATOM 2 cohort and the LAMP cohort, you find about a 0.35 millimeter reduction in axial length compared with what you would expect, which is very significant for that cohort of children. So with that kind of fresh impetus, we can look at some of the data in a bit more detail. So the ATOM 2 study, remember that these studies, it's hard to get bottom lines because it wasn't just kind of treatment for 5 years, but they examined several factors within how you might manage a child with myopia, and it's important that we bear some of that in mind. So, for example, in 2 years, the ATOM 2 study looked at 2 years of treatment, which was phase 1, then a 12-month of washout period, so was there a rebound? And what we found in this study was, well, they defined a rebound as more than half a diopter, and they would then recommence on 0.01% atropine. And they found that there's an inverse relationship between atropine dose in phase 1 and myopia progression. So if you're on 0.01% atropine for 2 years and then stopped, there's about a 1 in 4 chance that you'd recommence on atropine during phase 2 because you would have progressed by half a diopter within that 12 months. Versus the number there that I can't see now because it's kind of chopped off my screen. That's 2 seconds, sorry. Apologies. There we go. Compared with 68% of children in the 0.5% group. So an inverse relationship there. So that the higher the dose, the more likely you were to get a rebound defined as half a diopter. And if you combine that together, that's where we get the statement that 0.01% demonstrate the strongest efficacy in reducing myopia over 3 years. But continued use, no, it's not. Obviously, higher doses give you more myopia control effects. But if you want to mitigate against the deleterious effects, then 0.01% would probably be the most favorable. And then if you can again extrapolate that to the LAMP study, so in the LAMP study again, so you had 2 years of treatment. Remember that in the second year, they lost the placebo group that was changed over to 0.05% arm. And then in year 3, we split the groups into continued treatment and withdrawal for each of the 3 arms. And then in year 4 and 5, everybody will switch to 0.05% atropine because that was the most efficacious and probably the most ethical thing to do at that point in time. But if you look at that study, 88% of those that had treatment needed retreatment at over half the drops a year. And that's the key message here. And that this is not something that you can just use for, you know, a year or 2 years. And it's very likely that if you stop at a young age in children who are progressing quickly because of their age, you will lose some of the benefit, if not all the benefits of the preceding year or two of treatment. So this is a long-term treatment. And if you look at that in more detail, so this is the phase 3 kind of data from the LAMP study, which showed that in the 0.05% atropine, there was a very significant difference in the 0.05 and the 0.025, both for axial elongation and dark trip progression when you stopped treatment versus continued treatment. But in the atropine group, there was no significant difference with the treatment group and the washout group. And I know what you're thinking, well, that's probably because it didn't work in the first place, and maybe, but maybe it's just that you got less rebound, however you're describing that for the purposes of the study. And following on from this, we then have lots of studies, and time does not permit us to kind of examine all of those in great detail, although I'd love to do that another time. But the key take-home message is if you look at the ages of these patients. So, for example, the CHAMP, although it's over 3 years, versus this study in Danish children, approximately the same age of 9.5-ish, I guess, is the middle, and about a quarter of a diopter change in spherical equivalent refraction, and a 0.11 millimeter reduction in axial elongation. And the same can be applied to older children. So the Mosaic study, which compared 0.01% against placebo, and again, for the Western Australian ATOM study, again, atropine groups of just over 11 years, again, showed very, very similar axial length changes over the period of the study, and dioptric progression over the period of the study. So very important messages to show that age is an influence, but actually that can be extrapolated to very similar effects, even within cohorts from different studies. And the question really is, well, you know, if it works, you know, it's okay, because lots of people believe that, you know, 0.01% atropine, if you stop it, you're not going to get a rebound. Well, I'm going to show you a couple of papers that would kind of argue against that. This is from the Western Australian ATOM study, and as I said, we don't have time to go into all of it in detail, but essentially, if you look at the 12 months before treatment was stopped and the 12 months after treatment was stopped, in the placebo group, there is no significant difference between spherical equivalent change and axial length change over those 12 months in comparison. But in the atropine group, there are significant differences, which suggests that, and you can see here that there is faster growth after stopping the drops in these two boxes here compared with before, which would suggest that there is a rebound effect, although not massive. And so what some people would say is, well, let's just use a high concentration of atropine to start with, because that gives us really good control, and then we can always taper to a low concentration. And there's been no really good studies that looked at doing that, but we all kind of do that, and we think it's probably a good thing to do. But this is a good, interesting study. So this is in Danish children, and what they did here, this blue line, they loaded them for 6 months with 0.1% atropine, and then they were switched to 0.01% atropine for the remainder of the 18 months or 2 years in total for the study. And then you have the orange line here, which is continued at 0.01% atropine for 2 years, and then the green line here, which is placebo for 2 years. And what you can see here in this is for spherical equivalent, and this is for axial length change up to 2 years, and then the washout period for the 12 months that go thereafter. And continued atropine 0.01% at 2 years in point in time had a statistically significant improvement when compared with placebo. However, when you loaded patients with 0.1% first, it did not. And you can probably tell in the graph here that there is a point in which you get a rapid drop in spherical equivalent refraction, and a steepening in the graph here when you withdraw from 0.1% atropine and go into 0.01% atropine. And at the end of 2 years, there was, as I said, a statistically significant difference, but by 3 years, i.e. when everyone has stopped all the drops, that difference has been lost. If you look at the actual differences in it was faster in both groups compared with placebo, but there were no p-values shown in the study. But that suggests that actually that change can mitigate the benefit that you had before, because before it was statistically significant and now it's not. So again, be careful if you're going to use high concentration and assume to low concentration is safe, and when you withdraw atropine, even at low concentrations, you should expect a rebound effect, and we see that in clinic all the time. So obviously, 0.01% atropine doesn't work in every single child. In fact, in the ATOM2 study, almost 1 in 5 progressed by more than 2 diopters, and about a third had progressed between 0.5 and 1 diopter over 2 years. And the LAMP study showed very similar, 1 in 5 and a third progressing by 1 to 2 diopters. So, and then if you look at more modern studies, we're using this term called responder rates, which is cited in the CHAMP and the STAR study, which is yet to be published, but they looked at a 0.5 diopter change at 3 years, and a 9-year-old child is, quite ambitious. But they found that, that about 30%, so let's say, just under 1 in 3, would respond to 0.01% atropine alone, which means that, in real life, we don't think it that way. We don't give a target. We don't say, well, I'm going to say you failed if you progressed a half diopter a year. We compare age and ethnicity means over 12 months and make a decision. But let's say you did, for a fact that not every single one of your children that you treat is going to be controlled. So what's your options? Well, you can either increase the concentration, and we've seen that from the LAMP study and also from the Mosaic 2 study, which we haven't had time to go into today, but that has shown that you can have added benefits of increasing the concentration. Or my preference is to combine with an optical intervention, either highly aspherical lens slits, a defocus incorporating multiple segments, or ortho-K. And so here's some studies that looked at that. So this is the most recent by Sim in Singapore, in a mean age of 9 years, so quite and its mean spherical of 4.8 diopters, so rapidly progressing myopes, East Asian children. And if you look at the results here over 12 months, 0.05 diopters and 0.11 millimeters is pretty impressive. And all of these children had what they define as failed treatment because they'd progressed at half a diopter over 12 months. And you can see very similar results in this high risk kind of rapidly progressing children here against a study by Paolucci, who we had from earlier on in the day, comparing DIMS and atropine 0.01%. Again, getting 0.05 millimeters, slightly more dioptric progression. So is there evidence that? Yes. Was it the only answer? No, but is it probably a safe and sensible way to? It's certainly my preferred practice. So in summary, atropine 0.01% has been proven to slow myopia progression. It's not the optimal concentration for getting the maximal myopia progression, but equally, when someone's got high blood pressure, you don't put them on the maximum blood pressure lowering medication. You put them on a balance between efficacy and tolerability, and that's really important because long-term treatment is needed until emmetropic growth rates are achieved, and that doesn't really happen until you get to your late teenage years. So children are going to be needed to continue this treatment for a long period of time. Insufficient control can be mitigated against with combination therapy, which, as I said, was my preferred approach, or you can escalate the concentration. One of the issues we have certainly here in this part of the world is that we would struggle to do that. We get hold of atropine 0.01% relatively easily, but higher doses can be challenging. And then if you're committing children to using high doses and you suddenly run out, well, then you're going to be committing them to rebound progression and much more risk of that when the higher the concentration you use. And now that we have market authorization for atropine by the STAR study by Syndromic, that should lead to more widespread availability, stability of the preparation, and ongoing supply to mitigate some of those issues. So thank you very much. I hope that was interesting. I'm going to stop sharing and happy to take some questions at the end. Thank you.
Thank you, Dr. Imran, for that insightful and valuable presentation. Now we move to our next talk, Early Onset High Myopia, Clinical Challenges and Management Pathways. It is my pleasure to invite Dr. David Nerg from Canada. Over to you, Doctor.
Are you able to see the screen? Is that all set up good?
Yes, Dr. David.
Okay, Thank you, or good morning, and good afternoon, or good evening, wherever you may be listening to these sessions. Thank you to Myopia Conclave for giving me a few minutes to talk to you about early onset high myopia in children and how we deal with it clinically. Learning objectives today is hopefully we learned that early onset high myopia is not your normal progressive myopia. And as such, it probably needs more aggressive treatment. However, our treatment options are very limited given the limited data that we have to help us in our clinics. And so with the limited data and the tools we have that previous doctors have talked about, how does that apply to us in our clinics? So this is the typical patient that I think we're talking about. A 3-year-old Asian male comes into my office with this prescription, right eye minus 1050 with some SIL, left eye plano with some SIL, and mom poses the question, what can you do to help my child as their prescription continues to get worse? So these type of kids I usually put into 2 boxes, syndromic myopia, which was spoken about earlier today. These are the kids that are under age 5 with high amounts of myopia. The question is whether or not myopia management even is part of the equation with these children. What I usually do is I have to monitor axial length. If I see axial length increasing, then myopia management program might be part of the conversation. And obviously these kids need to be referred to a pediatric ophthalmologist. If we do start myopia management, it would probably be co-managed with the pediatrician or the pediatric ophthalmologist. And the second group are those that are the axial myopes. So these are the young children, 5, 6, 7, usually younger than age 9, and they start developing myopia, and it accelerates very, very quickly. These kids usually need some type of combination therapy to keep the myopia under control. So this was talked about earlier today. I'm not going to talk about it in this session. Most of the high onset myopia, only 8% of them are really truly just high myopia with any systemic disease. And of course, you would refer off, or I would refer off to a pediatric ophthalmologist to rule out the systemic disease. So like I said earlier, the tough part is there's really no data to drive us for our clinical decisions. Most of the studies that were presented today, enrollment of these children usually stops around -5, -6. So we have very little studies that deal with children greater than -6. But we have to do something. Just because we don't have all the data doesn't mean we give up on these kids, especially the early onset children. There is something that we can do in our clinics. So risk assessment tools are also talked about earlier today. I'm not going to talk about risk assessment tools. There's a lot online that you can use. What I want to drive home is this one is just one that Dr. Lipson and Kaufler developed a few years ago. You put in all of the data, and then it gives you sort of a final score. And I just want to let you, just sort of drive home the fact that most of these kids are going to score very high on whatever risk assessment tool that you decide to use in your clinics. And the recommendations are always going to be aggressive combination, ortho-K and atropine, contact lenses and atropine, high concentration of atropine, and the monitor is going to be very frequent. So it's going to be every 3 to 4 months instead of maybe every 6 or every year. So what data do we have to help us clinically? Well, we have the HM Pro study. This was done over 10 years ago. High myopia, partial reduction in orthokeratology. And what they did here is they took these high myopic children, spherical equivalents greater to -575, aged 8 to 11, and they fitted them with ortho-K lenses. And the target was to correct 4 diopters of the myopia, and anything residual was going to be corrected with single vision lenses. They did this for 2 years, and the end result was a 63% slower axial elongation. So this is great news for clinicians because now we have something we can treat our kids with. The high myopic kids, we can do ortho-K, and we don't have to correct all of it. As long as we get 4 diopters or more of target, we should get some good axial length control. So just a few sort of words on ortho-K. I know there's a lot of orthokeratologists in the audience today. We know the standard ortho-K systems out there usually give you axial length of 50% control. For those of you who do custom orthokeratology, you know that we get better than 50%. And there's a few reasons for that. Number one is a small optic zone. The Volt study taught us that the smaller the optic zone, the more control we're going to get over the myopia. Clinically, I use maybe a 5.0, sometimes even a 4.8 optic zone diameter on some of the kids that really need tight control. Second thing is the pupil size. We want to get that plus peripheral ring diameter totally within the pupil. When we do that, we know the Ortho-K lens is giving us the maximum amount of treatment possible. Just in this example over here, this child here, you can see his red ring, and the pupil is designated by this gray area here. So you can see that red ring is totally within the pupil. So all that defocus is getting to the eye. So all that treatment's getting to the retina, giving us the maximum amount of control. Just in case you're an orthokeratologist and you're curious, this was a child referred to our clinic. He was minus 14. Prescription was getting worse every 6 months. And we started Ortho-K according to the HM Pro study, and he's doing extremely well. So what else do we have? Well, there's a study, multifocal RGP contact lenses. Do they help in terms of with kids with high myopia? One study says yes, one study says no. Zhang and their group last year did a retrospective study, and they say, yep, it does help. You can get 46% control over axial length versus you and their group. They did another study, and they concluded there was no significant axial length control. So why the difference? The difference comes down to the lens design. Similar to Ortho-K, which we just talked about, the central optic zone in Zhang's group was very small. It was 2 millimeters as opposed to around 5 millimeters, which you in their group, allowing more of the defocus to get through the pupil to the eye, giving more control. So clinically, what metrics do we use? Well, we use axial length. So if axial length escalates or increases by 0.15 millimeters in 6 months or 0.3 millimeters in a year, depending on how often you monitor the child, that's when we have to escalate therapy, and that means combination therapy. So regardless of what treatment you started with the patient, the question becomes, well, what do you add next? So usually it's atropine. So for my Ortho-K patients, I'll add atropine. I'll add 0.01% because that's very effective. The previous doc just mentioned how good it works, and it does work great. If they're currently on atropine, I'll add some type of optical defocus treatment, everything except for multifocal soft contact lenses, and we'll get to that in a moment. If they're on some type of myopia spectacle, again, the DIM study with the ASPECT trial showed us that 0.01% atropine works great, so I'll add that. The only sort of exception here is the multifocal soft contact lenses. The BAM study taught us that adding 0.01% low-dose atropine really has no additive benefit. The authors did suggest there's probably a ceiling effect going on here, meaning the amount of defocus that the multifocal soft contact lens provides is already getting through the pupil, and so increasing the size of pupil of atropine doesn't allow more defocus to get to the eye. So here's the evidence-based combination therapy that we use in our clinics. So if, again, I'm a big orthokeratologist. If I'm not seeing the control I want, I'll right away add 0.01%. And that works very, very well for us. I will escalate it to a higher percentage if on follow-up I see the pupil is not big enough to encompass the red ring, then I'll bump it up to 0.025 and 0.05 accordingly. If they're on atropine 0.025, again, adding DIMS or another like defocus lens works great. ASPECT trial shows us you get 61% more control than just low-dose atropine. If they're on the DIMS lens, again, we'll add atropine to that. Huang and their group said it works very, very well. They didn't specifically state how much axial length, but they said it was a significant additive effect. And because of the BAM study, multifocal soft contact lens, I won't add atropine to that. So we talked a lot about what are the treatment options. Let's get to know our tools a little bit better, because when that patient comes into your office and they're a minus 10 or 11, you want to know, does that product work, or is that even available? So for Ortho-K, most of the Ortho-K systems FDA up to -6. Remember, we just have to correct 4 diopters. For your custom fitters, we go up to -10 or even higher, and it works very, very well. Atropine, because it's topical, you can apply it to almost any eye. Here's where things get a little bit more interesting. Soft contact lenses. In North America, we have a few. And you can see the parameters here, up to -10, -8. We have a monthly that's up to -15, which is great because this is really helpful in our toolbox. Please bear in mind that when they studied these lenses, the daily disposable ones, they were only up to -5 and 6 again. So we're extrapolating to treat them in our clinics. This one did include higher myopic kids, although that wasn't the majority of kids that were in the study. So again, you have to be careful when you use it. And then we're going to finish off with the spectacles. I'm sure most of you have these where you're practicing. The DIMS, that's very helpful because it goes up to -13, a HALT, a -10, the dot lens -12, and the CARE -10. Again, the studies weren't specific to high myopic children. However, this is what we have in our clinics. So hopefully the minutes that we've spent together, we realized that early onset high myopia is not your normal myopia. They're super aggressive, need to be treated accordingly. We do have proven treatments, so hopefully we can use these in our clinic, and that does sort of drive what we do in terms of our clinical decisions. So next time we get this high script walk into our office, there's no more question marks. I think we know where to start. Thank you very much, and I hope you enjoy the rest of the sessions.
Thank you, Dr. David N., for that excellent and insightful presentation on early onset high myopia and its clinical management. We now move to the panel discussion. Due to time constraints, this panel will be kept brief. I would like to invite Dr. Rizwana Husseindeen to lead the discussion. The panel will be open for the next 6 minutes, and I request all speakers of this session to kindly join. Over to you, Doctor.
Okay. So I think due to the short time, I'm just reserving my questions. I think first is to Dr. Imran. So Dr. Imran, based on your clinical expertise and all the data, do you still feel that monotherapy is recommended only for slow progressors, or what percentage is atropine first, optical first, and how do you take that call?
I mean, I think it's very difficult because you don't really know how, well, it's very hard to know which child is going to progress the most. And it even, so my practice generally is to kind of present the information to the family and say, like, you have optical interventions, pharmaceutical interventions, contact lenses, etc. And these are the modalities. And really, it's choosing the right modality that suits that child and that family. And for some of them, I have to, to be honest, like in young children, most families are happy with optical interventions. And I would say in my practice, 90% of kids choose an optical intervention first. And then atropine would be an additive if they're progressing beyond the mean for their age and ethnicity. That being said, I mean, Dubai is quite a nice place to work in the sense that you have children from kind of all over the world. And I find that children, so particularly from East Asia, Russia, where ortho-K is more popular, do choose to go down the route of ortho-K. And then combining that with atropine is a really, really useful and powerful metric. Yeah, that would be but to be honest, like I'd say most kids would go down the route of optical interventions. Atropine is used as an additive effect, both with ortho-K and with an optical intervention. And really because, I am pain split that there's not a 1-year treatment, a 2-year treatment, it's a treatment through childhood. And it's only really when they stop growing that you stop the atropine. And that, to be honest, it puts a lot of people off. But it's the honest and right thing to say.
Thank you. Actually, that question came after listening to Dr. David, because his approach was primarily optical and then adding atropine even in the early onset high myope. So thank you, Dr. Imran. My next question is to Dr. Rafael. I mean, very interesting talk on how myopia control spectacles were developed. So looking at the future of how we've evolved from early progressive designs to now DIMS and all of it, what is the key optical variable, Dr. Rafael? Is it the contrast reduction or the defocus amount, or is the lenslet? What evidence do you have in terms of the mechanisms that drives the myopia control in the optical designs?
Well, thank you very much for the question. At first, when I saw the spectacle with little lenses with positive ad, I thought that they were producing some defocus. But now that we know that negative lenslets also arrest myopia progression, we are thinking that it's the contrast sensitivity that is changed in the periphery. So we really don't know what happens. The spectacle I presented is completely different because it doesn't have little lenses. It produces a double image in the fundus of the eye. So we have to study more. We don't know what is happening there.
Thank you. Thank you for that honest answer. Of course, definitely there's so much evolution happening in this, right? So, okay, Dr. Elizabeth, happy to see you here because I thought so in your talk, you spoke about the hyperopia reserves and the pre-myopia part at the beginning of your talk. So what's your approach in terms of monitoring them before you intervene? I mean, we had lots of discussions beforehand on the pre-myopia aspects. So what's your practice pattern looking like when it comes to monitoring the pre-myopes?
Yeah, so there was a very good debate in Auditorium too. And it was basically, I follow the same sort of thing. So it's a matter of identifying it, and that advice about environment and things like that, it's all free. So just give it to every child, actually. It's not a bad thing to get your children outside, myope or not. But it's a matter of evaluating each child individually, looking at the risk factors. The more risk factors there are, the more likely they may become myopic. South Africa has a very different demographic. We are still in our infancy stages with controlling myopia. So it's a bit difficult to tell within our demographic based on statistics because we just don't have the stats. So we really have to take it by case by case. I completely agree with monitoring very closely. So I would say if you think the child is a possible pre-myope and you're concerned, I would say every 3 months, check the spherical equivalent with the cycloplegic refraction, do the axial length measurements, and evaluate the risks. And then you take it from there, just one child at a time.
Thank you. And the last 1 minute to Dr. David, I'm going to ask about the one thing that you didn't talk about, the RLRL. So, I mean, in terms of the high myopes, the combination of RLRL and combined optical pharmacological therapy. What's your take on that in early onset high myopia?
So I would say the reason why I didn't talk about red light is we don't have it in North America. So from my clinical experience, it would be 0.
Okay. Okay.
But I look forward to seeing it once it reaches our shores, because I think it was Dr. He who said ortho-K and red light actually 100% control. So I would love to have a modality that gives me 100% control.
Yeah. I mean, I asked the question because also the IMI paper also talks about the highest rebound that happens with the combination of RLRL and atropine, so that's why I wanted your opinion on that. So I think with that, we can wrap up our panel and move on to the next session, as we have a lot more sessions still pending. And this has been a very interesting session on evidence-based interventions for myopia control. Thank you.
Thank you, Dr. Rizwana Hussein-Dean, for that insightful and engaging panel discussion. We now move to a special session by Essilor-Luxottica. It is my pleasure to invite Dr. Mark Bullimore from the USA for his talk, The Continuum of Myopia Care. Over to you, Doctor.
Well, hello, everybody, and thank you for sticking with us through this long program. I'm talking to you from Colorado, where it's a nice day. Before I go any further, I do need to disclose my conflicts of interest. I'm a paid consultant for the companies you can see here, and obviously many of them have an interest in myopia, but the most relevant, of course, is the Essilor-Luxottica, and I'm going to talk today courtesy of them and perhaps focus a little bit on some of their work. So this is what I call the continuum of myopia care, starting from the very young child and extending into older adults. I don't have time to touch on all of these topics today, but let me just talk about a few. The first group I want to talk about is delivering appropriate care to the very young myope, because we need to be worried about these patients because they're not your typical myopes. Excuse me, I'm having difficulty with my screen here. And in particular, we need to be worried when we see more diopters than there are candles on the birthday cake. So when we see a lot of myopia in a very young child, we need to be concerned. We particularly need to be concerned when there is a reduction in best corrected visual acuity. And these issues were really articulated wonderfully in this marvelous review paper from the IMI led by Ian Flitcroft. And we need to be careful when we're talking about myopia control in these people. Dr. Ang has been given a very nice presentation in the last session, but you need to remember that the myopia control modalities we have available to us were generally evaluated on 7 to 12-year-olds with modest levels of myopia, with normal visual acuity and no systemic conditions. We don't have a lot of evidence for myopia control in these very young myopes. The etiology of their myopia may be different, and the response to treatment may be different. Now, we are beginning to see some nice early studies. This was a paper that was published recently looking at, what happened there? Looking at HAL lenses prescribed in myopia of prematurity. And what you can see here is that the HAL lenses were quite effective at slowing both myopia progression and axial elongation. Now, the next thing we need to consider is examining 6-year-olds to identify those at risk of onset. And it doesn't matter whether they're 6, 5, 7, whatever, but it's important to examine these children. And we've heard a lot of presentations today on this issue. This seminal work from Zadnik and colleagues demonstrated that the best predictor of future myopia is just a simple measure of cycloplegic refractive. And if you have less than 3/4 of a diopter at the age of 6, then the child should be considered at risk. This prompted the definition of premyopia, which is a refractive state of 3/4 of a diopter of hyperopia or less, but not yet myopic. But it's important to consider that there are other components of this definition in terms of other quantifiable risk factors. Now, this was demonstrated to be very important in this lovely paper by Don Muti and colleagues that was published a few years ago. They looked at children from the CLEAR study who were initially non-myopic and who were followed for up to 7 years. And as expected, the risk of myopia was predicted by refractive error, but also some other factors. So I've pulled a couple of panels from their figure here just to show you the key findings. And that is that if you look at these children, both groups of children have a half a diopter of hyperopia. They have a little bit of astigmatism, but they differ in other ways. On the left, you see Asian girls at the age of 7. And you can see with these refractive characteristics, Asian American females, over half of them develop myopia by the age of 14. That is in stark contrast to the figure on the right, which is white American boys. In these children, less than 10% of them with the same refractive characteristics develop myopia over the following 7 years. So, moving on to our next issue, well, what do we do with these children at risk of myopia? Well, we can counsel, but we could also consider attempting to delay the onset of myopia. And this is important because we know the age of onset is associated with the final level of myopia. And we characterized that in this particular paper, where we looked at the relationship between the final recorded level of myopia and the age of onset. And you can see the data on the right and the slopes of those lines are 3/4 of a diopter or more. So what that means is we can have greater influence on a patient's ultimate level of myopia by delaying onset by 1 year than perhaps treating the myopia and trying to slow it down for 2 or 3 years. So how could we do that? Well, there are clinical trials that have been conducted around the world, but they're all based on this compelling evidence published from the Arinda study, so Lisa Jordan and colleagues here, showing that the probability of a child becoming myopic is directly related to the time that they spend outdoors. Now, more recently, it's been shown that 0.05% atropine can be effective at delaying onset. And this large-scale study showed that in children treated with a placebo for 2 years, non-myopic children treated for 2 years, over half of them became myopic. That's a number that just blows my mind. But with 0.05% atropine, that incidence was halved to around about 1/4. So that's one way. Now, there are also spectacle options. So going back to the Howell lenses that I'm going to talk about more in a little bit, these are the lenses produced by EssilorLuxottica. There was a 1-year randomized control study conducted in China of children with up to 2 diopters of hyperopia. Children were randomized to Howell or single vision spectacles. Interestingly, the duration of wear was monitored using this cloud clip wearing device. Now, what they found in the overall population was no difference between the groups. But when they looked at wearing time, they found, first of all, that the refractive and axial length changes were significantly correlated with wearing time. And when you look at the children who wore their spectacles for more than 30 hours a week, the axial elongation was a lot lower in the Howell group than the single vision group. This agrees nicely with another retrospective study that was out of Shanghai, where they again had about 100 kids with premyopia. And over a year, you can see that before treatment with the Howell lenses, axial elongation was almost 0.5 millimeter per year, but it was much lower once the Howell lenses had been prescribed. Now, let's move on from this study in the interest of time. Some of the most compelling evidence comes actually from children with unilateral myopia. So you've got 4 groups of children here in a retrospective study: children who were prescribed single vision, children who were prescribed Howell lenses in just one eye, Howell lenses in both eyes, and children prescribed orthokeratology in the myopic eye. And what you can see here is axial elongation in the single vision wearers, and you can see that you get the expected increase of about 1/3 of a millimeter axial length over a year. Now, in the children who are prescribed Howell lenses in one eye, you can see that that eye showed much slower axial elongation. But the non-myopic eye that was wearing a single vision lens, you got very pronounced axial elongation. Now, of course, the solution to that is to prescribe the Howell lenses to both eyes. And here you see excellent slowing of axial elongation in both eyes. And finally, here, I'm not going to show you the ortho-K study today. So moving on to the next issue in terms of the continuum of myopia care, it's important to start promptly on newly incident myopes. You don't need to wait to demonstrate myopia progression. And one of the reasons for that is that past progression doesn't predict future progression. You can see here that there's really no relationship between a myope's progression in the first year and a myope's progression in the second year. And we know from studies like the MiSight dual focus clinical trial that all untreated myopes are going to progress. So the time to treat is now and not waiting until you see progression. What are you going to do? Well, you need to administer the best evidence-based intervention to all young myopes. And we reviewed the evidence in this paper that was published last year, where we looked at a whole range of different interventions. And you can find this paper very easily, either using this QR code or using the QR code behind me, which will take you to my website, where you can find a link to that paper. So I'm going to focus mainly on spectacle lenses, given this session is sponsored by EssilorLuxottica. The options available to you depend very much on location. We've only just got approval for the first first spectacle lens for myopia control in the United States, the Hal lens, the Stellest lens. But you can see here that a couple of lenses rise above the rest in terms of their efficacy. Just to review the findings from the primary efficacy trial that was conducted in China. This was a 2-year randomized clinical trial, of which 90% of the children, over 90%, completed the 2-year visit. These are the 2-year results for the Hal lens, and you can see over 2 years, the Hal lens has slowed myopia progression by 0.8 diopters, and they slowed axial elongation by about 1/3 of a millimeter. Now, the investigators wanted to continue this study, but of course, withholding treatment is highly unethical, which means we, amongst other things, we need to rethink how we're conducting clinical trials, given that we have all of these interventions available. So what we did was we leveraged the results of our systematic review and model of axial elongation. And in this review, we analyzed a total of over 60 studies, and we derived this model on the left. This shows the annual axial elongation in children of different ethnicities as a function of age. And you can see, first of all, that the East Asian children progress or elongate about 40% faster than their non-East Asian counterparts. But in both groups, there's a slowing of 15% per year. So we can leverage that to look at 5-year data with the Hal lens. So what you can see here in green is the myopia progression and the axial elongation in the children wearing the Hal lenses for 5 years. You can also see in red the control data for 2 years. But we can extrapolate, first of all, the spherical equivalent data on the left, and on the right, the axial elongation data using that 15% slowing per year. Now, when we do that, the difference between the two lines is 1.75 diopters of myopia control, or about 3/4 of a millimeter of slowing of axial elongation. Now, if you don't like my extrapolation, you don't need to use it to demonstrate the efficacy of these lenses. What you can see is the myopia progression and the axial elongation in the children wearing the Hal lenses for 5 years is about the same as the results for the single vision wearers for 2 years. So the lenses save 3 years of myopia progression and axial elongation. So, in summary, these lenses are highly effective. Another interesting data point is the one at the bottom here, in that only 9% of the children wearing Hal lenses for 5 years developed high myopia, compared to almost 40% in the extrapolated control group. Now, there are a number of questions unanswered by this pivotal clinical trial. They only look at efficacy in Chinese children. There's no comparison with other therapies. There's no assessment of combination therapy, or indeed the use in delaying myopia onset, which I've talked about previously. So we conducted a large and thorough literature review looking for studies that describe the use of Hal lenses beyond this clinical trial. And we identified 78 papers, and these included 26 independent studies of at least 6 months of myopic children reporting myopia progression, axial elongation, or both. And collectively, these 26 studies report data on over 4,000 children. All but 9 studies were conducted in China, but they include 4 studies in Europe. So there were 4 randomized clinical trials, 6 prospective studies and 16 retrospective studies. 11 of the studies included single vision comparison, and I don't have time to go into all the details today, but a remarkable 10 studies compared the HAL lenses to overnight orthokeratology. And in most cases, the HAL lenses were superior to overnight orthokeratology. So what I'm going to show you here are, first of all, our model of 1-year axial elongation in both Asian and non-East Asian myopes. Okay, so this is the model I showed you earlier. This is what we would expect to happen as a function of age. So let's first of all take the 10 studies that included a single vision control group. And you can see both for the East Asians and the non-East Asians, the data fall pretty close to what we would expect based on our model. Now I'm going to take the data for the children wearing the HAL lenses and plot those on the same graph. The purple dots are the East Asian children. The green dots are, or the green circles are the European or North American children. And the circles represent just HAL lenses, and the squares represent children who were prescribed both HAL lenses and low concentration atropine. And you can see in all cases, the treated children fall well below the untreated children, whether you're making a comparison between the single vision wearers or our axial length model. Now, what we can also do is say, all right, let's take that top line for the East Asian children, and then let's lower it by 0.23 millimeters. Why 0.23 millimeters? Because that was the treatment effect that was found in the original Chinese clinical trial. And you can see that the data from these largely retrospective, but some prospective studies follow the expected line. So we're getting a really good treatment effect with these lenses across a range of clinical studies. Now, there's one study I haven't shown you yet, but I'm going to show you it now, and it's shown by these triangles, which are appearing now. And these are the data from the North American study that resulted in FDA approval. And you can see again, you've got a control group that conforms to what we would expect, and a robust slowing of axial elongation in children wearing the HAL lenses. Now, I often get asked which treatment is best. I focus on spectacle lenses today, but we've got a lot of other good options. This question causes me a little problem because I work for a lot of companies who have a lot of different technologies. It's like asking me which of my nephews and nieces I love the most. It's an impossible question. So the answer I always give, regardless of who's paying me to speak, is the one that the child will use. There's a whole bunch of other considerations that will affect your prescribing decisions. Perhaps most importantly, compliance. If a child's not going to wear their lenses or use their drops, they're not going to derive any benefit. And of course, there are other considerations like lifestyle, motivation, but that's where you get to be the clinician. You get to have the conversation with the parent, interact with the child, and make a recommendation that is best for that individual child based on your assessment. Of course, it's also going to be limited by your scope of practice and the availability of products in your location. So the final thing I want to talk about is the need to base our treatment duration on an individual patient. This came up in the first session of the day. When do you stop? When do you tell a patient we're going to stop treatment? When are you going to tell, what are you going to tell a parent if they ask you, how long are we going to do this? Well, I would encourage you to base it on an individual, and here's why. We know from the excellent data from the COMET study that when they rounded up 400 of their patients and followed them for at least 11 years, they found that they could really assess stabilization in over 400 of them. And what they found was a large variation in the age of stabilization. Now, 50% of the children showed stabilization by the age of 15 and 75% by the age of 18. But the flip side of that is that 50% of children in their study are still progressing at the age of 15, and 25% are still progressing when they finish high school and go on to their college or whatever else their career takes them. So I would argue you've got to individualize when you stop your myopia control treatment. So just to take you back to the original slide, the continuum of myopia, there's a lot that you need to be doing with your patients at all ages of their life. And I finally, again, want to thank you for your attention. I'm very easy to find on the internet. If you want access to this presentation, you can reach out to me. You can also find most of the papers that I talked about today on my website that you can reach through this, this QR code. So again, I want to wish everybody a happy World Optometry Day. I want to thank you for all the great work that you do with your patients, and it's been a pleasure to spend time with you today.
Thank you, Dr. Mark Bullimore, for that amazing and insightful talk. We also extend our sincere thanks to EssilorLuxottica for their continued support in making this event a success. We now move forward to the final session of today, the future of myopia care, digital tools, AI, and new clinical models. It is my pleasure to invite our first speaker, Jagrut Laulu from New Zealand. The topic: Next Generation Diagnostics, Digital Biomarkers and Advanced Imaging for Myopia. Over to you.
Hello. Rightio. So, welcome to the last session. Happy World Optometry Day to everybody. My name is Jagrut and I'm coming in from New Zealand, and we have a few of us from down under in this session. I'm going to be discussing with you some advanced imaging for myopia, and really a topic that is a bit in vogue now, but really is quite simple in terms of why haven't we been doing this, and why haven't we been doing this is answered by technology hasn't been there to help clinicians. We're approaching sort of year 17 of translating clinical research into private practice, and what we're now seeing, at least in New Zealand, is almost full adoption of the concept of myopia management. Practical implementation is still a way to go, but we're getting there. So why are we sort of here? Well, oops, what's going on here? There we go. Well, it's always important to remember why, and this is why we're all here, why all the 16 or 1700 attendees are here, and that's really to do with what we're trying to avoid here: preventable blindness. This is a giant retinal tear that occurred to me last year, and 7 surgeries later, I now have perfect sight, which I'm very grateful for. But this is sort of the why of all of this. Let's see if my slide advancer is working. Right. So as you can see, it's quite a large tear that happened within about sort of an hour of onset of symptoms, and that was going rapidly towards the macula. What are we going to talk about today? Well, we're going to talk about the quantitative analysis of the choroid. This is sort of advanced imaging, and one of the challenges that we've had translating research into clinical practice is that many people might have access to an OCT, however they don't have the time, effort or energy to go through and look for variations in the choroid related to the treatments that we apply. So what is a common thing that we could be looking at in terms of advanced imaging? Well, that really looks at things like the thickness of the structure. So, you know, it puzzles me for so long. We've observed that the choroid is affected by optical treatments or drug-based therapies, and now more recently light-based therapies, yet it's been very difficult to associate the impact of that change reliably on the choroid. And so obviously with optical methods of myopia management, we're looking at creating as much retinal confusion as we can, which then promotes the thickening of the choroid. Conversely, with a drug-based approach, we observe that there's an inhibition of thinning, and in these light therapy-based approaches, we're seeing increase in volume via swelling, an inflammation process of some description. So in order to measure this, we can have our OCT and we can start measuring things, but how do we actually analyze this and practically look at using this within our myopia management clinics, or, you know, as we should say, just in private and public practice globally? So one of the things we want to look at is sort of the thickness of this, the vascularity. It's a highly vascular structure, and then applying thoughts from the front of the eye when we look at orthokeratology-based like interpretation of the anterior segment. We could look at the curvature of the structure, and by looking at all variety of these three things and using automation and machine learning, we should be able, I'm hoping now, and I'll present some data shortly, to get to a point where we have a reliable metric. Now, one of the challenges relate to this highly vascular structure being affected by so many external factors, such as sleep, hydration, caffeine intake, a whole bunch of things. But thanks to the development of this metric, which has taken about 15 years of Dr. Chiblani's life for applications in other parts of the retina, we're now getting very, very close. And I'm hoping that we can start looking at using this more in global research. So first step one was actually how do we automate choroidal segmentation? And so this technique is using machine learning and a manual grader to verify and check as this has been built out. And what we want to do is we want to automate rather than manually measuring specific areas of the retina, and then create a metric that's helpful and useful in clinic. So we can get the machines or machine learning to outline the border of the choroid, and then look at subsequently the area underneath it and measure all of that. So what's really critical here is when we're looking at things is we want to look at the metric or a biomarker, which is choroidal vascularity index. So the choroidal vascularity index serves as a biomarker for eye disease, in that it can be a bit more robust and reliable to evaluate the vasculature compared to older methods like just measuring choroidal thickness. What we do know is that the choroidal vascularity index is lower in myopes compared with emmetropes. And there is also, we can map this area and essentially produce a heat map like we do for glaucoma. So essentially this imaging shows that where there's more red in the image across these sort of 9 sectors of the retina, which is divided by, we're seeing more vascularity, in other words, more blood flow, in other words, more engorgement of the vessels of vascularity there. And that could be an indicator to effectiveness of myopia treatment. What's still lacking? Well, surface evaluation. Okay, so what I mean by that is looking at the contour. So we're applying things around optics like we have for the front of the eye now to the back. And with the advancements in a lot of these new technologies in terms of measurement devices, we're now getting complete ray tracing. And so we're looking at the optics and we're looking at a whole range of now, as Mark was just saying, sort of customized or personalized myopia management options, which are very fast and ready to come into play thanks to machine learning. So what we've been looking at is the choroidal contour, and one of the easiest things to do is look at, like we would in a tomography of the front of the eye, looking at the inner and outer boundary, as we call it, or the inner and as we would look at, say, the cornea, the front and back surface of the cornea. So if we apply this, then we're looking at the shape over an area, which we're now looking at and seeing is, there is a little bit less variability on these other factors. And this is very exciting and very interesting. So having a look at the inner surface and outer surface, we're starting to look at trends. And so as we sort of increase the radius of curvature, we're seeing differences within myopia. And to complicate things slightly more, in healthy databases, we have natural changes in our choroidal inner and outer boundaries. But this is where the development of these metrics and the support of technology now is so useful, because we can look at multiple factors at the same time and come to conclusions that us as, sort of human researchers is, haven't really been able to think in that many orders of magnitude or look at the variety of different aspects to find associations. So we seem to find that there's a decrease in radius of curvature with significant correlations with age and axial length. And this is very helpful and useful for us to standardize a method for managing myopia. The other advantage of having using, say, OCT is, or at least in our part of the world, and I think in most parts of the world, is that almost all practices seem to have access to OCT, and this technology and technique can be applied to any OCT, so long as the database is then trained, and that's what the work that's going on right now. And so we don't necessarily have to immediately purchase new equipment in order to feel like we've managing myopia well. We could potentially use existing technology. So choroidal changes in patients undergoing ROT, this is just a group of light-based therapy to show you a practical application of this before we finish up for the talk. If we have a look at 13 patients, 23 patients, 46 eyes as a pilot over 6 months, we wanted to have a look at and assess the choroidal thickness, choroidal vascularity index, and like in glaucoma, have a standardized area that we look at within the macular area. Okay, and what we found was that we can analyze changes in choroidal thickness, and there was actually a significant increase in choroidal thickness from baseline to 3 months after initiating an interventional treatment using light. And we also found that it stabilizes at 6 months. We also have 1 year data and 2 year data, but that will be published after the first papers are published. So what do we do? Well, you divide the retina into sort of these 9 sectors, and to be honest, we just needed to look at is there anything to this, and how can we standardize this? And essentially, what you're looking at here is you'll have this sort of heat map, and more red means more thickening. We looked at all the 9 sectors and looked at them all over different areas of time, over the different times, and analyzed the thickness differences. And all we found was that, yes, all sectors demonstrate progressive thickening of the choroid, but the largest increases were actually observed in the central and inferior sectors, in inferior sectors. So not suggesting that that means anything directly at the moment, but this is something that we're really interested in studying when we're looking at personalized myopia management. And approximately 20 micron increases seen in 2 regions in our treatment group. So What about choroidal vascularity index? Well, nothing statistically significant was seen in this index over across time points. However, we are now looking at, for prospective research, to increase our sample size and data and have a look and see if there are a couple of very interesting things that we've seen, which anyone that's on the call or interested, feel free to contact us and we can talk more about that. So how do we use this in practical terms? Well, let's have a look at an 11-year-old female in New Zealand. We're looking at the changes in choroidal thickness, and we also take into account that there is, we're looking at axial length as well and corneal changes and things like that. But for the purpose of this discussion, let's look at just this particular biomarker or aspect of the eye to manage myopia. And what we've seen here is you see this sort of glaucoma sort of heat map here, where red is more thickening and blue is less thickening. And you'll see in baseline we've got our eye and choroid, and then you'll see the inferior inner sectors. As we progress through, you start to get gradual thickening. Now, this is quite exciting because it means then we can then monitor the effectiveness of a treatment, and we're going to be very interested to see, the impact of different treatments and what particular patterns we see. What about the changes in choroidal vascularity index? Well, as we said, not necessarily significant from a research point of view. However, if you're in clinical practice, what you're probably going to notice or see is that you'll have your baseline and then you'll have a change to this choroidal vascularity index, which makes sense, right? If you're creating swelling, in this particular case of the choroid, you're going to see more vessel engorgement, and more vessel engorgement can therefore mean, you're going to increase this parameter. By how much? Well, we'll leave that story for another time. This is the left eye as well. And then if we go, the final thing we want to look at is sort of choroidal segmentation binarization. So we're really looking at, with this sort of technology and making lives easier, giving people more confidence, because the one thing that we see certainly in myopia management is not the belief in the science or the belief that this is a thing that we need to do. It's confidence in prescribing, and it's confidence in delivering treatment. So tools like this and advanced imaging are going to make lives easier for practitioners, and they're also going to give them more confidence, especially when they're new to this. We've got one other a case here. I'm just conscious of the time, where we had another patient come in. We looked at their baseline, and this patient had a previous treatment already, and then we're adding a second treatment in for this patient. And as you can see, there's thickening at the baseline of in inferior sectors, and then at 1 month there's no real huge change, but by 3 months we've actually got an increase there in that sort of red zone or red area, and then things seem to stabilize. Correspondingly as well, axial length is associated with this as well. This is the left eye. And then changes in our choroidal vascularity index. We're seeing originally there's quite a lot of vascularity index change, and then as we move through, it sort of drops down a little bit at 1 month and then increases back at month 3 and then 6. This is all very exciting stuff for us. But so these are the sorts of maps that we want to be doing and presenting to our colleagues in from a industry point of view to practitioners and patients to make their lives easier. Right, so having a look at the choroidal thickness and the shape and change, there are some inherent challenges, and that's why at the moment there are some manual graders as well to make sure and double check that the algorithms are working fine, but soon they'll be completely trained and ready to go in terms of a mass market rollout. If anyone's interested in these sorts of tools for research, both commercially or in private research, this is really important that people know that we're trying to get this into as many different OCTs as possible. The newest ones that are working on are Zeiss rated ones as well. as just a disclosure, I'm not financially involved with this. This is just an area of passion of mine, and I've seen this product from somebody else who's developed it, and we're just changing the application from retina from AMD to myopia, and that's why it's a combination of about 15 years of work in another part of the retinal disease, but we can apply this to here, and I think it's going to help us quite a lot. I think that's enough from me, and I look forward to the rest of the session. Thank you, everybody.
Thank you, Jagrut Lalu, for that insightful presentation on next-generation diagnostics and advanced imaging for myopia. Now, we move to our next talk, a novel computerized adaptive testing, CAT, system to measure the QOL impact of myopia interventions. It is my pleasure to invite Professor Ecos Lamoureux from Australia and Dr. Eva Fenwick from Singapore. Over to you, professors.
Hello everybody, my name is Ecos Lamoureux from the Singapore Research Institute and the Duke and US Medical School. My talk is going to relate to the psychometric assessment and computerized adaptive testing simulations of quality of life item banks for myopic refractive intervention. We all know that uncomplicated myopia can often be fully corrected using optical aids and or surgery. However, living with corrections have also an impact on several aspects of non-visual quality of life. For example, for people wearing spectacles, very often the rain will wet their lenses and they complain of blurriness. Similarly, for people undergoing refractive surgery, there's also the issue about the economic burden of such processes. We usually use the PROMS, PROMS, which stands for Patient-Reported Outcome Measurements, to assess the impact of quality of life across multiple domains. Currently, however, most PROMS are fixed length, lengthy and designed to assess only 1 to 2 aspects of quality of life, and can be very burdensome to administer in routine clinical care. With that in mind, we have been developing what we call SMART question in ophthalmology. To do this, we use the CAT system, CAT, which stands for Computerized Adaptive Testing, which goal is to estimate a person's level of the construct based on responses provided to a set of items of varying difficulty. To do this, first we generate what we call item banks, which are large electronic databases measuring a particular trait, such as functioning, using all calibrated items on the same linear scales. Once this is done, the algorithm will start the person with an item of moderate difficulty, and based on a response to that first item, if it's too easy, we'll provide a harder item. If it's too high, we'll provide a next item. And this will keep on doing until the time the line is flattened and the algorithm can accurately estimate where that person's score is at. And that will also depend on the stopping rules set for this particular CAT. Compared to paper-pencil tests, CATs are flexible, efficient, and better targeted and allow real-time reporting and can be used to download into EMR, for example, for doctors and patients to have a communication. So we have developed what we call the Maori CAT in Singapore, which is focusing on myopia refractive intervention CAT. It has 7 quality of life domains, such as activity limitation, comfort, which is CM, concerns, which is CN, convenience, which is CV, EM, which stands for emotional domain, MB for mobility, and work, WK for work. It focuses on 3 specific myopic refractive interventions, such as spectacle wear, contact lenses, and refractive surgery. We have completed phases 1 and 2 based on our own framework. For phase 1, usually we undertake comprehensive review followed by qualitative data. The phase 2 usually optimize the item pool generated from phase 1 to develop fixed length instruments, which we followed by cognitive testing to ensure that patients understand the questions that are being asked. We then proceed to phase 3, which I'm going to report here, where the aim is to optimize the psychometric properties of the 7 myopic refractive interventions, quality of life item bank, and evaluate the performance using CAT simulations. So for this work, we're going to use 7 quality of life domain of the Maori cat, which contains 204 items across a 5-point Likert scale, as you can see here. For example, because of your myopia treatment and correction, how much difficulty do you have adjusting your vision going from a bright to a dark area? For example, in a cinema, and the 5 options are none, a little, quite a bit, a lot, unable to do, or doesn't apply to. So first of all, we will undertake the psychometric assessment of these 7 quality of life domain. We will use rash analysis, which will look at identifying misfitting items, poorly targeted, or items exhibiting what we call differential item functioning, called diff. These will be removed, and the calibration will be generated and then move to undertake the CAT simulations. To do the simulation, we use the CAT-R program in the R software, where 1,000 simulated respondents will undertake this work. What we are looking at here is the average number of items needed for 2 precision level: the moderate precision with a standard error of measurement, an SEM of 0.387, or high precision with an SEM of 0.3. We're also going to look at what we call item efficiency, where we will know what's the average item needed for each of these 2 simulations, the moderate and the precision. We're going to look at whether there's model fit using the RMSE, which is the root mean square error, whether there's bias, for example. For example, here, the lower values for the bias are better. We're also to look at the correlation between the CAT simulation and responding to the full item bank itself. So here are some of the results. We recruited 291 participants for this phase 3 aspect. The average age was around 34 years old. 2/3 of them were female. Most of them were Chinese, around 86%. And the type of refractive interventions included 21% for spectacles only, 35% for laser refractive surgery only, over 40% for spectacles and contact lenses. And we didn't have a lot for spectacles and laser refractive surgery, only 5 patients, and only 1 patient for contact lens and refractive surgery. Now let's look at the psychometric assessment of these 7 quality of life. What we found was that for 5 of them, they had satisfactory psychometric properties after removing misfitting items were showing differential item functioning, or items who were poorly targeting values, and these 5 could then be operationalized using CAT. We found that the mobility, the MB item bank, had poor targeting, and we had to be removed and not considered for CAT simulations. When it comes to the work item bank, it had poor precision due to a substantial amount of missing data. But however, because it's an important item, we retain it, but not to be used as a CAT, but as a fixed length scale. So now that we've done the psychometric testing, we've obtained the calibrations of each of that, and we're going to move now to do what we call the CAT simulations. And here's are the results for the 2 precision levels, the high precision level, and which looks at an SEM of 0.3. We found here that it has satisfactory model fit, very good RSME, and very good bias values. We found that the mean number of items taken range between 14 to 19, and the potential time savings also was very good, around 71%, the mean time saving. The correlations between the CAT simulated and the actual score were pretty high, an average of 0.7. For moderate precision, here we're looking at an SCM of 0.387. Again, we can find satisfactory model fit. We found that the average number of items needed varied between 10 to 12, so much less than the high precision one. The potential time saving was around potential time saving was around 80%, and the correlation between the cat simulated and actual score was around 0.8%. So overall, what we found that 5 of the 7 Maori cats showed a very, very good precision, validity, and highly efficient measurements of quality of life when administered using cat via simulation system. We found that the potential time saving could be up to 80% using the moderate precision setting. However, with high precision setting, it required more items than anticipated, ranging between 15 to 19. The Maori quality of life item banks function independently, therefore it allows flexible administration, ability to pick and choose. Clinicians, for example, can pick and choose the quality of item banks that they need or as needed. Therefore, it can be very useful for clinicians and researchers in clinical care management to assess effectiveness of their myopic treatment. Some of the strengths and limitations of this work include, for example, strength-wise, we undertook rigorous psychometric assessment using item response theory or modern item response theory such as rational assessment on the Maori cat item banks. We recruited from both clinical and community populations, and therefore it has enhanced applicability of response data across patient populations. Some of the limitations of this work include, for example, the majority, 86% of populations were Chinese, and very few people from the two minority groups in Singapore, Malays and Indians. Therefore, the instrument are not designed to assess. Also, the instrument is not designed to assess certain refractive correction modalities such as auto-K related quality of life changes, and therefore it has limited data generalizability. The Maori cat is already attracting a lot of attention of our clinicians, and the next step it would be to implement it at the Singapore National Eye Centre, where we have already undertaken a large implementation project involving 3 conditions: cataract and refractive error, retinal and glaucoma clinics from August 2024 and December 2025. We use a very simple, what we call hybrid model, where the links to the cat were sent via WhatsApp to the phones or to the tablet of our patients, and they would answer them remotely. At the time when they come to the clinic on their appointment day, upon registration, the CRC will know who has responded and who hasn't. Those who have responded remotely would have the report sent directly to the treating doctor via our EMR system. Those who haven't would have a tablet where they could take the cat that they could not respond remotely. Once done, this work will also be sent to the treating doctor via report for the EMR system. As you can see here, we had 1,038 participants involved in this implementation project at SNEC in retinal glaucoma and cataract, where we had a response rate of around 80%, which is quite phenomenal. Around 86% for retina, 75% for glaucoma, and around 78% for cataract. And really, we had some very good feedback from both doctors and patients. For example, one glaucoma doctor said that patients had good vision but poor quality of life score. Without the cat, I would have assumed everything was fine and moved on. So quite important for doctors to see the value of having cats in their clinic. For example, for retinal patients, one of the testimonial shows that says that the questions were quite nice because people rarely ask you about these kind of things. So having a questionnaire that asks this question helped me to feel a bit more seen and heard. So again, these are quite good testimonials that we found for our implementation, and we will do the same for MyoRecut in the forthcoming month. Thank you so much for listening to my talk, and I'll be happy to take any question after. Thank you. Bye.
Thank you, Professor Ekose-Lamoureux and Dr. Eva Fenwick, for that excellent and insightful presentation on the CAT system and its role in measuring the quality of life impact of myopia interventions. Now, we move to our next talk, the future of myopia control, emerging therapies and translational research. It is my pleasure to invite Dr. Chinman Pan from Hong Kong. Over to you, Doctor.
So it's 2:30 in Hong Kong. I'm trying to stay up, and it's my pleasure to be invited to share on the topic, the future of myopia control and emerging therapies and some transitional research. So first of all, I have no any financial disclosures, and on behalf of the Asia Pacific representative of WCO, just happy World Optometry Day. And then some backgrounds for myopia control. Very good tonight. Tons of lots of presentations from all over the world. And then we're seeing that the myopia control research actually evolved from very early unscientific methods to a very evidence-based approach. So when I was a kid, my mom keeps telling me to look more green things. Old elderly customs. Nowadays, we know that seeing far outdoor activities will be very important for delaying or controlling or slowing the myopia progressions. So throughout this presentation, I try to outline some sort of ongoing approach and future direction in the field. And then, as we all know, that the eye growth and metropolarization is a visual guide process, and is guided by visual experience with active and visual dependent control mechanism. So that's why we have many different active control methods involving optical interventions and pharmaceutical interventions or light therapy, or some dietary or nutritional approach. And at the end, I will share some little others approach. All the things we try, the ultimate purpose is to slow down the myopia progressions. So optical interventions, the defocus theory, we know that it's been there for more than 20 years, 30 years. And then orthokeratology, actually is try to use the defocus theory to explain how the orthokeratology can slow down the myopia progressions. And then in the year 2020, we have the optical lens coming out, and then as well as a soft lens. And then later on, we have some other approach using retinal contrast. So based on the theory that the eyes can respond to the positive and defocus. So for orthokeratology, many studies have shown that the slowing down the progression rates will vary. Usually, I will tell the patient around 50%. Some based on the previous study will vary from 30 to 60%. And then usually the OK lens have a focus on some long-term change of 1 or 2 years. So here is some data I show here from the studies. Well, comparing to regular spectacles, they are effective in slowing down the axial elongations. And then usually the BOZ, the optical zone diameter, it will be around 6 millimeter for traditional OK lens. Well, but in recent years, there are some studies trying to investigate to reduce the velocity of the OK lens. So, given that some studies show that the peripheral region or mid or somewhere around the macular region around 6 to 10 degrees centricity will be more sensitive to defocus and for detect of the positive or negative defocus, and that's why we lead to, in particular in mainland China, try to see how it goes from reducing the VOZD of orthokeratology. By reducing the VOZD, you see that from this schematic diagram that the defocus can be more close to the central region. And then here's the study I try to pull out. Okay, we see that from 2020 onwards up to now, still there will more studies to try that there will be increasing OK lens treatment soon, but with reducing VOZD. So most of the results are quite good, more effectively in controlling the eye growth of controlling the axial length growth. But bear in mind that if changing to a smaller treatment zone, that maybe have high aberrations. The kids may report to you have slightly blurry visions. And then the thing is that if you take a closer look, if you take a history of the OK lens, it has been here for maybe in near 20 years. Only from 2020 onwards, that will be more research by reducing the VOZD. I suspect maybe because by that time the defocus spectacle lens start coming out of the market. And then the OK lens efficacy try to be increased or further increased, so to maintain the competitiveness to wearing the spectacle lens. So here you go, the defocus spectacle lens. So again, this is for study, regular study. So will slow the myopia progression for approximately about 15 to 70%. Depends on which papers you are citing, and again we use the defocus concept to explain how the spectacle works. And then in China, actually, the defocus pattern or defocus lens have a very rapid growth, and then many industry try to make their own pattern. And with just pull out some of these to show you here. So for adding on, is the defocus lens come out from the market in around 2018. Something is already 8 years on, and then the industry or institute try to further increase the efficacy, myopia control efficacy. So that would be several directions for get more defocus signal, or either get closer to the myopia control sensor, which I showed that told you before, the paracentral of the retina, or get more coverage of defocus signal. So this is usually the approach of the newly myopia control lens. If you take a closer look or stay tuned to the news, there will be some new lens release. And then interestingly, in China, there will recently there is quite a big hit on another type of spectacles, which called the diffusion optics technology lens. Is actually the research will be originated from the US, and by the lens outline will be like this. The lens will have a tiny box, which will reduce the retina contrast, or reduce the image contrast reaching the retina, and interestingly, show some effect of slowing down the myopia progressions. And then the concept behind, or the hypothesis behind, will be about degrading the retinal signal quality, which mimic the visual experience of the outdoor or the lateral lights, while the high contrast image from the environment of myopic stimulus will be promoting the eye growth. So degrading the image to a certain contrast level may be a potential the hypothesis for slowing down the myopia. So very different school of thoughts from we learned about the defocus theory in animal studies or in human study, and then all along the OK lens and the defocus perspective. So how about then with defocus and diffusing dot act together? And actually, in China, they are doing it now. And of course, there's not much study coming out, but the industry, they are trying to develop a lens with a defocus, and there is some diffuse dot in between. And then, well, the people may think that 1 + 1 will be equals 2, right? So one is effective, another is effective. The add together will be very effective, right? The thing is that need to have more study or more research to see if it really works by combining two things together. And one important note to remark here is that even defocus actually already the physically reduce the image contrast, particularly the high spatial frequency. So here's what going on. And then atropine for medication to treat the progression of myopia. I'm not spending much time in here because many other experts already talk about it already. Typically about 0.1 to 0.05% low dosage. Some studies still say it's working quite well. And then of course for using the medication, the safety and efficacy atropine we need to be paying more attentions. And then now in Hong Kong like that, we tend to, because the myopia prevalence is quite high, very high, and then the parents are usually very concerned, and then the parents tends like to have a combination myopia control. For example, wearing a defocus spectacle with atropine, and some even use atropine with orthokeratology. Again, there will be some study coming out, and then to see. And I know that in the University Institute, they are doing some low level red light in combination with atropine. Hopefully, in the future, there will be more results will be coming out to show the efficacy. And then lighting and myopia, we all know that for outdoor activities, that we can slow the myopia progressions. And then of course, but thing is that in urban areas or urban city or inner city, the kids are really difficult to get them into outdoor. So and then for indoor activity, that will be the light will not be so high enough for the myopic control, and that's why in Hong Kong we try to have the Polytechnic University try to develop a bright light therapy research to see if this device can actively slow the myopia. And I'm expecting the data coming out very soon, because this is a 2-year double mask study. And then, of course, the red light, low dosage, repeated red light therapy. Again, I'm not getting into detail here because Professor He has already talked about it. And the therapy, the machine is used laser lights. So and then of course some experts or some parents or whatever may have some concern about the laser lights, right? But in recently, so very new one is that maybe there no laser lights needed. Okay, the other device trying to show that LED lights with LED light, red light, can possibly have similar therapeutic effects as the laser light of the RLR therapy. So hopefully that we have more results on that and more study on that. And then another things I usually encounter in my clinical practice will be asked by parents, any food or any nutritional dietary approach that can slow the myopia, right? And they hate the glasses. They think that the glasses is also actually doing some harm to the kids. Well, but although I keep saying that actually the glasses do no harm, actually, on the other hand, it will be, if you are prescribing the focus lens, help to slow the myopia. Of course, doing some research, literature search, the ongoing some study about using the barberry extract and DHA in guinea pigs as well, working guinea pigs. Also, for some studies, Africans and omega-3 can try to is associated with reduced risk of myopia. So another approach in the future will be on dietary. And then, I don't know in other region, other country, have you, if you guys see this before? In China, it's become a fraction now. This is a reading and writing desk platform. The concept is to try to project the homework or the near work third site doubling distance, try to reduce the working distance to slow down the myopia. Of course, the products are there, and we have in China there are different versions, but the evidence we still need to further look at it. By far, there's not a particular paper doing it. Maybe there's some institutes are doing it already, but let's see. And then here's the summary. As I said, there's a many different approach to slow the myopia progressions. And then AI and myopia prediction. Actually, if you search AI and myopia as a keywords, many upcoming new technology utilizing AI for myopia predictions. Thank you and happy World Optometry Day again.
Thank you, Dr. Chinman Pan, for that insightful and forward-looking presentation on emerging therapies and translational research in myopia control. Now, we move to our next talk, Myopia Navigator, a game changer in myopia management. It is my pleasure to invite Mariam Jabbar from Pakistan. Over to you.
Assalamualaikum and hello everyone. Here's me, Mariam Jabbar, currently working as lecturer of Optometry Department, University of Islamabad, and recently joined as Media Secretary, Pakistan Optometrist Society. It's a great opportunity for me to be a part of this global platform and contribute to the discussion on one of the most important challenges in eye care, myopia management. Let me share my screen. Yes. Around it's about to show. Yes, Bismillahirrahmanirrahim. Topic of my presentation is Myopia Navigator, a game changer in myopia management. This is basically a guideline for eye care practitioners for related to the myopia management. Let's start. Why myopia is like a time bomb in today's era, because of its growing concern. According to World Health Organization on report on million, myopia is becoming a global health concern, and research showed that half of the population will be myopic by 2050, and it's an alarming condition. Here's a graphical representation that show about half of the world population will be myopic by 2050 due to increasing in prevalence of myopia. Myopia Navigator is basically a free online resource that provides a range of content, practical actions across 3 M's of the myopia management. And when we proceed with the 3 M's, it's basically mitigation, measurement, and the management. Let's start from the mitigation. Mitigation is basically the evidence-based mitigation as a standard of care. What we expect from the optometrist, how they have to educate and guide parents and the children about the risk of developing myopia. When we're talking about the mitigation, it's basically proceeding with the preventable strategies. Preventable strategies for the proceeding with the 2 further principles, primary and the secondary. Primary is all about when the disease is not occurred actually, but there is a chances of happening or onset of the disease due to presence of the risk factors. And the secondary level is proceeding with disease happened, onset of the disease is proceeding, but we have to prevent the complications. So in this pillar, we proceed with the preventable strategies, and we target the toddlers and the preschool initials because they are at risk for the developing of myopia. And in mitigation pillar, we cover the conversation on family history or the child history. Major factor is about the lifestyle factors, with the goal to prevent and delay the onset of myopia. This is basically the category of primary level of preventable strategies where there is not disease onset, and that's basically proceeding with the primary level. So in mitigation, what we do, we proceeding with the lifestyle advices, we proceed with the guiding about the children who are at risk, and what will happen if we do not control or manage the myopia, what will be the consequences of myopia. Let's start from the lifestyle advices. First of all, when we're proceeding with the lifestyle related advices, it's basically about the modifiable risk factors. There's 2 sort of risk factors, modifiable and non-modifiable. Modifiable are those we can modify and prevent or delay the onset of myopia. That's basically starting from the maximized time outdoor. Researchers show that more time spent outside during the day, the better will be the effect. Furthermore, the second component is about the limit near work. Aside from the schoolwork, most make families aware about research show that there's a strong relation between screen time and near work with the onset of myopia, and it's basically alarming due to the digitalization of this current era. Furthermore, we should have to limit the screen time. Maximum of 2 hours of screen time every day is recommended. More than this, but if we exceed from this, there is a double or triple the risk of myopia. Furthermore, the most integral part is about the regular eye examination. We should encourage preschool and the school-age children to come in for the eye exam. When they proceed with the initial eye exam, then we recommend or guide about to maintain the follow-up to proceeding with the minute checkup on the myopia. Furthermore, who are at risk? The children are at risk are those who are at a younger age, because earlier the myopia emerges, the greater risk of progression with the passage of with the increasing of their age to a higher prescription. Furthermore, those children who have the significant screen time or the near work, these studies show that there is a connection between excessive amount of time spent on near work and digital devices appears to the greater risk factor for developing of myopia. Furthermore, parental history, that's basically the non-modifiable risk factors, but it's just like a gun that trigger the factor. And presence of myopia in one parent increase the risk of myopia in children. And if both parents are myopic, it double or triple the risk of myopia. Other vision disorders are also correlated with the onset of myopia, such as reduced accommodative response or increased accommodative lack, or a high AC over A ratio are frequently found in the patient who have myopia. These are few other vision disorders that related with myopia disorder. We should have to limit the time outside. We should have to follow or supervise those who have little outdoor time. Children who spend little outdoor activities, little outdoor exposure, they are appear with greater risk of developing myopia. Furthermore, significant screen time. Those children who spend more time on digital devices or for the near work, they are appear to the risk factors for developing of myopia. Furthermore, if we are not look after myopia risk factors, developing of myopia and risk factors of myopia, then what will happen at the end is the consequences of myopia. Several studies show that the link between myopia and serious eye health conditions later in life, as there is a tabular formation that show about degree of myopia, mild, moderate, severe, and then proceeding with the cataract, glaucoma, retinal detachment, and myopic maculopathy. These are those that are irreversible vision changes. So if we just look at the degree of myopia and myopic maculopathy, with the mild degree of myopia, there is a risk of 3x for developing of myopic maculopathy. But if we proceed with the greater risk of myopia, about -6 diopters, it will proceed with the 41x of the myopic maculopathy, and this is a alarming condition. As the degree of myopia increase, the risk of developing serious health concerns is also increased. That's the basically thing that we want to prevent with the preventable strategies later on complications and associated serious eye health concerns. That's all about mitigation. Furthermore, this second pillar is about the measurement. When we're proceeding with the measurement, being an eye care practitioner, being a myopia care provider, being primary eye care provider, what we have to measure, measurement by time, measurement by modality, and our effective error. Let's start from what to measure. When our patient visits us, we did proceed with detailed patient history. When patient visits us, we should ensure to capture the family history of refractive error, as this is a risk factor of developing myopia and non-modifiable risk factor of developing myopia and other risk factors, other refractive errors. And we should also encounter the time spent on near work using the digital devices, how much they spend time for the outdoor activities, and date of myopia onset if already present, or if any previous treatment of myopia has been already taken. So these are the few points that we should consider in patient history. And furthermore, what we proceed in daily OPD, when our patient visits us, we proceed with the standard assessment that's starting from the visual acuity, distance visual acuity, and the near visual acuity. Then we proceed with the internal and external ocular adenesas, and then we proceed with the refraction and accommodative and binocular vision testing. These are the standard protocol that we proceed in our daily lab activity. But when we proceed with myopia, there is additional checklist for the best practice related to myopia. Axial length measurement, clear film evaluation, and the cycloplegic refraction. These are the three main key factors for checklist for the myopia. Furthermore, measurement by time, as we initially discussed, as myopia is progressive in nature or progressive sort of, so we have to consider with the maintenance of the follow-up. Whenever patient visits us, at each visit, we have to proceed with the check the case history, investigate the compliances and the feedback related to already given treatment, and corrected for real equity and the over refraction. These are the 4 key things we check at each follow-up. And when patient proceed with the 1-year follow-up, we have to proceed with the complete diagram. When patient visits us about 6-month follow-up, we have to proceed with the cycloplegic refraction and the axial length. These are the major factors to proceed with the 6-month, as there is the chance of the fluctuation within the 6 month with the progression of myopia. Furthermore, the third pillar is about the management. When we proceed with the mitigation, measurement, and then we have to manage. When we proceed with the management, is the optical option, that's about the spectacle lenses. And when we proceed with the myopia control strategies, we have to proceed with the soft dual focus or the multifocal contact lenses. And orthokeratology, when the proceeding for the management of myopia, patient have to wear the lenses over the night, and there is no need of glasses or the contact lenses throughout the day. Furthermore, one non-optical option is there as well, that is basically atropine. Apart from all these 4, regular therapy is also used for myopia control strategies. These are the management strategies. Furthermore, these 3 pillars, mitigation, measurement, and management, is basically interactive educational guide for the myopia management, is provided by World Council of Optometry, myopia management ambassadors. A big thanks to all 4 ambassadors for proceeding and put up these guideline that's work as a myopia management. For the myopia management is a game changer, as this is a put up combined effort of Coppervision and the World Council of Optometry. Furthermore, there is the spotlight, a best memory from the 3rd International Myopia Conference 2025 that was conducted by University of Islamabad in February 2025. And Professor James, all the way from Eastern University, UK, visit us at our campus, University of Islamabad, and we just take a photo with the holding 3 M's, mitigation, measurement, and the management. In the picture spotlight, we proceed with Professor James, me, and of course, my head of department, Professor Amir Ali Chaudhry, and this is the best memory that we call me every time about the down the lane of 3rd International Myopia Conference. Furthermore, is the reference if you want to explore more, or you want to update it more about the Myopia Navigator, you can visit this website. And thank you so much, Jazakallah khair, for all your concern and listening this. That's all from my side.
Thank you, Mariam Jabbar, for that excellent and insightful presentation on the Myopia Navigator and its potential impact on myopia management. Now, we move to our next talk, Cyan Light, a potential strategy for slowing myopia progression in children. It is my pleasure to invite Dr. Ranjay Chakraborty from Australia. Over to you, Doctor.
Hi, everyone. Good morning and good evening in Dubai. Thank you for the invitation for Myopia Conclave, and I hope you can hear me okay. I'm going to talk about Cyan Light with some of the work that we have been doing in the lab, trying to understand this as a potential strategy for slowing myopia progression. So the data that I'm presenting today has received, just trying to. The data I'm presenting today has received funding from Essilor Luxottica, and I've got some other funding that are unrelated to the work I'm presenting today. So we understand from a large body of work in animal models that the chromatic cues associated with the longitudinal chromatic aberration may play an important role in regulation of ocular growth. And in this image, what we are seeing is the retina, and this is a broadband white light, and I'm trying to illustrate the longitudinal chromatic aberration. And essentially, the emmetropization mechanisms compare. I'm sorry, I'm just trying to hide my. Can you still see me okay? Sorry about that. I was just trying to hide the bar on the left. So essentially, in this image, we are seeing a broadband white light and the process of longitudinal chromatic aberration. So essentially, the emmetropization mechanism compares the image contrast produced by the short wavelength cones and the long wavelength cones. And they are trying to balance the contrast. And in that process, the eyes make compensatory changes in order to get the eye to the emmetropic state. But we also know from, again, a large body of work in animal models that monochromatic light on narrowband wavelengths, in which the longitudinal chromatic aberration signals are absolutely absent, also influences ocular growth and refraction in animals. For example, exposure to long wavelength red light induces myopia in chicks and guinea pigs, while it slows myopia and makes eye even more hyperopic in tree shoes and rhesus monkeys. In fact, the blue light induces axial myopia and disrupts emmetropization in tree shoes. And what these mechanisms shows is that it's probably not the LCA alone, but the retina also perhaps processes a wavelength specific defocus. And in this case, it probably shows that it is the spectrum of light that is extremely important in order to regulate the eye towards emmetropia or managing the refractive errors. There's also a couple of human studies, very recent human studies, that are also looking at short-term effects in choroidal thickness and axial length in response to long and short wavelength light, which I'm not going to go in detail today. Our interest today is cyan light, which has a peak of around 490 to 520 nanometer. So this is the sweet blue-green region of the visible spectrum. Cyan light generally creates a more balanced light spectrum, where you can see in this image that the energy is spread across on a wider region across the visible spectrum, compared to the blue light that has a very steep peak. Some studies have shown that cyan light reduces digital eye strain, and it provides a more naturalistic, comfortable viewing experience because of the spread of the energy across the visible spectrum. But how is cyan light related to myopia? So some very recent studies have shown that cyan light in fact inhibits axial myopia in zebrafish, but it disrupts emmetropization in tree shoes. In fact, a human study has shown that a 30-minute exposure to cyan light every morning, just 30 minutes, causes a significant thickening of the choroid after 1 week. And this is the paper from Reed et al., in which you can see that repeated exposure to cyan light causing a choroidal thickening, which is much more visible towards the end of the day. So in this study, we wanted to examine if the exposure to cyan light causes short-term changes in axial length and choroid. And this is the study that we published a few years ago. So the study had, I'm sorry, this is 2024. So it's a very recent study that we published from the lab. And it has two parts. So we did the study in young adults and children. This is the demographics of the both refractive groups. And you can see that in both young adults and children, myopes are generally low to modest myopes, but they are all age matched for both young adults as well as for children. So in this study, the participants are in fact exposed to narrow band wavelengths of either blue light, cyan light, red light, or a broadband white light, which is our control condition, using light emitting glasses. The blue light couldn't be tested in children because of safety reasons. And then we measured the changes in ocular biometry and choroidal thickness using Leinster and spectral domain OCT. So this is for exposing the eye to different wavelengths. We use light emitting glasses, which we validated a couple of years ago in the lab. And this is basically a custom designed light emitting glasses, which is made up of a 3D printed material. And then in order to modulate the light characteristics using this, we use a custom Android based mobile app. So just very briefly, what happens in these experiments is participants come to the lab. We give them a 10-minute of washout period in order to wash out any previous effects of visual activities. After the 10-minute washout period, they sit in the lab, they watch a black and white television in the lab, and then essentially they are randomized into these 4 light conditions in randomized order across 4 different days. So this experiment is not done in one day. So this is quite tedious on participants. They are expected to visit the lab on 4 different days. And then when they are watching the TV with these light sources, we take the measurements at the baseline, 60 and 120 minutes after the light exposure. And after 120 minutes or 2 hours, we switch off the light. And then we also take another final measurement 20 to 30 minutes after that, which is the recovery period in these participants. And we want to see if any of the changes have recovered. This is quite a busy slide, so I'm just going to break it for you. And in this, so this is my first slide of the results. And on the x-axis, you can see the time periods in which the measurements are taken. On the y-axis, we can see the changes in axial length. And the black line here is our white light, or the broadband white light, which is our control condition. And you can see that compared to the broadband light, exposure to the long wavelength light causes a significant elongation of the eye, which is visible at after 2 hours of exposure. These are all short-term changes, so this is not changing the eye by a huge magnitude. It's only changing it by a couple of microns, but it's still important that the eyes are able to modulate its shape or length depending on exposure to these wavelengths. So compared to white, you can see then elongation, but then most importantly, I want to get your attention to the fact that with the cyan light, you can see a decrease in the axial length or reduction in the axial length visible as early as 60 minutes of light exposure. And these effects are sustained not only up to 2 hours, but also even after the lights are turned off. So this is quite a strong and significant effect. We also saw a small reduction in axial length with blue light, which was only visible after 60 minutes. These are on the right side, you have changes in emmetropes and myopes, and I'm only going to focus on the cyan light, which is our interest today. And you can see that the cyan light changes are almost negligible in emmetropes, but all the big effects that we see with the cyan light is actually happening in myopic adults, which is important. The graph here is showing the changes in choroidal thickness, and you can see that consistent with the reduction in axial length, there's a thickening of the choroid, which is visible as early as 60 minutes here, again, which is consistent here. And the changes in the choroid are generally similar between the 2 refractive groups. This data is showing here the changes that are happening in children. And you can see that with the cyan light, there was a significant reduction in axial length, even in children eyes. But surprisingly, these changes that we see, the reduction, is only visible in emmetropic children and not in myopic children. The similar thing we see with choroidal thickness as well, consistent with the reduction in axial length. You can see a thickening in the choroid in children, which is important. But again, these changes are only confined to the emmetropic eyes, not the myopic eyes. This busy looking graph here, we are just trying to compare if the changes vary between the young adults or children, between the 2 age groups. And I don't want to go into the details, but you can see that there is indeed an effect of cyan light. It's doing its work, but these changes are similar or same between adults and children. Or in other words, the effects of cyan light are independent of age. So it happens in both age groups in a similar way. So there's another experiment that was recently conducted. This is done by my PhD student, Aswira Hussain. We recently published this paper just a couple of months ago. And here we are asking the question if the cyan light can inhibit or counter the effects of hyperopic defocus in human eye. So essentially, if you put hyperopic defocus in human subjects, it causes a short-term thinning of the choroid and an increase in axial length. So the question we are asking, if we expose the eye to cyan light, can we counteract that effect? And so for this experiment, the participants are wearing a 3-diopter hyperopic defocus contact lens in the right eye. And on top of that, they are getting 2 different light conditions, either the broadband light, which is our control, or the cyan light, which is our experimental light condition. And so the idea is that if you give the cyan light, is it able to prevent that thinning and short-term elongation that we see with hyperopic defocus? The biometric changes and choroidal thickness measurements are same as I explained before and at the same time points. So this graph here is showing the changes in the defocused eye and the non-defocused eye in axial length. And what we see is that in both defocused and non-defocused eye, there is a small elongation in axial length with white light, but this elongation was significantly prevented with the exposure to cyan light. So there was a good preventive effect. Although this preventive effect was only seen in the defocused eye, not in the non-defocused eye. The graph on the right side is showing the changes in subfoveal choroid. And in here, we can see that in both defocused and non-defocused eye, the cyan light was able to produce a thickening of the choroid, which was visible after 2 hours compared to the white light or the broadband light. So basically, these slides, both axial length and choroidal thickness, they're trying to summarize that independent of whether the eye is under defocus or non-defocus, the cyan light is able to exert a protective effect and is able to induce a thickening in the choroid and a reduction in axial length. This busy-looking slide is again trying to compare the effects between myopes and emmetropes, and we can see that the cyan light is again working, causing an increase in the thickness and a reduction in axial length, but these effects are same between the two refractive groups. So to conclude, I want to conclude by saying that short-term exposure to cyan light resulted in axial length reduction and thickening of the choroid in both age groups, young adults and children. We believe that these effects are a combined or individual effects of melanopsin or rod pathways, and there are some ongoing trials in the lab that we are carrying out in order to extract that. The effects of cyan light on ocular biometry appears to be stronger in myopic adults, but weaker in myopic children. And we believe that the myopic children may require repeated or greater intensity cyan light exposure in order to exert the effects. We also found that the cyan light can inhibit the effects of hyperopic defocus on axial length and choroid in human subjects. And of course, these are all preliminary short-term results. So we definitely need much more research to understand and to determine if these results can be used to develop light-based interventions for myopia control. So with that, I would like to thank my collaborators from Essilor. They are all on the right side. Aswira, my PhD student, all my lab members and research assistants and undergraduate students. Thank you so much for your time. Appreciate it.
Thank you, Dr. Ranjay Chakraborty, for that insightful presentation on cyan light as a potential strategy for slowing myopia progression in children. We now move to the panel discussion. I would like to invite Dr. Thanuja Panikar from Botswana to lead the discussion. I request all speakers of this session to kindly join the panel. Over to you, Doctor.
Yeah, good evening all from Botswana. It's evening out here. I'm simply fascinated by the long-sighted approach towards short-sightedness, Myopia Conclave of UFO. It's wonderful to see optoms are expanding access to eye care, which is a fundamental human right. Happy World Optometry Day. Of course, myopia is no longer a benign refractive condition. It's a serious public health priority. Future of myopia care is shifting from passive kind of treatments and corrections to active, personalized, combined therapies aimed at reducing the axial length. Of course, there is a need for early detection, widespread education, accessible to these kind of services, proper preventable strategies and management to address the expanding burden. Dr. Mariam, Walaikum Assalam. You presented on the game changer. Definitely, it's a ground-breaking educational source that will change eye care practitioners' approach towards myopia and also protect the vision of future generations. You mentioned MMM, mitigation, measurement, management. Where did we miss the fourth M, money? The factor which is very important to pay for these services, that also has to be taken into consideration. Of course, Professor Ekose rushed us through the quality testing presentation, but to just for the audience to understand, it's all about having a tailored questionnaire which is easy, which gives less burden to the people who are the recipients of the questionnaire, and it's a useful tool to measure physical health, social, mental well-being, and also about the surrounding factors associated with it. Let me ask Dr. Ranjay a question related to cyan light therapy. Of course, you did mention a lot of research has to be made in these lines, but I want to understand how will you compare of course, you might be foreseeing this question. How will you compare the red light therapy, which also gives 65% result, and not many established side effects have been reported probably, or maybe they are still working on it, like your studies. How would you compare the low-level red light therapy with this? And then I'll ask other questions once you have answered. Doctor?
Sure. Yeah, I just want to highlight that it's very difficult to make direct comparison between the light therapies for a variety of reasons. Well, most importantly is the fact the data that I presented today is all experimental work. So these are all short-term changes that we are observing in 1 to 2 hours of light exposure. And at this stage, we definitely no claims are being made about their efficacy as a clinical intervention for myopia control, because these are all experimental studies at this stage. So it's very difficult to compare what effects you might see, because all the data that we have, at least in the context of RL, we already have the clinical data of the myopia efficacy. And you're right, it's supposedly one of the most potent therapies that are available, and a lot of work is undergoing in order to understand the side effects and their efficacy further. So, but hopefully at this stage, it's it's, as I said, very difficult to predict. But also the other thing is RLR's therapies are only given for 3 minutes twice a day kind of therapy because of the different kind of light source that's been used. The one that I presented today are all LED-based light sources, so you can see that they probably take a little bit more longer time in order to exert the same effect. So yeah, because one is an experimental work and the other one is a clinical work, it's very difficult to make that direct comparison at this stage.
Okay. Now, Dr. Chin, I have a question for you, but before we get into the question, you mentioned about sunning, and it goes back to the naturopathy. Sunning is a naturopathy as long as you don't directly look at it. And I like the way the dietary approaches you included in your history. And also it was interesting to note about the writing, the way the writing platform was set up for the children. I hope he's around and I could ask this question. Could you explain about the rebound effects of certain therapies, say whether it is orthokeratology or atropine therapy? Would you want to just summarize about the rebound, whether these therapies can cause recurrence if withdrawn? Dr. Chin?
He's not here actually. He left.
Let me move on to Dr. Lalu. He mentioned about it was a very good presentation. It's just that it was not loud enough. We wish it could have been more louder. But yes, you had mentioned that the key advancement is AI-driven and predicted by AI. And the biomarkers being the choroidal vascularity index and choroidal contours. It would be interesting to understand, does it work across different ethnicity groups as well as the different modalities? Does it help even to understand whether there is some effect on using atropine therapy or orthokeratology, using these biomarkers, not only for the progression of myopia, but once the management is in place, would it have some effect on these indicators? I hope he mentioned, I think he was the one who mentioned it was too early in the morning, or it was Dr. Chin. Probably they both have gone to sleep. Is there any question from the audience? Any questions from the audience? So we could summarize that there's no single solution is applicable to all. We have multiple interventions, be it optical, pharmacological, behavioral, and emerging options like Dr. Ranjay has mentioned, like that therapies with established findings and with studies which is continued. As the landscape of myopia management expands, it's very important to understand the safety, efficacy, practicality, availability, the cost factor, and also we need to identify the barriers like compliance, whether the parents and the children are able to cope up. Of course, future success depends on early management, public health engagement, multidisciplinary approach, and collaboration. Of course, a proactive, personalized approach is the key to the global burden of myopia. Each case is different. And then we would continue to pray to bring miraculous transformation for global peace. Happy World Optometry again. Thank you. I believe we have ended this session.
Yeah. Thank you, Dr. Tanuja, and to all our speakers and to our attendees for staying so late. And here you go for the quiz, the much awaited one. Please scan the QR code, 20 questions to be answered in 20 minutes. The QR code will be scanned, shared shortly. Thank you all for making this World Optometry Day a great success. Happy World Optometry Day again. On behalf of the organizing team, I would like to extend our heartfelt gratitude to all those who made the Myopia Conclave event a great success. We sincerely thank our platinum sponsors, Zeiss Middle East and Africa and Essilor Luxottica for their generous support and continued commitment. Our appreciation also goes to our gold sponsors, Ion Care, Vision and Equipment Solution, silver sponsor, Amico, and bronze sponsor, Unoya, for their valuable contributions. We are grateful to our media partner, Abira Media, for the support in amplifying this event. Our sincere gratitude goes to our distinguished speakers for sharing their valuable insights and expertise. Thank you for accepting our invitation and for being here with us today. To all our attendees and participants, it is your engagement and enthusiasm that truly make these sessions meaningful and impactful. Thank you for your unwavering attention and active participation throughout. A special thanks to Peppo Event Management for the excellent coordination and seamless execution of this event. A big round of applause to the organizing team and scientific committee members of United Optometrist Forum for their incredible dedication, valuable input, and tireless efforts in working around the clock to make this event a grand success. We are excited to announce our next on-site event, October 7, scheduled for October 2026 in celebration of World Sight Day, and we look forward to seeing you all there. For CME certificates, kindly visit the Optoverse website and complete the feedback form. Certificates will be processed within approximately 10 working days. Thank you all once again, and we look forward to meet you all in October 7. Thank you again. Good night. Thanks.